इस साइड की पट्टी काट दो पीपीटी की, साइड की पट्टी काट दो पीपीटी की। ठीक है, ठीक है, रेडी। So finally, another big exam called the INI-CET November 2024 is over. 3 hours of tension, months and months of preparation, and you guys have finally appeared and taken this 200 questions exam. And like me, all of you are mostly sitting with this orange band in anticipation that what should be the right answer, what should be the correct option for this answer, for that question. So very quickly, without wasting any time, I am here for the exam analysis. I'm Dr. Himani Joshi, the academic director at DBMCI MDS. I'm also the original guru for oral and maxillofacial surgery. So let's quickly do the exam analysis for INI-CET MDS November 2024. Okay, first we will see individually subject-wise what were the questions like and what was the difficulty level. So if I talk about first subject, that was anatomy. There were 5 questions on embryology. Right from an image-based question of the notochord to an image-based question of, the questions on embryology, like the lung embryology or the cardiac embryology, second pharyngeal arch, derivatives, lot of questions on embryology. Equally, 5 questions were there from head and neck. Easy questions from head and neck. Embryology questions were difficult. I will consider them tough because, the lung bud was asked and the superior most portion of the notochord gives rise to which of the cardiac structures. Usually we read more of the head and neck anatomy or head and neck embryology, but a lot of questions on embryology were tough. Head and neck questions were mostly straightforward, all right? Which nerve supplies the carotid body? The bifurcation of the external and internal carotid artery was shown as an image-based question, and the nerve supplying it was asked. Or there were questions on muscles of mastication. 2 questions on muscles of mastication. The lateral pterygoid was shown and the action was asked. Another multiple correct answer question on muscles of mastication. So head and neck questions were broadly, and the pterygomaxillary fissure was shown and which artery terminates in this region. Broadly, these were not very difficult questions. One question was asked from upper limb. Deep ulnar nerve supplies which muscle of the arm, the adductor pollicis or abductor pollicis brevis, or contractor, or what muscle of the upper limb is supplied by the deep ulnar nerve. Now this is something we don't read routinely. All right, this is something, an odd question, which is called difficult. I will call it difficult because this is not routinely what we study. This was easy. And 1 or 2 questions from joints, from osteology. 2 questions from osteology. One was axis vertebra. The C2 was asked, and the types of joints that it forms, all except, so pivot joint and plane joint and symphysial joint, all the types of joints that the axis bone forms, that was asked. And periosteum, properties of periosteum, it's outermost layer, innermost layer, and it has osteoblast and resorption happens. So osteology questions were also relatively easy. If you have done the basic osteology, the questions were easy to moderate. Okay, if you call axis identification of osteus, although the odontod process, you could identify the axis very easily, but still you can call it easy to moderate. So embryology questions in anatomy were tough. Okay, other than that, anatomy was easy to moderate. Coming to physiobiochem. Now, certain questions in physiobiochem were easy, like, the capacitance vessel. Which of these is the capacitance vessel? Or, the 2,3 DPG formation. So some direct questions or cyanocobalamin, like macrocytic anemia is caused by which vitamin deficiency. So cyanocobalamin. Easy questions from physiobiochem. And of course, certain questions were very, very difficult. Okay, the which organ has the highest arterial and arterioventricular difference in the oxygen levels? So such questions needed thinking, and lungs was not an option. So heart, brain, kidneys, and all those liver were the options. So physiobiochem also, if you have done some basic study, they were moderate. They were not very tough. They were moderate questions. You could find some repeat questions. You could find some easy questions. I could remember some questions that I had read, 15, 17 years back when I was preparing. So there were certainly some questions which were direct, which were straightforward. Yes, there were some questions which were difficult. So I will call physiobiochem as moderate. Okay, next we come to DADH. Surprisingly, there was only one question from dental anatomy, which you could also say was in pedo, that eruption question which was there. So only one question. Sometimes, AIMS gives a lot of DADH questions, but this time, just one DADH question. Okay. Next, it was the turn of dental materials. Dr. Aishwarya is going to discuss in recall all the questions of dental materials, and according to him, the paper was difficult. The questions in dental materials were really, really difficult. Okay. Usually, clinical questions are considered to be difficult. Clinical questions have a lot of twist, have a lot of integration between subjects. And these questions, the basic papers like physio, biochem, DM, they are considered to be factual, not considered to be difficult. But this time, dental materials questions were really difficult. All right. Next, we come to patho and micro. Again, lot of histology questions from patho. Okay, lot of staining questions. The blue-green colored stain was asked, and in that stain, you were expected to arrive to a diagnosis, and lot of mucormycosis, lot of aspergillosis, and what is the what kind of hyphae are seen, and tuberculosis was asked. So patho micro, broadly, the topics were repeated. They were repeat topics. Definitely there were repeat topics, but the exact question repeat was not seen. All questions, almost all questions were new questions. Topics were repeated, but questions were new. So that made patho micro also moderate to difficult. Okay. Next was pharmacology. Pharma was moderate, not easy, not difficult. Questions on tuberculosis, which drug causes color vision problems and vision related problems. So direct question from side effects of ATT. One new drug of tuberculosis was asked, and simple common sense questions. Those who were afraid by seeing this question where this diagram was given and the drug dosage was given. So in blood the dose was high. Then slowly, it picked up in the skeletal muscle, slowly, picked up in the adipose tissue and skeletal muscle. And this was the question, and this was the excretion. This is how it got excreted. And very simple. The question seemed tough. Okay, this was the time concentration chart of a drug. And it was asked, what is the route of administration? And you can see that the highest level is in the blood initially. So you can come to a conclusion that yes, it's a venous, it's an IV route. It cannot be oral, it cannot be subcutaneous. It should be a IV route. So some questions based on logic, some questions based on calculated risks were also there. So pharma by definite means was not tough. Okay, ibuprofen was asked, like which of these drugs reduces the periodontitis chances, reduces alveolar resorption. Questions were there on metronidazole. Questions were there on, in kidney disease patient, like which quinolone is easily used or does not need any drug modification in renally impaired patients. So these are questions which we have read, which we have heard, which are common. Okay, antimicrobials, metronidazole, drug time concentration graphs. These were moderate questions. I mean, not very easy, but not very tough also. So pharma was moderate. Next, we come to oral path. Oral path, like always, and PhD. These two questions were the BAP of all. New questions, okay, questions like, cuniculata, carcinoma cuniculatum, and new pathologies like, samametide ossifying fibroma, juvenile ossifying fibroma. Although a lot of that has been asked in theoretical questions, but image-based questions in oral path were new. Okay, if you know the concepts, you will be able to mark. If you don't know the concepts, if you've only mugged up the answers, not read the explanations during your PYQ revision, it would be difficult. Similarly, PhD, bar of a lot of PhD questions from numerical based to, mean, mode, variation, variance, and policies, all kinds of questions in PhD as expected. INI-CET will always give a lot of importance to public health dentistry. Lot of questions have always been asked in PhD and the trend is repeated. So PhD, lot of questions, some easy, some moderate, some really difficult. So I will consider PhD and oral path with the bar of all very tough to remember also and moderately tough questions. Then we come to medicine. General medicine, only 2 questions were asked. The cardiopulmonary resuscitation, how it is done in pediatric and infants. So only if adult you have remembered and you've not remembered pediatric and infants, you will be feeling sad. But those who have learned both, it is easy. One more question, medicine, which you can consider pharma also about, about giving symptomatic treatment. Like a young child who has fever and diarrhea and mucus in stool, and the prescription, the doctor gives them loperamide, which is a symptomatic drug to stop the stool. Is it the right policy or wrong? Is it right? Is it the right rationale? It's wrong because you're only treating the symptoms, you're not treating the infection. So this kind of one simple question based on loperamide was asked in medicine, and that's it. Only 2 questions in medicine, surprisingly nice. Then general surgery. Only 3 questions in general surgery, which were some easy, some moderate. So one non-resorbable suture was asked, polyester. Then thyroid, one thyroid question was there, which like, whether it's an ectopic thyroid or how will you rule in an ectopic thyroid over a malignant cancer. So that was one thyroid question, and we always expect one thyroid question from general surgery. So all those who have read thyroid, you must be able to answer this. And third question was, I consider it into either oral surgery or general surgery, xanthelasmas. We all know those cholesterol clefts that are formed under the eye are known as xanthelasmas, and it was very easy, whether it was caused by hypertension, hyperglycemia, hyperlipidemia, or hyperthyroid. So it was a straightforward question. 2 questions very, very easy. 1 question moderate. So midline swelling of the tongue, base of the tongue, causing an ectopic thyroid. So that was moderate to difficult, but 2 questions, straightforward general surgery, easy questions. Okay. Then we come to the final year subjects, and finally, our dental subjects, which had a lot of importance. Okay, unlike previous times, sometimes the dental subjects do not have a lot of weightage, but this time, yes, there were a lot of basic subjects also, but dental subjects had a lot of importance. Starting with oral medicine and radiology, it was definitely easy. Okay, most common odontogenic tumor, most common developmental odontogenic cyst, okay, most recurrent pathology, and parakeratonised OKC and all those things and options. So these were relatively easy. 6 questions on radiographs, again very, very easy. Questions like, dentigerous cyst, questions like parallax error, questions like 2D radiography में what are the 2 types of x-rays that you can take for localization of an object, so Slob rule, OPG and occlusal view. So easy questions on radiographs. 5 questions were there on syndromes, and all those who have attended the morning motivation session and where we have discussed syndromes, I think one was not directly discussed, but all 4, including Mobius syndrome and Perry-Robin syndrome, inheritance pattern of, AI and DI and cleidocranial dysostosis, everything was discussed very, very nicely. So syndrome questions were easy. genetic defect in syndromes in OKC, BRAF gene, and all these mutations in syndromes, very nicely discussed. Most of the times we do read syndromes very nicely. So 5 syndrome questions, 5 radiograph questions, not very difficult. Okay, OMR was relatively easy. Coming to oral surgery. Now, oral surgery, again, like I have always said, the topics were repeated. Except one. There is one new topic which I'm going to discuss in my recall is arthroscopy. So TM joint arthroscopy is neither taught in BDS curriculum nor taught in MDS curriculum. It's a super specialty thing. Like those who go in for TM joint arthroscopies, they, kind of read about it in more details, because in India, most of the times we are doing open surgeries. Chinese people are doing a lot of arthroscopic surgeries, but still the question was easy, like how will the disc be seen on TM joint arthroscopy? So this was a new question in oral surgery. Lot of questions on condylar fractures. What kind of fractures will cause ankylosis? Why pediatrics have more ankylosis? And what is the safety triangle of dissection in TMJ ankylosis surgeries? So a lot of joint questions, lot of trauma questions, questions on Ludwig's angina, which were easy. Straightforward questions on Ludwig's angina. No questions on exodontia. I was surprised to see that there were no questions from exodontia. Questions from LA, bupivacaine was asked. Why esters are rarely used was asked. So OS was, I will call it moderate. Too tough. Because of certain new questions, I will cause oral surgery as moderate to tough. All right. Then we come to prostho. Again, prostho was moderate to tough because lot of questions on implants. Right from, the open tray impression showing the impression analog, the implant analog, to the, the tracers in prostho, cast duplication, classification, even the Applegate-Kennedy classification was not straightforward. It was applied question. So prostho was moderate to difficult, for sure. Then we come to endo. According to the most experienced person in endodontics, endocons was definitely tough. Lot of questions in endocons, more in endo, less in conservative. Lot of questions on post and core, again, which is a specialty thing, not routinely done in the BDS curriculum. 2-3 questions in post and core, Schweck pulpotomy, and questions on rare things like, a female has a feline pet and an OPG was given where cervical resorptions were asked. So these were difficult questions. So endocons definitely tough. WHO classification of, KO4.1. Now, those who have attended sir's classes, Dr. Aishwarya's classes would know it. Otherwise, it was also tough. All right. Next, we come to ortho. Ortho was moderate. Not many questions. Frankel was asked, and anchorage-related questions were there. Clinical questions were there, but ortho was still moderate. Pedo, perio were easy. Okay, perio questions were like KRI paste composition and Dean's fluorosis index and periochip, what is the constituent of periochip, and surgical curate was asked, and dentogingival unit was asked. Plaque related questions were there. So perio questions, mostly they were read before, they were seen before. They were not really much very new questions in pedo and perio. So perio was easy. All right. And like I said, the last PhD, it was really, really tough. All right. So this is the subject-wise distribution of, how the questions were asked. Now, like I always say, this exam is a proof of the fact that 60% questions will be easy to moderate. This is the standard, especially in INI-CET. And this is what we saw in this exam. 60% paper were from previous year topics. If not previous year questions, then previous year topics. Questions were new. Lot of new questions. Okay. Lot of new questions. But lot of previous year topics, which if the concepts are strong, you should be able to answer. And 40% questions are moderate to tough. Okay. All those who have given the exam, if you are sad after taking the exam, Please do not be sad because of these 40% questions. 40% questions, see, it's AIMS, all right? And AIMS can't throw, cherries and lemons at you. It will throw stones at some point. It has to have some difficult questions to maintain the level, to maintain the integrity and the difficulty of the examination. So please don't get disheartened by these 40% moderate to tough questions. If you have taken calculated risk and made a few of them wrong, it's okay. If you were not sure and if you have left certain of these questions, it's also okay. All right. What decides your rank, what decides your selection is how well you have done these 60% questions that were easy to moderate. If you have made mistakes in simple questions, in vitamin related questions, in fracture related questions, in simple questions that were from repeat topics, then that is a problem. Otherwise, if you have done your repeat questions correctly, keep your fingers crossed. There is a good chance that, your name might be there in the top 50 who get the JR-ship, the academic JR-ship, which is a PG seat, or the non-academic JR-ship, which is a work experience for 6 months at the institutes of national importance. All right. So, guys, don't worry. Any questions if you have, you can ask me, although the analysis is over. I wish all the best. Honestly, I really wish all the best to all of you. And those who have really worked hard, it will show result. Don't worry. It will definitely show results. If you want to ask me anything, I'm here with all of you. You can ask me questions and you can chat with me at the live chat box, which is there in the YouTube channel. I'm opening my chats also. And you can ask any questions that you want to ask. Anybody who wants to ask any questions? मुझे एक बार लाइव खोल के दे दो. खोल नहीं रहा है. एक बार सच ऑन है, लाइव ऑन है ना?
हाँ हाँ, वो मैंने वो हाइड कर रखा है. एक मिनट, मैंने लिंक ग्रुप में, अब व्हाट्सएप ग्रुप में होना तो मैंने वाले मैं डाला हुआ है अभी जस्ट.
ये ना
तो थोड़ा ऐश्वर्या सर अभी रेडी नहीं है ना, तो मैं बोला कि
पॉज ले लो, थोड़ा ब्रेक ले लो. 5 मिनट लगेगी. ठीक है, ठीक है, ठीक है, कोई बात नहीं. और इसके बाद फिर डॉक्टर रुचि का ले लेना, ऐसा होगा तो, कि मेरे को भी फिर टाइम मिले.
आपका नहीं ना
153 लाइव. हाँ मेरा है, पर 1 घंटा अगर मिल गया तो ठीक है. ऑन कर दे ऋषभ वापस. Okay. So now I have opened my live chat. Anybody who wants to ask anything, we are open to discussion. Before we begin with Dr. Aishwarya Kaushik, we all know who Dr. Aishwarya Kaushik is. He is the legendary author of the books of Endodontics. He's a teacher since 2010 and he's our original guru for Endodontics, conservative dentistry and dental materials. He will be with you live in a short while. Till then, we have a few minutes. If anybody wants to ask anything about this exam, I hope you all had a safe and a comfortable experience for the exam. And you can all share your experience also in this live chat if anybody wants to share their experiences. We are open. I am somehow not able to open the chats. Okay. So our live chat is on. So in one way, I really appreciate the AIMS authorities. Okay, now I can see your questions. Thank you so much. So most of you are just typing in questions. Beta, we have the questions ready for all of you. We will all discuss. And third year BDS के batch कब से start होंगे? Third year BDS, you can always enroll now. You can start now. Third is the most best time to start for your MDS preparations. And again, I cannot see the chats. Yeah, again, now I can see the chats. All right. Okay, how many felt the papers was not easy? Me. Paper was not easy. You can't expect AIMS paper to be easy. It was definitely not easy. All right. Yes, a lot of repeat questions. 20 to 25 questions were repeat. Yes, Ranjan, you are absolutely right. And very soon we will start with a recall where you will know the exact question and the options. All right. And the correct answer. All right. Siddharth has also announced the topper for this year. Fingers crossed. I hope all of you get the results that you expect. Yes, there were less few PYQs, but more PYTs. A lot of previous year topics were repeated. Okay. Yes, OS questions will be discussed in detail, beta. We will have an OS recall. The PPT is being made. And just after this analysis, we will have endo. And I don't expect you to ask me individual questions because they will be discussed in the recall. Are we ready with the endo cons? Rishabh, are we ready? All right. So I think most of you had a okay experience with INI. It is usually smooth. Blend करो ना, बंद मत करो, blend करो.
ब्लेंड नहीं कर रहे हैं, मतलब इससे आप हो जाओगे फिर एक्चुअली सर का सिस्टम में.
तो मैं उनको इंट्रोड्यूस तो करूँ ना. सर रेडी हैं?
हाँ हाँ, तभी तो मैं आपको इशारा किया.
ठीक है, चलो.
रेडी?
हाँ, लाइव कर दो एक बार. The facilities in the center were flawless. The pen was available, water was available, frisking was smooth. At least in Delhi centers, everything was smooth. If anybody of you faced any difficulties during the exam, that also you can let us know in the chat box. What will be a low scoring paper and how much marks a topper can expect? It's difficult to say. You can calculate your individual scores with this recall. At the end of the recall, we will take the scores of all the students that are enrolled with us, and then we can tell you what is the difficulty level of this exam. It was definitely a moderate to difficult exam. And all those who have marked appropriately, not marked a lot of answers, but if you have marked appropriately, somewhere around 160 questions, 160, 165, that's a good marking. And with that, you should expect a good result. All right. So there was difficulty in Ahmedabad Center. Dhrumil, you can let me know about the difficulty in the chat box. And we will be finishing our exam analysis with this. I am glad to invite here Dr. Aishwarya Kaushik. He will be taking up the recall for dental materials, conservative dentistry, and endodontics. All right. Thank you so much for everybody for being with us. You can let us know your views about the analysis also. And all the best to all the hardworking students. जिसने भी मेहनत करी है. Remember, if you get a rank, it's a very good thing. Even if you don't get a rank, I am sure the experience that you have got with this exam is invaluable. NEET will be similar to INI, not same, but similar. Some bouncers you can expect, some repeat questions you can expect. Don't get disheartened, all those who are not feeling good. Just take it as an exam. Just learn from whatever you have done and move on. Okay? Just relax, take the recall and take a break. Restart for NEET 2025. All right. Thank you everybody for joining this session. I'll see you for the OS recall. Thank you so much. सर 1 घंटा ले लेना आराम से. हम ज्यादा
देख लिया मैंने ये DBMCI रिकॉल। मेरे को स्क्रीन दिखा देना। हाँ, स्क्रीन भी दिखाते रहना एक एक उस पे। हाँ, मैं रेडी हूँ। हेलो, माइक चेक। माइक चेक इज फाइन। या ओके, माइक check is fine. Hi guys. First of all, a very good evening. It was a very important day for all of us today, right? Um, I'm trying to get you the most accurate possible version of the questions today, right? So that is my endeavor today, guys. And yeah, good evening, Nami, good evening, Doc, good evening, everyone, guys. First of all, tough paper, guys, full of community, full of endo DM. And in as far as endo DM cons is concerned, cons is less, endo is more, DM is more. Um, Tough questions. Hardly 3 questions were as it is repeat. Rest all new questions, and new also to the extent that you won't find the references straight from your standard textbook. So, in a way, many a times this serves to be a blessing for all of us who are preparing very hard, right? Because there's no scope for hit and try, right? So in such a paper, you cannot attempt like too high, like out of 200 you're attempting 190, 195. That's too high. By the same time, when you zero in, when you completely eliminated 2 options and you're kind of 70-30 with one option and 30 with the other, you zeroed in on 2 options, kind of 70% for one option, 30% for the other, and completely eliminated 2 options. Go for it. And in such a tough paper, go for almost say 175, 180 type of an attempt instead of 190, 195 out of 200. I'm talking about out of 200, right? So guys, that's the thing with tough papers. First question itself, very tough, guys. This is from your dental materials, not given in your Phillips. Heat sinks. What is the true statement regarding heat sinks? Now, first of all, we don't know about heat sinks. Heat sinks in the entire Phillips, you will only find one reference of heat sinks, and that is some coating of the burrs, in the finishing and polishing materials chapters, which nitride coating of the burrs, which help to reduce the frictional heat. But a slightly advanced version of heat sink is what, guys, is basically, when you've invested okay, so when you've invested your wax pattern, guys, right? That's your crucible former, that's your sprue former, right? And you have a very thin wax pattern, right? If you have a very thin wax pattern, guys, right, you create an accessory kind of a sprue or a vent, a very narrow accessory kind of a sprue or a vent, which will act to dissipate heat, right, and would ensure that in those critical thin areas of your wax pattern, your hotspot kind of a porosity does not take place, right? Whatever heat is concentrated in those thin areas, very thin areas, it also has a ability to kind of escape through this auxiliary vent or a reservoir or a sprue, auxiliary sprue, right? Not a reservoir, auxiliary sprue. So it's a heat sink as far as our understanding of the investing and casting procedure is concerned. It's a auxiliary vent or a sprue, which would ensure a nice complete completion of the casting without any porosity, especially hotspot in the areas of a very thin wax pattern. um, um, Guys, right? So I mean, I would, as far as I'm concerned, I would suggest that even if you've left this question, it's okay. Advanced question not given in the textbook. So from an examiner's perspective, yeah, tough question, guys. So auxiliary vent, or it's actually not a reservoir, or more importantly, like a sprue, right? Additional sprue for the fabrication of castings of thin wax patterns. That's my answer, guys, right? This is a repeat, guys. Argon atmosphere, many a times in my live classes recordings, every time TND, I've told you, if you are going for casting of titanium, right? If you're rich enough doing a PFM crown and you say, I want a very light PFM crown, you go for titanium. You have to ensure, that it does not get oxidized too much, because titanium has this, just like chromium, it has this tendency to form a very thick, brittle layer of titanium dioxide, especially when the temperature is raised to beyond 850 degrees Celsius, right? So you want basically your casting to take place in vacuum, or basically in the absence of air and oxygen, right? So it can be an argon or a helium atmosphere, right? A noble gas atmosphere. So the answer is titanium, guys. Very simple. Again, next question is also actually simple, but slightly application based, in the sense that it's basically the choice of investment material for uh, which kind of alloy that you're using. A gold alloy that's a low fusing, or a high fusing alloy, right? Like a base metal alloy, like a cobalt chromium or a nickel chromium, right? So high melting alloy, you're going to use what? A phosphate bonded investment material, right? Now, phosphate bonded is basically what? The binder is your magnesia and your aluminum phosphate. So that's the answer, right? Very simple. In fact, the other options were slightly tricky if you were to see those options. One is silica is used as the binder. No, silica is there. So silica is there, of course, but it is the refractory. So this cannot be the answer. The investment material should be silica free. No, because it should have silica, right? So this is also wrong. It should have silica, because quartz or cristobalite in the form, silica in the form of its allotropes, quartz or cristobalite is going to give refractory nature not just to gypsum bonded investment materials, but also to phosphate bonded investment materials. Gypsum and silica, of course, cannot be the answer. This is for gold based alloys, right? So again, as I said, this is again straight from our lectures, from our live discussions in metallurgy. But yes, the options were very smartly put, right? Not they did not give you a straight away phosphate bonded investment material or silicate bonded investment material. They were actually they moved from point A to point B like this, right? Holding the ear like this. You needed to know the composition of the phosphate bonded investment material in the form of ammonia, phosphate, magnesia, in order to reach the right answer. Then true regarding the following diagram regarding casting or fabrication of a cast partial denture. Now this was an image based question, guys. Again, a trick question, tough one. Why? Because we don't do casting procedures, especially of cast partial dentures and our inlays or onlays at BDS level. So in that sense, it's I think it's wrong to give a question like this at BDS level. It's very wrong, but that's how the examiner creates new questions every year to eliminate and make the paper tough. So basically, I'll tell you one more very important thing. We've been discussing impression materials in very detail, right? Especially agar, right? So if you see this, the image that the closest image that came in the examination was, guys, similar to this, if you may recall, right? A green, from a metal kind of a container, a greenish colored, liquidy, semi-solid substance was coming out, right? Now, please realize, in all our dentistry, mostly, these metallic kind of containers, when we discussed about the manipulation of agar, the liquefaction chamber, the storage chamber, the tempering chamber, right? The tempering and the storage chamber. Because basically these are all metallic almirahs, isn't it? And the kind of liquid coming out, it kind of tells you about it's like agar coming out, right? Why would you want wax or plaster coming out like that, right? So that is I would say a more even if you don't know the answer, a calculated guess can be made in that manner, right? So so that's why my answer here is agar as a duplicating material, right? So during lab procedures. Who's saying this? You came to wrong Zoom meet trending today. Anyways. Uh, okay. Okay, okay. These questions were not there in your paper. Okay, good. Fine. Right, guys? So, well, they were there in mine. Anyways, right, guys? Uh, where are our students? Yes, Saurav, Nami, are you all there? You're listening? Aditi, Gautami, Libra. I want your feedback also. Yes, guys? Okay, wonderful. So the answer here is agar as a duplicating material, right? Wonderful, guys. All right, great. Fine. So we have the answer here as agar for duplication. Okay, new question. Tough one, guys. Tough question. Again, I would say um, okay, great, great. So we have our students here, Aditi, Gautami. Yes, not a technique of CAD/CAM. Tough one, guys. But I'll tell you what. I mean, you might not be knowing about fluid design modeling, right? New term, selective laser sintering, probably a new term. Stereolithography, probably a new term. But guys, pressing. I mean, pressing or heat pressing or hot pressing fluid ceramic material into the lost wax investment mold cavity is just like a very similar process with which you cast your metal, right? With which you get to cast your metal. And olden days, if ceramic, even today, you know, you can actually heat press a lithium disilicate, right? Or a feldspathic porcelain in order to get an all ceramic restoration, right, guys? So this is a classical method, cannot be CAD/CAM. So I mean, if this was there in your head, you would have marked pressing, and I understand this is the answer, right? And of course, I understand the fact that you would not be knowing. Fluid design modeling is one of the methods in which you basically see the movement of fluid and irrigant in a engineering structure, in any physical structure, and you can design it by CAD, CAD/CAM technique. Selective laser sintering, again, it's like a 3D printing. It's the most modern method of, you know, kind of manufacturing your PFM crowns, right? The metal coping is extremely paper thin, very precise, wonderful crowns made with DMLS technique. I'm doing that in my practice these days. I fabricate PFM crowns with DMLS, wonderful crowns, and it is a computer aided designing technique, right? Stereolithography also is a CAD technique. However, as I said, even if you did not know the details about these three options, pressing, guys, pressing is very similar to the lost wax technique and the classical technique in which you you know, in your casting machine, you basically with pressure, with adequate casting pressure, you insert your liquid metal into the mold cavity following lost wax burnout, right? So that's the answer. Another important question, guys. This is from obturation. For lateral condensation of gutta percha, spreader should be pre-fit too. So basically, guys, what he's asking is, first of all, this is straight pick from Cohen, right? And what basically this guy is asking is that, nahi beta, stereolithography is an option, but it is one of the techniques of computerized techniques of designing, right? So the answer is pressing, right? ठीक है. What is ODF? As a PDF. Okay, just listen to the presentation carefully, guys. So for lateral condensation of gutta percha, spreader should be pre-fit too. Guys, basically what he's saying is, you have done your BMP, right? That's your tooth. You've done your BMP, right? You've selected your master cone. Now, before insertion of your sealer and gutta percha and the master cone gutta percha, you will take, so for example, my master apical file or my final file is 40 number K file. I'll take a 40 number 2% spreader, and I'll ensure that it, even if it is not going right up to the working length, it should go 1 to 2 mm short of the working length. Right, now, this is what is written in Cohen. Logical reason, I don't know. Frankly, I feel that it should go right to the working length, right? But can't help it because here this spreader is going to be replaced by the master cone, isn't it? So the length should be very precise, right? But Cohen writes probably they're kind of incorporating some kind of curvature, factoring in some kind of curvature in which a more pliable gutta percha would go, but probably a smooth stainless steel spreader is not going, whatever the reason is, the answer is 1 to 2 mm just short of the working length, right, guys? So the answer is, and the other options were very tricky actually, 0.5 to 1 mm short of the working length, exactly the same as apex locator determined working length, radiographic working length, right? So all the options are very close to each other, but the final answer is 1 to 2 mm short of the working length. No controversy, no doubt about this, right, guys? Beta nahi hai 0.5 to 1 mm. Even I feel practically it is, but that's what the textbook writes, right? So can't help it. Okay, best current evidence for anti-caries activity of silver diamine fluoride concentration for the prevention of caries is 38%, guys. This is straight value-based question, no doubt about this. This is from Periodontics, right? All are now, tricky one, guys, tricky one. All are reasonably true. This is a clinical-based question, reasonably true for the parameters of post-space prep, except all are reasonably true for the parameters of post-space prep, except. Now, please understand, at least 3 questions, very similar, tricky ones were there regarding post and co-prep, right? So let's see. Let's see the second option first. In an average rooted tooth, like what do you mean by average or a routine tooth? Whatever word was used, average or medium-sized tooth, basically not with an extremely long root, right? So it should go inside the canal by 1/3 the root length. Now this was average to a long rooted tooth. It was actually there was provision of a long rooted tooth here also. So therefore, practically in a long rooted tooth, for instance, if the root length instead of 10 mm being 15 mm, you can just go about 1/3 inside the root length, right? Inside the root canal, and this should be sufficient, right? This is especially true for a fiber post, which is going to be cemented with a dual cure composite, right? So if your root length is not too short, basically the idea is if you have a root which is too short, then even for a fiber post, you have to go half the root length. 1/3 is okay for medium to a long rooted tooth, right? So this is fine. This is a clinically acceptable criteria. Next, you should definitely go up to 7 mm in molar roots inside the canal from this is the CEJ or the pulp chamber, of course. You should definitely go up to 7 mm, but not beyond that, because then you're facing curvatures, right? So this is also true. In average length roots, the post should be prepared so that 5 mm apical plug of GP is there and the post nearly extends or touches the GP. Yes. Time and again, I've told you in the recordings of the post-endodontically treated teeth or RC treated teeth, post-endodontic restorations chapter, that ideally 5 mm of GP should be there and at least 4 mm as you see in the radiograph. So this also seems to be true. The first option should go at least 4 mm apical to the alveolar crest for the minimization of dentine stresses. Guys, here, please realize that 4 mm is just about too less. Why? I'll tell you why. This is a very application-based question, guys. I'll tell you why. Guys, what is the criteria? Whether it's a fiber post, whether it's a metal post, it should go half the bone-supported length, of the root inside the root canal, right? Yes. So this is my tooth, this is my root, right? And this is the level of my alveolar crest, right? So whatever this length is, it should go at least, this is L, so it should go at least L by 2. Now, normally the length of the root is anywhere between 9 to 15 millimeters, right? 9 is the minimum, right? So on an average, I'll be somewhere in between like 11 to 12, right? So half is about 6 mm, right? Now, if the alveolar crest, even in cases, alveolar crest just inside the, so apical to the alveolar crest, it should be, isn't it? It should be 6 mm. Or even if I'm to take a case with the smallest possible root, 9 mm, then also it should be at least 4.5 mm inside the canal apical to the alveolar crest. So should go at least 4 mm apical to the alveolar crest is not true. So all are true except I would go at least 4 mm even for the smallest of roots. right? 4 mm is too less. So this was, guys, yeah, exam was really tough. Not most, dear, not most, but yes, 3 or 4 questions were there from post and core. I'm very tough. I mean, just see this question, see the level of the question. You have to really know. It's written in Cohen, and I've told in my recordings also. 9 to 15 mm is usually the average length of the root, and 10 mm is the average length of the crown, any tooth, right? Right. So, guys, you have to be slightly more than 4 mm, not 4 mm, right? Okay, all are true regarding ideal properties of a root canal filling, except now, guys, there were very simple options. The rest of the options were very simple. It should never resorb and so on and so forth. It should not support bacterial contamination. There was one option which said that it should slightly contract after setting. Guys, it should slightly expand after setting so that it creates a nice seal in the apical part. So, in fact, one of the other option was it should be inserted in a semi-solid state, and then, of course, after setting, it turns into a solid, right? This is also right. So I would say slightly contraction after setting is a wrong statement. Slight expansion after setting is what is desirable for a good apical seal. Very tough question, guys. Next one, statement A and statement B. And this was, the options were, again, both statements are true, both are false. Statement A is true, B is false, and vice versa. A is false, B is true, right? The statement A is, do not remove the GP immediately for post-paste preparation. It is totally wrong. If you have, especially, see, the examiner specially mentioned well-condensed obturation. If you have a well-condensed obturation, guys, there is no problem. If you've maintained the correct principles of preparation, like you've not violated the apical constriction, you've not created a ledge or a teardrop shape apical zip or tear, it is rather recommended that you remove the GP in the same appointment as that of the obturation. So statement A is true. So statement A is false. Do not remove. Do not remove GP immediately. You can definitely remove it. Rather, it is recommended. So do not remove GP immediately after post-paste prep is a false statement. Second, GP can be effectively removed with the same efficacy. Whether you're using rotary or hot instrument, yes. There are people who are very well trained in their hand skills with using hot pluggers to remove the GP. No problem. If you know the right technique, do it. Not necessarily use piezo reamers or GG drills, right? So statement A is false, right? You can remove it immediately. So do not remove it immediately is a false statement. Statement B is true. It can be equally effectively removed, either with the hot instrument or with rotary. So the option which says that statement A is false and statement B is true is the right answer, guys, right? Next, which is true? Next question is, again, tricky one from post and core. Which is true regarding post-paste prep, guys? So let's see the first option here. End cutting burr is used, absolutely wrong. You're using a piezo reamer, which is a non-end cutting burr, or a drill. You're using a GG drill, which is non-end cutting. You don't want to create perforations. Next, increase in diameter increases the retention of your post and core assembly, and it is a recommended method. Now, guys, this is a wrong statement. You know why? Yes, increase in diameter does increase the retention, but it is not a recommended method. I don't want to do it unnecessarily. I'll weaken the root, right? So again, wrong statement, guys. Wrong statement. So this statement is, in a sense, partially wrong. So it's a wrong statement in all. Increase in diameter of your post-paste prep and using a thicker, fatter, more bulkier post, yes, it increases the retention form, but it is not recommended. And in the exam, it was clearly recommended. It is a recommended method to enhance the retention form of the post and core assembly. No, it is not a recommended method. Right? Then I would go directly to the third option here. For molars, very interesting. For molars, one has to be careful in the preparation of the distal aspect of the mesial root, right? And the mesial aspect of the distal root are as concavities might be there. Guys, here again, statement, first part of the statement is right? That you have to be careful in the preparation of the distal aspect of the mesial, right? So guys, this is the cross section. The Abu Ras gave anti-curvature filing, especially for the filing of the mesiobuccal and mesiolingual root of the mesial root of mandibular molars. Why? Because the first part of the statement is true, that the distal aspect of the mesial root canal or the mesial root has concavity. So you have to be very careful. But if you see the distal root, guys, then the mesial aspect of the distal root does not have such significant concavities, right? So the second part of the statement is false. So the entire statement is false, right? So again, this is again a false statement, guys, right? Next, the depth of post-space prep should be kept as minimum as possible. Yes. I mean, you just want it to be as minimal. You don't want to unnecessarily go deep inside the canal, even if you have adequate, when you realize that you get adequate retention form, it's not like you always have to go right up to the depth at which you will only have remaining 5 mm of GP left. If you're doing a post and core prep with in a canine, you can, and you achieve adequate, other parameters are fine. You can let more GP remain as an apical plug if you satisfy other criteria, like if you're using a cemented, if you're using a fiber post, and you can stick to the criteria 1/3 to maximum 1/2 of the root length, right? And then in case of a, say for example, a canine, you can have more than 5 mm of GP plug remaining, right? So try to go as less deep inside the root canal as possible without compromising the retention. So this is a clinically true statement, right, guys? So therefore, the answer is, as far as the true statement is concerned, the depth of post-space prep should be kept as minimum as possible. Wonderful question, guys. I always say this, guys. Take your time. The time is never too less in the examination. These questions are practical, clinical-based questions. See them through, think them over. Don't be in a hurry. You will reach the right answer. Commonsensical question, guys. Right? Then the next question was age-old. I'll write a big star here. Age-old controversial question, guys. Nobody knows the answer, correct answer to this question till now. This is from 1970s National Board of the US. People who wanted to go to the US. First irrigant to be used in case of acute periapical abscess case with active pus discharge, right? Then what is the irrigant that used? Now, by all logic, you should use hypochlorite. So it was, the options were sodium hypochlorite, like a small percentage, 2.5, then sodium hypochlorite around 5 to 5.25%, then saline, and then warm saline, right, guys? Now, because of some logic, the people in the national board, because of probably the fact that, using in cases of acute periapical abscess, there's already so much tissue destruction. So if you use hypo, if there is by any chance some sort of extrusion of periapical, into the periapical tissues of the sodium hypochlorite, it will cause more tissue destruction, right? So probably because of that reason, in the key to that, to the national boards, way back in 1970s, 80s paper, it was given as warm saline. So till such time, I don't find a more solid reference to this, more predictable reference to this. As of now, as of today, I'm going with warm saline, but I'll keep this in mind. I'll keep looking for it. If we get a solid reference, we can change the answer. But this is a question that has created controversy in the past 30 years, right? Yes, beta. So yes, adequate depth, that's what I said, right? Adequate depth of the post is required, but it's not necessary to go unnecessarily deep. So as minimum as possible, right? Okay, WHO classification, KO4.1 was asked, guys. KO4.0 is pulpitis. And you know why WHO classification is not used, is not practical, because it includes all sorts of pulpitis, right? Reversible, irreversible, symptomatic, chronic, everything. And KO 4.1 is pulp necrosis, right? So the answer is pulp necrosis here, right? Just to give you a perspective here. What a paper, guys. What a paper. DM, endo, what a paper. Tough paper, guys. But don't worry. So KO 4.1 is pulpal gangrene or necrosis, and O 4.0 is just all types of pulpitis, right? That's why it's not used very often. Achha, I'll check that, guys. Saline or warm saline. I'll check that. But it's a line definitely. I don't know. I mean, I don't know why the latest Cohen angle don't give any solid reference to this. So age-old question, creating so much controversy. Anyways, next question, guys. Regenerative endo. All are the goals. The goals was the word that was used in the exam. All are goals of regenerative endo except, right? So yes, I mean, simple. You don't have to look at the options in such a question. Just think in your head. So what do you want? You want resolution of signs and symptoms. Of course, you want healing, right? You want periapical healing to take place, right? That's one. You want the increase in the length and the width of your root canal. Yes. You want your revascularization itself to take place. So you want the transition from a negative response to pulp testing to a positive response, right? So these three options are correct, right? What you don't want is complete obliteration of the canal, although this can happen, and it's not a very bad thing in the sense that it is representing some sort of revascularizing, but it is not my goal. I want my pulp to kind of get back its loose connective tissue structure, not complete obliteration with hard calcified tissue, right? So yes, it's not too bad, but it is not my goal. So complete obliteration of the canal is not my goal, right? Now, guys, big controversy, right? Statement A, Schweck's type 2 open apex, immature apex 2. Now, I've done this so many times, but the examiner is just one step ahead here, right? So what he's done is, Schweck's type 2 open apex, immature apex case, revascularization is the treatment of choice. This is a true statement, no doubt about that, right? So basically, guys, Schweck's type 1, in which open apex with the length of the root less than half. Type 2, open apex, immature permanent tooth, length of the root equal to half. Type 3, open apex, length of the root equal to 2/3. Type 4 is an open apex in which the length of the root is the same final length, right? Right. And type 5, of course, is not, it's a mature apex, so it's not even an open apex, right? Now, the thing is, when you see the criteria from the original article of Schweck, he says that in 1, 2, and 3, you definitely have to go for regenerative endodontic procedure or revasc, right? It's the same one and the same thing, two different ways of putting it, right? However, in a type 4, you can either do a revascularization or you can do an apexification, and the article does not mention which is better in this. Therefore, I always recommend in a image-based question in which you have a case of open apex X-ray given, as has been the case with AIMS people in previous years, and they give both the options, revascularization and apexification. You should go for revascularization because you can do either, right? However, this question is slightly tricky in the sense, you know why? Because he's asking that one particular thing, like in type 4 open apex, immature, MTA apical barrier is the treatment of choice. As I said, very incorrect to ask this, you know, because this is a big controversy, right? I mean, even the article says you can do either. However, I personally feel, and this is my feeling, guys, specifically, why has he asked this? Specifically, why has he chosen type 4 and asked specifically for MTA apical barrier to be a treatment of choice? Can it be true? So if you see it from the perspective of the fact that one of the goals of revascularization is to bring back the length and the width of the root to the original dimension, right? So that the tooth is no longer weak. That has already been achieved with in a type 4 open apex case, right? Right. So why to subject the patient to a very long treatment protocol of revascularization, which can take almost 18 months, right? 1.5 years, 2 years, when you can finish the treatment in 2 or 3 visits, do BMP, do give your calcium hydroxide dressing for 2 to 3 to 4 weeks, make an MTA plug, apical barrier, and finish the treatment without worrying about the fact that the tooth is predisposed to cervical root fracture because it has already attained good length and width, because it is an open apex, but it has. So I get this feeling that AIMS people are trying to play games here slightly, and they've fabricated this question specifically to ask us to elicit from the student whether he knows the clinical difference, the practical difference between type 1, 2, 3 on one hand and type 4 open apex on the other. So I think here, and this is subject to, we'll do some more research on this, but I feel as of today, statement B is also correct. Both statements are correct, right? I feel the examiner specifically asked us to fathom, to figure out whether the student knows the biggest advantage of a type 4, Schweck's type 4 versus 1, 2, 3. 1, 2, 3, no doubt, revascularization or regenerative is the treatment of choice. You should not even attempt apexification there. Only if the patient is saying that, I'm in a hurry and so on and so forth. But you should, type 4, when you can do either. And when the examiner specifically asked you about type 4 open apex, what will you do? An MTA apical barrier seems to be I would say just a hint, 1% better option in terms of the fact that, in terms of logical reasoning, that, you're not gaining too much by doing a revascularization, right? You're not increasing the length or the width of the root. So I think in this, both statements A and B are correct, guys. I would go with that. As of today, this is the new question. Tricky one. हाँ बेटा. Thank you, guys. Right. हाँ, ये क्वेश्चन ने पूछा शिवम, but sir, post should be, बेटा, metal post should be 3/4 of the root canal. Fiber post is just 1/3 to half. So the examiner, when he's not mentioning anything, you have to incorporate the possibility that he's talking about the fiber post. And in fact, in modern endodontics, fiber post is used. Rarely metal post is used. Right? So guys, I know this is a tough one, but I feel, as far as this question is concerned, the examiner is slightly trying to, play mental games here, and it's both A and B are correct. Next question, guys. Statement A: avulsion and luxation are more common in primary dentition. That's true. The bone of the children is not that thick, and is not that calcified. So luxation injuries, avulsion are more common, and of course crown fractures and crown root fractures are more common in permanent dentition. So both statements A and B are correct, right? Then cry paste composition is a repeat question, guys. So it's basically your iodoform, camphor parachlorophenol, and camphorated monochlorophenol, right? So that was it was simple. In the exam, you had 4 different options, but there was no confusion because they were not asking about concentrations and so on and so forth, right? It was a straightforward, simple this thing, guys. Straightforward, simple one. Iodoform also containing parachlorophenol, camphor, and menthol. This is a straightforward one, right? So iodoform, parachloro, camphor, menthol. Where is it? Yeah. Iodoform, menthol, parachlorophenol, and camphor. Right, guys? Yes, beta. I hope you, Nami, Dr. Libra, Gautami, beta kya mark kiya uska? What did you mark, guys? Did you mark both statements are true? Because frankly, statement A is true and statement B is false. That is also not wrong. But I don't know. I have a feeling that both statements are true. I think the examiner is going to go with that. What did you guys mark? Huh? I don't know. But I mean, I would have gone with both statements are true. Tough one, guys, but can't help it. These AIMS people do create such tough questions. Acha, tough one, guys, again, from in between the lines, guys. From in between the lines. Root and prep during microsurgical endodontics is done by ultrasonics at. Guys, basically, arey very good, Harmandeep. Or Gautami, what did you mark? Nami? कोई बात नहीं. I don't know. I mean, you might be right also. Statement A is true, statement B is false. That might be the right answer there also. Both true, both true. अच्छा. ठीक है. Gautami, what did you mark? Nami, Nami, you got confused and what did you mark? Bushra, yes sir, agreed to you. हाँ सही है, ठीक है, good. Both true was my answer. I think it should be both true. Chalo, good. Okay, root and prep during microsurgical endo is done by ultrasonics. Guys, basically, you know what you're supposed to use. Studies have shown if you can use them at low speeds, low power, high power, but high power creates cracks. So you should do it at low power. Also, it should have, Cohen writes that an ultrasonic and should have ultrasonic tip should have irrigation port. Acha, okay, should have an irrigation port. So of course you should use a water coolant. So low power water coolant is my answer, guys. Right? Acha, again a trick one, which is not critical regarding perforation repair. So guys, basically he's talking about your perforation, right? So first of all, of course, we've discussed this in my TND also. I mean, if you have a perforation which is more apical, it is tough to repair, but the prognosis is better. So as compared to a cervical or a middle third perforation, right? So the level of perforation, whether middle third apical or cervical, is important, no doubt. Delay, time delay is again important. The more is the time delay between the perforation and the repair of perforation, again, the prognosis is poorer. Size of perforation, although not directly given in Cohen, this is also important, guys. You know why? Because if you have a too big size of perforation, the size of the perforation is bigger, then guys, I'll tell you nature. Yes, Krish, I'll tell you that's the fourth option. The size of perforation is would, although not given directly in Cohen, what it would do is it would affect the sealing ability, isn't it? Sometimes it's tough to basically repair or get a nice seal if you have a larger size perforation, right? So I think that is also important. Then was the nature of perforation. Nature of perforation. Whether it was a pathologic or iatrogenic. I think this is the most appropriate answer. Out of these four, this is the least important as far as prognosis is concerned. So I would go with nature, which is not critical, nature of perforation, whether pathologic versus iatrogenic. Although I feel even this is important. Pathologic perforation is usually long-standing, isn't it? You have a case with, say, internal resorption, right? And the patient is presented to you after perforation, not before that. Right? And it's been some time. So obviously that area will become more infected, right? But somehow it's not mentioned in the various points from various sources which I've referenced. So I think this is the answer. So nature of perforation, even if it is important, out of the four, this seems to be the least important. Yeah. So I feel nature is the answer. Nature of perforation. Now, this is one of my favorite, guys. The images that I always show you, all our students at DBMCI, right? There's a 245 burr. The image was that of a 245 burr. I'll tell you what. I always do this in my class in operative, isn't it? All of you must be, remembering that. So this is the exact burr that was shown, right? It was an inverted cone. The base was thicker, wider than the upper part, right? And the catch here was, see, the examiner was so smart. the examiner was so smart, he put an option of 330 burr also. But 330 burr is exactly the same as 245, but the length is 2 mm. And in the exam, 3 mm length came, right? And the diameter was 0.8 mm and the shape was like this of an inverted cone, right? So the answer is 245 burr. Again, I always do this in my classes, guys. Always do this in my live classes. And this thing. Where is it? Yeah, so the answer is 245, right? Okay, then a trick question, guys. Bench curing. Bench curing of denture base resin, which is true statement. Right now, first of all, please realize if you have made, for instance, in our college, we used to make all our dentures ourselves. No help from the staff. Everything, packing, teeth setting, everything. And we were supposed to make 4 dentures in third year, 4 dentures in final year, 4 dentures in internship. Otherwise, you would not get any sign. At least the minimum. Rather, I think in internship, 8 dentures. Complete, full, complete upper lower. Anyways, and each and every step ourselves. Now, guys, the question was about bench curing, not bench cooling. You understand? So basically, when you've dewaxed it, you've packed it, and you have this thing, you try to compress it, right? Some pressure with some pressure. Then you let, before putting it for curing at the thermal cycle, right? Before putting it under heat, is supposed to let it remain for about 30 to 60 minutes, half an hour to one hour outside before starting the curing cycle. That is bench curing, right? Right. So first of all, the first option goes out of the window. It is done post curing during the cooling period of the denture base resin. That is a bench cooling, right? ठीक है? That is bench cooling. So this cannot be it. Then third option, not recommended as monomer is lost. This is wrong. Where will the monomer go? You've packed it well, right? It's not like it does not have an open lid. It's a closed lid. Irregular or non-uniform thickness of denture base resin will be there. This is absolutely wrong. In fact, when you let it rest for a while before going for the heat curing cycle, you actually ensure that a uniform thickness of denture base is uniformly distributed throughout the horizontal cross section, right? So this is wrong. What is true is it is recommended. And one of the reasons why it's recommended is better bonding of the acrylic teeth takes place with the monomer. You give more time before putting it directly under heat, because then the monomer kind of sometimes boils out, right? And porosity is there. So you give adequate time for good adaptation, good bonding of the acrylic teeth with the monomer, right? So that is my answer, guys. Again, a tough one, guys. Application based. Rather, I would say, tough question, guys. So better bonding of acrylic teeth takes place with the monomer. That's the answer. Sodium hypochlorite irrigant to be used in regenerative endodontics, guys, it's 1.5%, and the closest option was 1.5 to 3%. So that's the answer. Straightforward, right? Good. Hemostatic agent of choice during VPT, sodium hypochlorite. That's actually the criteria when you're doing, whether you're doing pulpotomy or a direct pulp cap, or to determine whether your underlying pulp is reversibly inflamed or irreversibly inflamed, you actually put, with slight pressure, sodium hypochlorite dipped cotton pellet in order to, of course, ensure hemostasis. And also, if hemostasis is not achieved, when you diagnose the pulp as irreversibly inflamed, and then you have to go deeper, right? So sodium hypo, although you can simply give a pressure pack with saline, that's also not wrong. But the agent of choice for VPT as a hemostatic agent of choice is is sodium hypochlorite, right? And concentration again is up to 5.25%. In one reference, in one place in Cohen chapter of VPT, it's written around 3%, but in another place it's written 5%. So it's between 2.5 to around 5.25%, right? Pulp capping agent of choice, simple question, guys. But MTA is, any calcium silicate based cement is the best. The rest two options were super EBA, and the other was fast setting calcium hydroxide, slow setting calcium hydroxide. Guys, MTA is the best answer, no doubt about this, right? नहीं बेटा, bench cooling गलत है. Bench curing and bench cooling is different, right? Then, one very important question from Periodontics, guys. Straight image from Sturdivant Periodontics. Image-based question of enamel and dentine caries was there, right? It was a colored image, and this is from the 5th edition of Sturdivant. Exactly same image, but it was a colored image, right? Now, guys, see this. If you see this, this portion is basically bacterial plaque, right? Then slightly underneath is, if you see the various histologic zones of dentine, right? The lowermost part would be the reparative dentine, right? Which was in the exam, which was slightly yellowish, isn't it? Then you had a whitish band of sort of an intact dentine, in the sense that it was not colored dark. So just above the yellowish band of dentine, right, which was reparative dentine, just above it was the arrow that was marked with blue, right? And they had asked, what is this? And see the examiner, it is actually what? Transparent dentine. It is actually transparent dentine, but the options did not have transparent dentine, guys. What were the options? The options were reparative dentine, firm dentine, hard dentine, and soft dentine, right? And this transparent dentine, right, is basically, the transparent layer is a zone of carious dentine that is softer than normal dentine, right? So it shows loss of mineral, but bacteria is not present, right? Collagen cross-linking remains, so it's basically affected dentine, right, which can be remineralized. But that's not the point here. This is basically, the answer is soft dentine. So this is an application-based question, guys. Application-based question which you should have been knowing this diagram. The deepest part just above the pulp, the yellowish part, is reparative dentine, and just above it is transparent dentine, which is soft. So the answer according to the options was soft dentine, guys. Tough one, guys. Again, I would say tough one, right? So the answer is soft dentine. Although I think this is basically Periodontics. Probably you will do it with your, pediatric dentistry people also, but whatever. I thought it's important that you get this right here. Not used, this is repeat, guys. This is repeat, not used as a crucible former is, the answer is glass, guys. You can use rubber, plastic, and metal. What you cannot use is glass. So this is a repeat. Okay, not true about this. I've done n number of times, right? Not true about IADT 2020 guidelines for traumatic dental injury without alveolar bone fracture about the splinting time. Not true about the splinting time. As per the IADT 2020 guidelines is. So these are basically the splinting times. And one of the options was lateral luxation 2 weeks. Guys, you're supposed to do splinting of lateral luxation for 4 weeks. For extrusive luxation, for subluxation, it's 2 weeks. For avulsion, it's 1 to 2 weeks. But for intrusion and lateral luxation, it's 4 weeks, right? Then, of course, this again, isolation, we've done in great detail. Exactly this clamp was there. This clamp was there, guys, right? And this clamp is an anterior clamp, right? In your, when you have the similar clamp in your Hugh Freedy company, it's known as number 212 clamp. This, of course, is from hygienic, and the number may vary, but this is an anterior clamp, right? So this is used for isolation of anterior teeth. This is a simple question, right? I always do this in my preps, in all my lectures. Right, guys? Wonderful. हाँ बेटा बताओ कौन सा बेटा डायग्राम हाँ ये टफ था ये this was really tough. That soft dentine question was tough. I had to actually look for the correct answer in this. A tough one, guys. But it's tough for everybody, guys. So I mean, don't get disheartened. Just keep studying hard, guys, and just realize, be proud of yourself. You've already done your BDS, you're preparing for it, you get selected, wonderful. You don't, you keep working hard. You have to keep the faith, guys. Keep taking your God's name. That's what I do. That's what I always tell all my students and friends. And we can only do what we can, right? So just keep your spirits high. And best wishes, guys. Thank you. Right. Thank you, guys. Take care. Beta molar thodi nami. This is anterior. Molar clamp is shown this to you in the class on, I think, were you there in the last class just before on that day of Navratri? Don't worry. I'll share that in the group, the different types of clamps. They always ask this one question from the clamps, right?
So, hello and good evening, dear students. I am Dr. Ruchi Raj. I am your original guru for Prosthodontics, and I welcome you all to the mega recall session of INI-CET November 2024. We'll wait for a few seconds till all other students can come back and we can start the discussion for Prostho. So, how was the paper for all of you? So I'm checking your messages live on the YouTube chat, and as of now, what I have gotten to know after interaction with students and from the initial perception of the paper, it seems like a moderate to tough paper to me. Prosto, however, was moderate. What was expected, we have got the same as well in this particular INI exam. Let me know your thoughts. How was Prosto for you? Good evening, everyone. Good evening, all dear students. Okay, so Verika is saying very hard paper. Yeah, I understand it was quite a tough paper, not very previous year questions or straightforward questions. But just now, few minutes back, in one of our recall groups, a student very well mentioned that this time INI just picked up 2-3 questions from the same topics. That is what INI is. The emphasis is on previous year topics rather than previous year questions. And then you will see very similar interconnected questions coming from the same topics. A lot of students, Adya, and even sort of lot of students are saying it is a tough paper, but Prostho was comparatively easy. So I hope you were well prepared. That is why Prostho was easy for you. And as expected and predicted in all of our previous sessions also, what I've said, complete dentures, partial dentures is always conceptual. I have put emphasis on centric relation a lot of times. Tell me yes or no in the chat box down below. And we found a very good question on centric relation this time in exam. Implant was very straightforward. Rest all was very straightforward. Whatever was conceptual came from CD and RPD. So the essential pattern of Prostho remained the same, which is conceptual questions from complete and partial denture, straightforward questions from all other topics. Do you all agree with me or not? Right? So let us start with the first question here now. Let us tackle our image-based questions first. And yes, a lot of students are agreeing over here. So for the image-based questions, the first question showed a model or a cast, upper and lower models, and there was an assembly attached to it, and you were asked to identify what it was, whether it is an intraoral tracer, extraoral tracer, either is it Fox plate or something pertaining to tech scan. So the correct answer over here is actually intraoral tracer. But in contrast to what classic intraoral tracer metallic plates would look like, this looked like a custom intraoral tracer that was fabricated for that particular patient. I even went through a lot of articles. These images are not my own, they've been taken from the internet. But what I have gotten to know is there was the tracer looked like made out of resin material, a blue resinous material. So could be something that is custom made for the patient, and that was an image. But what we can use to identify is that there was a tracing device that is placed within the cast only. There is no bearing plate that is extending outside. So all of that gives us good piece of information to identify that this is an intraoral tracer, which is used to record centric relation. Tell me, students, were you able to attend and answer this confidently, or did you skip this question? So first question, an assembly was seen on the cast that is attached. That assembly is an intraoral tracer that is used to record centric relation. This is a method of graphic tracing of CR. So what actually we have said previously also, two questions actually from centric relation. This is from graphic tracing. We have another question at the back. This is what actually happens in INI a lot of times. Now, second question, I had to pull back my postgraduate album so as to get this image. There was a machine shown, some green liquid or material was flowing out of it, and you were asked to identify what it is. Well, this is actually, this machine is called as Gelbat Mestra machine. This machine is used to process, or this machine is used to manipulate agar so that it liquefies, and then with the help of this mold that you see over here, you have your cast inside, so you can duplicate the cast. So the correct answer to this is agar, and it is a duplicating medium or a duplicating method for duplicating your cast, master cast, and make a refractory model out of it. So this particular machine and the green liquid that was coming out of it, it was agar. I'm not too sure on the exact format of question. If the machine was asked, it is a Gelbat Mestra, but I'm sure the material was asked here. So the material in the picture was agar. It's just that because of the machine and everything, you might be a little confused. Now, just an extra piece of information here. If it is silicones come into different materials, two different consistencies that you have to mix and then manipulate. So you won't require an armamentarium like this for silicon. This is only required for agar. So in a way, an easy question, but obviously it is iodized, so they'll make it different for you. Now, the third question from cast partial dentures. Actually, the image that was there was that of a mandibular cast, and the surveying arm was near the heel of the cast. We could also see 3 dots on the surface of the cast. That is the information that I have. So on the basis of all of that, what I can understand from the image is, this is the process of tripodization. Now, when we do surveying and we take off the cast, and when we have to do resurveying of the same model, we need a way to identify or remember the angles at which we had fixed for that cast. That is done by marking 3 widely spaced points, which is called as tripodization. And that is what was done in the particular image. The other options were estimation of guiding plane, block out, or duplication. But obviously, they were not the correct answer. So by looking at those 3 dots and what I saw at the heel of the cast, I can confirmatively say the answer was tripodization. Now 3 questions. We have total of 10 questions for Prostho. Tell me, students, any doubts, any queries, any questions, and were you able to answer this? So were you able to answer this? We can take a 10-second break over here. Just use little bit of common sense. That is what I felt while, just a second, sorry. That is what I felt while solving these questions, that they were from the topics that you know, but they were a little offbeat. So if you are in the stress of the exam, probably there's a chance you might make a mistake, but that is what INI is at the end of the day. Right. So no doubts. Now the 4th question that came in, it was from implants, and the image was that of a mandibular impression, and there were bilateral molars missing. Implant was placed, there was an impression coping, and there was something over it, and you were asked to identify that. Am I right? Was this asked to you? Because that is what I know, that this was asked. Now, the exact way in which I perceived that particular image was that it was a top view. So very difficult to identify actually what it was. As such, it is an easy component. That is why I've kept the second image here. So as you can see here in the second image, over the closed tray impression coping, what structure is attached? This structure which is attached here, this is implant analog. But why was it tougher in the exam? Because a top view like this was shown. So you could just see the top part of it, which made it slightly difficult to identify that it is an implant analog. The question was pertaining to bilateral molars, missing molars. So 4 options were there: implant analog, closed tray impression coping, implant abutment, and implant. The correct answer to this was implant analog. We have discussed all of the components, I think, several times while doing our classes. So I hope you were all able to solve this question. Let me know if you're not able to, if there's any doubt. I'm pretty sure all of you would have been able to solve this. Now, this is a question that actually overlaps oral surgery and prostho both. A patient has a history of CABG, operated before 3 months for the same. On examination, there are 3 to 4 periodontally compromised remaining teeth. This is the keyword over here, a key piece of information. Treatment plan for this patient should be what? Overdenture on the remaining teeth, extraction and complete dentures, extraction after 3 months with interim prosthesis in the meantime, or extraction after 1 year with interim prosthesis in the meantime. Now, the key piece of information, first, history of CABG, operated before 3 months, periodontally compromised remaining teeth. What is the treatment plan? So what I understand from this is the standard window period for any elective surgical procedure after such an operation is 6 months. And the history is saying 3 months. Second piece of information is these teeth are periodontally compromised. Once they are periodontally compromised, you will not make an overdenture over it. So considering all of this, first option goes out because you can't make overdenture on periodontally compromised teeth. You cannot do immediate extraction. You have to wait for another 3 months and give an interim prosthesis in between. So option number C is the correct answer here. Some applied knowledge, but still an easy question comparatively. So extraction after 3 months with interim prosthesis in the meantime. Very good question. Actually, very good questions in this INI exam. And coming on to question number 6. Now, we have stressed upon direct retainers a lot while teaching cast partial denture. And this was a very straightforward fact-based question. In the case of infrabulge clasp, infrabulge means the one that is below the height of contour, one that originates below it. Extension of the proximal plate is what? So you have an infrabulge clasp like this that comes, and there is a proximal plate here. What is the extension of it? Theoretically and ideally, in all of the cases, extension of proximal plate is from the marginal ridge up to the junction of middle and gingival third. Now, as far as I recollect the options, these were the options: entire length of primary abutment to distribute the stress, up to the middle third, up to the gingival third, and depends on dimension of proximal plate. Out of all of this, I feel that option number B, up to middle third, because that is applicable in all of the situations, ideally in infra-bulge class. So that should be your correct answer. So question number 6, option number B, up to the middle third, because up to gingival third means that you are going till here. Then what relief are you giving? So relief is actually needed in the gingival third. So question number 6, my answer will be option number B, up to the middle third. Ideally, it is up to middle and gingival third junction. So when you say up to middle third, it means that junction only. So 6 would be B. Christian, Uma, why do you feel answer should be C, up to gingival third? Do let me know your thoughts in comments. So it should be up to the junction of middle and gingival third. I re-verified it actually. In your McCracken's, there is a straightforward line in your McCracken's from the marginal ridge to the junction of middle and gingival third. There is the extension of proximal plate. Of course, there are variations in proximal plate where even it covers the entire surface, but that is not applicable in all cases. That is why answer is option number B. Now, discussing one of the most toughest questions, I think, and we have a very good recall of this question, considering that it was something that a lot of students could not even comprehend. So I would say very good efforts of even our backend team and doctors so as to bring back these questions to us for discussion. So students, yeah, I see a lot of, let us go to the previous question. A lot of students are discussing in the comments, why not option number A? So Shivam, I agree with you. Option number A is correct. It is a modification of proximal plate, but not applicable in all cases. So it is definitely given in McCracken, but it is not applicable in all cases of infra-bulge class. So even I opened up my McCrackens today afternoon and I saw it. And when you describe infra-bulge class, the standard straightforward line that is written is from the marginal ridge till the middle and gingival third junction is where proximal plate will come. But in some cases, you can extend it throughout the surface when you want the abutment to take up more load. So what is done in some cases cannot be applied to all. That is why I've kept my answer as option B. It is definitely not till gingival third. So a lot of students saying option number C as the answer. That is not correct. So this is my answer for this particular question. I will share my references with you in our Telegram group so that you can have a look at it. So I hope doubts are cleared pertaining to this particular question. Can we go ahead? Can I get a little thumbs up or something? We can go ahead from question number 6, or still there is any doubt or any query. Now, okay, let us take about 20 seconds. Let me go through the chat, see the different questions that you are asking. So most of you are saying it is easy to moderate. A lot of you are agreeing that yes, it is intra. So some student asked, why is it not extraoral tracer for the first question? Because the recording plate is not actually beyond the cast that we see in the extraoral tracer. It is within the assembly of it, right? Now, some students are saying, why not coping? It was not coping. It was specifically implant analog. We could identify it from the image that it is analog. The only thing that made it difficult was the top view, which was making it difficult to identify it was implant analog, but I'm 100% sure I confirmed it with other clinicians also. It was implant analog in the image, that we are 100% sure. So answer was implant analog to it. It was not coping. Now, yes, so let us thumbs up from us. Let us go to question number 7, the most controversial question from this particular segment of Prostho. Not controversial, slightly tricky, but I'll tell you. I have taught you CR, CO, MIP and everything. You are capable of answering this question if you just take a deep breath and try and solve it out. So let us read the question. When fabricating the restoration, the mandible was indirectly forced back when recording centric relations. So this, when you do pressure at the chin, the jaw will go in retrusion. So when you do the jaw position in a retrusive manner, what happens? Resulting implications are what? There will be discrepancy in anterior-posterior direction and not in superior-inferior direction. First, let us understand what the question is saying. So when I do chin pressure or forceful retrusion of mandible, the mandible will go behind but it just does not go behind. It will even go downwards. That is something that you need to understand. When we push the mandible forcefully and forcefully retrude the mandible, it will go behind, but it goes slightly downwards also. That is what happens. Now let us look at the options. There will be a discrepancy only in anterior-posterior direction and not in superior-inferior. That is wrong, because when the mandible goes downwards, it will introduce discrepancy in the superior-inferior direction also. Option number B, the resulting restoration will be in supraocclusion as condyles are not seated superiorly. They have moved backwards and downwards. This here is the correct answer. Option number B is your correct answer, and I'll explain you why that is the correct answer. When you push the mandible backwards forcefully and retrude it, not only goes backwards, but it goes downwards also. When it goes downwards, the amount of clearance or occlusal space that you get increases. Hence, the restoration also you make on it will be of slightly larger height than what it should have been. When it is seated actually in the patient's mouth at the correct centric relation, it will be in supraocclusion. So that is the correct statement. The other statements were that resulting restoration will be in infraocclusion or will be in best intercuspation, but that is wrong. Correct answer was option number B. Now tell me something, how many of you were able to attempt this? And now do you understand the answer to this question? We'll take a 10-second gap here. But now are you able to understand? All of our students who have joined, and we have over 90 students here at the session. Are you able to understand this question now? Now, there question number 8. Yes, so a lot of you agree that yes, now you are able to understand. So that is it. It was a simple question, but you just need to understand the mechanics. Still, I would say a very well-formed question. And see, this is what happens in INI-CET, that same topic, centric relation, 2 questions have come from it. So that is how it becomes INI-CET, right? Now, question number 8, there is a single edentulous area with optimal periodontal health of remaining teeth. No need of prosthetic treatment was mentioned in the options. Missing 1 molar and 1 premolar, class 1 maxillomandibular relationship and optimal occlusion. You have to classify this. Armani class 1, Kennedy Applegate class 1, Kennedy Applegate class 2, and Prosthodontic Diagnostic Index class 1. Correct answer is PDI class 1. PDI was given by ACP, American College of Prosthodontics, and it is there for completely edentulous and partially edentulous also. I pulled in a slide from their website only, where class 1 relates to this. It is an ideal or minimally compromised partially edentulous area with either 2 teeth missing anteriorly in mandible or maxilla, or either 1 premolar and 1 molar missing posteriorly, or 2 premolars missing posteriorly, and class 1 occlusion is present. So all of the description that has been mentioned in the question corresponds to PDI. Now, do you all remember that when we did cast partial dentures, I used to tell you, keep an eye on different classifications. It may be possible questions may come out of it. That is what have happened. Now, PDI has come into the exam. There are still, I think, McCracken's has a lot of other different classifications. There is a photo there. That is why I asked you, keep an eye on these classifications also. We will cover it in our upcoming live sessions that we are doing at the end of the month. So a good question. Probably if you have not read it, chances are you might not able to answer it, but I'll tell you the trick. You know Armani is for maxillectomies. You know Kennedy Applegate class 1 and 2 is not applicable here. The only option left is option number D. So if you know the other 3, which you have done in our classes with us, then you can take a calculated guess that the answer was option D. So tell me how many of you took this guess now. And on to question number 9 now. Implant pilot drill dimensions, very easy question, straightforward. The implant pilot drill is of 2 millimeters. That is used for the first niche that you put. The pilot drill, 2 millimeters is the answer. Students, are you able to follow? Let us take a few seconds here. Are you able to follow this? And from this particular question? Is there any doubt here? And tell me, how many of you actually attempted the correct answer here? Let me know in the comment section. Now, question 9, as I said, implant pilot drill. Answer is 2 millimeters. And last question regarding bone tapping. Now, those who have seen all of my live sessions, GT discussions, GT papers have been attempted, even the free sessions that we do on YouTube. Bone tapping is something that I've discussed time and again because somehow I feel that it will come in the upcoming exam. It did come in this paper. So bone tapping is needed for implant placement in which of the following conditions? This question was there in our GT papers. For INI GT papers, I've even added in our NEET GT papers. We have done and discussed it in our live sessions also. Options were dense bone, osteoporotic bone, demineralized bone, resorbed bone. This was even there in our notes also, where I mentioned in D1 dense bone, bone tapping is necessary and it should be done. So I hope you all were able to attempt. The correct answer was option number A, dense bone. What happens is that a dense bone, when you drill through it, the temperature of it would increase because of friction. So you need to do something which is called as bone tapping, where you prepare the osteotomy site in such a way that insertion of implant becomes easier by tapping. So that is the correct answer, which is option number A. That brings us to the conclusion of the recall session for prosto. Overall, I feel prosto questions were doable, barring one question on centric relation, which I feel was a very good question, and even the PDI question also. Apart from that, they were doable. Something that if you have your concepts correct, you would be able to do it. So I hope this session was useful for you and you were able to attempt all of these questions. If you have any doubts, any queries, any suggestions, please drop them for me in the chat box. You can connect with us on Telegram. And this is me, Dr. Ruchiraj, wishing you all the very best for your results.
Yeah, good evening, everyone. Yeah, first of all, before starting up with the session, you people must be all relaxed after giving the exam. So before starting up with the session on biochemistry, I just wanted to ask the feedback because I'm seeing so many, like WhatsApp group is flooded with so many questions. And this time biochemistry had like quite weightage, like some 9 to 10 questions were asked from biochemistry. So how did your exam go? I can't see any of the students here. So how did your exam go? Because there were some 9 to 10 questions from biochemistry. Let me just open my this link. Yeah. Yeah, good evening. Good evening, Neelu. Tough. Why they were tough, Nami? I think most of the questions we had already covered in the class, isn't it? And yeah, okay. Most of the questions we had covered in the class, isn't it? And I told you that this question might be asked in the exam. No doubt, if we talk about this, yes. No doubt this time no question from enzyme side came. In fact, I was so much, I was thinking that the question might be asked on competitive and non-competitive inhibition, but there was no question asked from that. Acha, Hansika, yeah, I had gone to visit Lahaul Spiti. It's in Himachal. So I had sent good this best of luck wishes from there, sitting at a very high altitude, so that you people also should rise high. And I was expecting that this time you people are going to get good marks in Biochem at least. Okay, so let's start up with this mega recall session. Right. Now, if we look at question number 1, see, so many times before taking up this question only, I've been discussing about hypoglycemia, hyperglycemia, because this is all biochemistry is all about this only, isn't it? And I've told you clearly how you have to understand. Hypo money when the concentration decreases, hyper money when the concentration increases, isn't it? So hormone causing hypoglycemia is, okay, that means which is decreasing the concentration of glucose. So what will be your answer? And this is a very interesting question and a very simple question, I would say. Isn't it? What all you have answered? The options are insulin, glucagon, epinephrine, and growth hormone. But here, clear cut, the answer will be insulin, isn't it? Why insulin? Yeah, and it's a straightforward. Yes, very good. Yes, correct. Why it is insulin? Because we all know that if we talk about glucagon, if we talk about epinephrine, yes. And if we talk about growth hormones, they are always released when the concentration of glucose is less. So they will try to increase or they will try to bring hyperglycemia. Isn't it? So here the straightforward question is answer is insulin. Yes, very good. So all of you got this 1 mark correct. Chalo, congratulations. Right. Then moving on to question number 2. This was little bit away from your track. Okay, DNA methylation in eukaryotes is done by. But chalo, let me ask you ki what all you have answered so that I can give up my answer. But basically, what is this DNA methylation? It is actually a epigenetic modification. Normally, the question in the past years have been asked only on post-transcriptional modification. This is after replication, epigenetic, above that. Okay, so what happens is DNA is actually methylated at the cytosine residues. Cytosine residues, beta, C. Yes, very good, Ruby, very good, Harmandeep. So, yes, cytosine, not cysteine, beta, it is cytosine. These are what? These are the nitrogenous bases, purines and pyrimidines. Adenine is there, thymine is there, guanine is there, and cytosine is there. So basically, it is rich in CpG islands. Right. So what happens is C cytosine residues पे methylation हो जाती है just to demarcate it from the rest. So this is a kind of epigenetic modification which is very important in eukaryotes. Right. So here the answer is cytosine. Is it clear? Option will be D. Not cysteine, beta. Cysteine and amino acid, don't forget. Cysteine is an amino acid. This is cytosine. Cytosine, which is a pyrimidine, which is required for basically methylation during modification of DNA after replication. Right? Then moving on to question number 3. End product of aerobic respiration is. Yes, very good, Moin. It is cytosine. Now let's look at question number 3. End product of aerobic respiration. Ab now see, yahan pe students, you people might get confused, isn't it? Because actually the end product of aerobic respiration, you know what is the end product? It is carbon dioxide and water. But surprisingly, carbon dioxide and water are not given in the options. Okay, so here the best possible answer will be pyruvic acid. Yes, this is the only best possible answer. Why? Because if we talk about succinate, we know succinate, oxaloacetate, and malate. These are all intermediates of TCA, isn't it? Intermediates of TCA cycle. So we can simply say, because one molecule of glucose will simply undergo glycolysis producing 2 molecules of pyruvic acid. That is a separate thing. Ki what happens to pyruvic acid, right? Pyruvic acid can react in the presence of oxygen. Yes, Moin. Because otherwise it is not an end product. We can say that ki the product of aerobic respiration. So we can say in the absence of oxygen that it forms lactate, and in the presence of oxygen it forms acetyl coenzyme which enters TCA cycle. Isn't it? So here the best possible answer is A. Always remember. Glycolysis, so answer won't change. Yes, you are right. So that is what, Krish, that's what I am saying. Ki as per this question, the most possible answer is pyruvate. So if you people have gone for pyruvate, you have got it right. Right? So those students who have opted for A, they should actually dance ki their answer is correct. Right? But in general, I'm telling you ki what happens actually in aerobic respiration. Because you remember, pyruvic acid undergoes a link reaction, isn't it, to form acetyl coenzyme? Clear? Then, now coming over to this question, I don't remember that so many times I have told you about this particular question. If you people have attended my classes regular basis pe and seriously, isn't it? Entry of glucose in adipocytes is by. And yahan pe to the question should be in your, you know, at the tip of your tongue. The moment you would have seen this question, you could have opted for the correct answer, isn't it? So what you have gone for? Yes, it is GLUT4. And so many times I have told you about this particular question in the class. This question might be asked. And you know, one very important, yes, the most important point about this is that this GLUT4 is dependent on insulin. Insulin dependent. Yes. GLUT1 is for RBCs. GLUT2 is for beta cells of pancreas. GLUT3 is for neurons. Yes, very good. Pranjal, yes, this is the mnemonic which normally I discuss in the class. Very good. I always say GLUT4 is for has. Yes. Has is for heart, cardiac muscle. A is for adipose tissue, the adipocytes. And S is for skeletal muscle. Very good. Right? So the answer is GLUT4. Yes, very good, Neelu. Yes. Right, then coming over to the next question. All can be derived from acetyl coenzyme A except. Okay, now if we talk about this question, all can be derived from acetyl coenzyme A. What are the things which cannot be synthesized from acetyl coenzyme A? We know that this pyruvic acid synthesizes acetyl coenzyme A, right? This acetyl coenzyme A is converted to form fats or TGs, right? This acetyl coenzyme A is required for the synthesis of cholesterol, right? And this is required for the synthesis of ketone bodies. ऐसा क्वेश्चन नहीं था पॉलीक्लिनिक, तो व्हाट वाज द क्वेश्चन, व्हाट वाज द ऑप्शन, या व्हाट वाज द क्वेश्चन? Okay, so all can be derived from acetyl coenzyme, only glucose cannot be derived. Always remember. And we always say that carbohydrates are converted into fats, but fats cannot be converted into carbohydrates. And that is why we say that acetyl coenzyme A is not a glucogenic substrate. Yes, cholesterol, beta, cholesterol is derived from acetyl coenzyme A, isn't it? Because I told you that this acetyl coenzyme A is the precursor of ketone bodies as well as cholesterol. If you remember that reaction. The only difference is this acetyl coenzyme A produces ketone bodies in the mitochondria. Acha, question was what can't be directly derived from acetyl. So yeah, chalo, let's put it that way ki what cannot be synthesized from acetyl coenzyme A directly, it is glucose. Okay, we'll correct this question. More or less this thing is the same, only the format is different. This question is also saying that all can be derived from acetyl coenzyme A except glucose. Or jaise Nami is saying, so we can put it that way also, ki what cannot be directly derived. Okay, so you can simply say glucose. And always remember that glucose is never directly synthesized from acetyl coenzyme A. Right? So here the option is D. Clear? Then coming over to the next question, enzyme deficient in SCID is. Now, what is SCID? It is severe combined. This also I have discussed in the class. Severe combined. Can anybody tell me what is the full form of SCID? Okay. This also I have told you in the class. It is severe combined immunodeficiency syndrome. And what happens here? Which is the deficient enzyme? I don't know what was the fourth option. Can anybody tell me what was the fourth option? First was ADA. ADA stands for, yes, adenosine deaminase. Yes. And this ADA converts adenosine monophosphate into inosine monophosphate. Okay. HGPRT is hypoxanthine guanine phosphoribosyl transferase. It's an example or enzyme of salvage pathway. Acha, fourth option was aldolase. Okay. Right. Okay. Xanthine oxidase. Xanthine oxidase is an enzyme of degradation of purines. Right. And aldolase, to वैसे भी it is an enzyme of, it is a splitting enzyme of carbohydrates. So here we can simply say that any adenosine deaminase deficiency leads to SCID. There is defective formation of B and T cells. Okay. So here the answer will be simply A. Adenosine deaminase, which converts adenosine monophosphate into inosine monophosphate. Right? This question also we have discussed in the class. This part. Then moving on to this question. This question, beta, you have to tell me the options because I am little bit, confused about this question. Enzyme deficient in urea synthesis. Can you just tell me what kind of terminology was used in this particular question? Enzyme deficient in urea synthesis. No doubt, if we talk about CPS1 and OTC, these are the two enzymes of urea cycle. Okay, if we talk about methyl malonyl mutase, it is not an example of urea cycle, nor is CPS2. So can you just tell me what was the format of this question? If we say enzyme rate limiting in urea synthesis, then it would be CPS1. If we talk about enzyme deficient in urea cycle, in hyperammonemia type 1, then also it is CPS1. Acha, language was somewhat like this. Acha, inhibition of what enzyme will cause defect in urea synthesis? Then if Ruby has written this question, inhibition of what enzyme will cause defect in urea synthesis? So here we can say that it has to be the rate limiting enzyme, isn't it? So the rate limiting enzyme is CPS1. Since this is a rate limiting enzyme, so if this enzyme is deficient, urea synthesis will not take place, isn't it? Because this is the first reaction, if you remember, that ammonium ions combine with bicarbonate ions to form carbamoyl phosphate. Right? So obviously, if this enzyme is deficient, concentration of this will increase and no urea cycle will be there. Urea cycle or no urea synthesis. Right? Got my point. So here the option will be CPS1. Because we know that if we talk about CPS2, carbamoyl phosphate synthetase 2, it's an enzyme of pyrimidine synthesis. OTC is an enzyme of urea cycle, but it is after carbamoyl phosphate. Okay, this is the second enzyme. So as per this question, the answer will be this. Am I clear to all of you? Any confusion in this? No confusion, everything is clear? So shall we move to the next question then? Okay, then the next question is a very simple question, and this question you people, this question you people are studying from class 9th or 10th. Pernicious anemia is due to the deficiency of this vitamin. Such a simple and such a easy question. What will be your answer? It's a direct question. Okay, it's clear. It's a straightforward question. We all know that pernicious anemia is due to the deficiency of B12. Yes. So यहाँ पे तो without giving a second thought, your answer should be this. And I hope all the students must have got this question for sure correct. Niacin deficiency leads to pellagra. Yes. Thiamine deficiency leads to you can say beriberi. Riboflavin deficiency leads to 5 things. Chelosis is there, stomatitis is there. But here it is clear that it is cyanocobalamin, which is none other than B12. Yes, because B12 is used as a coenzyme in so many reactions, and so many reactions we have also discussed in the class. So I hope this question you all got right. Clear? Then moving on to the next question. Primary immunoglobulin secreted or activated after vaccination. This is a question from microbiology actually, isn't it? But chalo, which question you have marked here? Because whenever we talk about the primary immunoglobulin, which is immediately activated after given a vaccine, it is what is the primary immune response generated by the body. So always remember, it has to be IgM. Okay, otherwise this is a, yes, Krish, you are right, it is IgM. First of all, IgM is released. Yes, so all of you must have got it correct. Yes. That's all. So these were the questions from biochemistry. Yes, IgM. Now, any other question, if you people remember about biochemistry, so you can ask me now. Anything which is left, which is not, included in these slides. And if you have any doubt, the question was this, the answer was this, so you can ask me. So I think there were some 9 questions this time from Biochem. Earlier, there were only 2 to 3 questions which were asked from Biochem. This time, 9 questions have been asked from Biochemistry. So, and all the questions are simple. If I have to give the analysis about Biochemistry recall, these are very simple questions. Only one question has been asked, that is DNA methylation. Otherwise, all the questions are very crystal clear and very simple, isn't it? And this time, yes, no question from glycogen storage disorders were there. No question from enzymes also was there. But this part was clear, right? So if you guys have any other question, if you guys have any doubt in your minds, so you can just speak up now so that I can resolve your doubts. Yeah, they were very easy. That's what I'm saying. And I hope you people get good marks in Biochem, full marks in Biochem. So if you don't have any queries, if you don't have any questions further, can we wind up the session? Yes, that's what I'm saying. Yes, Gautami, yes. Gautami has been a very sincere student and I would say very disciplined student and very intelligent student, isn't it? Nami also, yes. I don't know you people by names. So, yes, Moin. So, I hope this time you people crack this exam. So, wishing you all the best for your result. Yeah, my pleasure. So, shall we wind up the session? Okay, thank you so much. And wishing you all the best for your results. May you guys clear this time. Okay. Bye-bye. Take care. Yeah. Bye. Yeah. Thank you.
Okay, friends. So, welcome to the oral surgery questions discussion. I will just open up my YouTube so that I can read your questions also. All right, I can see. Okay, so yeah, so I've written a hi so that I'm sure that I am also live. So, starting with how was the questions of oral surgery? Look, the questions were really difficult. All right, even the topics which are commonly asked, even from them, none of the questions were straightforward, except maybe the Ludwig's angina question was straightforward. Otherwise, most of the questions were difficult. They were tweaked. The options were difficult. And I will really call it a difficult paper. If not extremely difficult, it was difficult. There were article-based questions, there were arthroscopy-based questions that could be guessed but could not be answered for sure. And honestly speaking, even I took time to read through articles and confirm the answers that I had marked just to be sure that my answers are correct. So they were really tough. Let's start with the questions. So the first question that came was, which of these is a safe distance or a safe dissection area in the TMJ surgeries? Okay, and the options were like these: 8 to 35 millimeter from external auditory meatus to 2 centimeter above the lateral canthus, and other options. Okay, now first let me tell you the correct answer to this question is option C, which is 1 centimeter from EAM to 2 centimeter above the FZ suture. Now, to explain this question, we have to go to the anatomy of the facial nerve. Okay. As I've always told you that whenever we perform any surgery in the vicinity of the facial nerve, whenever we are doing any parotid surgery or TM joint surgery or condylar fractures and we are using the preauricular incision, we have to take extra care of the facial nerve. Okay. Now, as we know, the facial nerve terminal branches, they come out of the stylomastoid foramen, get into the parotid gland and exit the parotid gland as the 5 terminal branches. They are the temporal, zygomatic, buccal, and your marginal mandibular and cervical. Now, when you are doing the TMJ surgery, the zygomatic branch is especially at risk. All right, the zygomatic branch is really at risk. Okay, so the upper branch and the lower branches. So this is the facial nerve. It goes into an upper branch which gives the temporal, zygomatic, and upper buccal branches, and the lower branches which give the lower buccal and your marginal mandibular and cervical. Now, this is our safety triangle which extends up like this. Okay. Typically, the distance from the most anterior concavity of the external auditory canal, okay, that is here, to the most posterior significant branch of the temporal branch of the facial nerve, temporal branch, is 0.8 to 3.5 centimeter. What does this mean? This means that, see, anatomy is not exactly at the same distance in every person. All right, in some people it may be 0.8, in some people it may be 1 centimeter, or 1 centimeter is 10 mm, so 8 mm, 10 mm, 12 mm. So there is variation. Okay, the first significant branch of the temporal nerve can be anywhere between 8 to 3.5 centimeter, that is 8 mm to 35 mm anterior to the external auditory meatus. Okay, so if I am going to give a preauricular incision for TMJ surgeries, okay, and using that preauricular incision, it can be Heinz, it can be Popovich and Crane, it can be Alkayat Bramley, whatever incision I am giving, when I am dissecting in the preauricular region, my dissection should be less than 8 millimeters. It should be less than the first chance of having the facial nerve. All right. So it should be under 0.8 centimeter or approximately under 1 centimeter. That is what the question is asking. And what is the upper limit? The upper limit is the frontozygomatic suture. You can go up to 2 centimeters above the frontozygomatic suture. This is the FZ suture, where the frontal bone and the frontal process of the zygomatic bone fuse. So somewhere here is the frontozygomatic suture, and up to 2 centimeter you can go up. So that is what the question is asking, that based on the anatomy of the facial nerve, what is this safe area in which you can do your dissections? So safe area has to be before the terminal branches of the facial nerves start. They start from 8 mm and can go up to 35 mm. So you have to be under 8 mm, or on an average you have to be under 1 centimeter from the external auditory meatus. Alright, so that is the correct answer. A lot of times, even when I was reading this question, first thing that came to my mind was, yes, 8 to 35, because that is the value we learn. Even when you're doing post-graduation in oral surgery, when you're actually opening up the temporomandibular joint, the first thing that strikes to you is that 8 to 35 pe facial nerve hai. Question is asking, what is the safe dissection area? That means where you don't have to go. So you don't have to go beyond 8 millimeters. So you should be within 8 millimeters, or average speaking within 1 centimeter from the external auditory meatus. Definitely it was a difficult question. I would be happy if you have left the question, because you cannot guess this question. You cannot judge this question based on any logic or any fundas. If you know it, you know it. If you do not know it, you should straightforward leave such questions. So this was one of the questions which was meant to be left. It was really difficult, very, very factual, and honestly speaking, you won't even find these answers in standard textbooks also. These questions are based on articles, based on some man or some standard articles that you refer when you're actually learning oral surgery. So this is an article-based question, definitely difficult. Okay, coming to question number 2, again an article-based question. Which of these is not a treatment alternative for enucleation and odontogenic keratocysts? Cornoid solution, definitely we know cornoid solution is used in OKC. Peripheral ostectomy, yes, you do peripheral ostectomies in OKCs. Now there are two confusion is between 5-fluorouracil and pre-operative radiotherapy. If I talk about articles, definitely people have tried this anti-metabolite drug, which is 5-fluorouracil. It is not common. Definitely not common. What is common is transnasal calcitonin sprays, intralesional steroids. This is the commonly used clinically, practically, theoretically, most commonly used things. But examiner has not asked topical steroid or intralesional steroid. Examiner has not asked transnasal calcitonin. He has asked two article-based things, which is 5-fluorouracil and preoperative radiotherapy. Now, the correct answer is 5-fluorouracil is used. Radiotherapy, if at all is done in OKC, is always done post-operatively. It is always done as a post-operative therapy, mostly in those cases which have turned malignant. There have been a few case reports where OKC has undergone a squamous cell carcinoma transformation. So in such cases, post-operatively, radiotherapy has been used. So the correct answer for question 2 is D, post or pre-operative radiotherapy. Okay. Quickly telling you about 5-fluorouracil. Again, it's an article-based question. So I've quoted the article. You know that it's a patch gene mutation, which was also a question asked in this exam. So there is a patch gene, which is a tumor suppressor gene, and there is mutation in this gene, which is supposed to be, you know, the cause for odontogenic keratocysts and nevoid basal cell carcinoma syndromes. And so 5-fluorouracil has gained attention in OKC management. It's an anti-metabolite drug. You usually, study about 5-fluorouracil in cancer treatments when you study pharmacology. And it targets proliferating cells. So like cancer cells are very fast proliferation rate. Just like that, they target the proliferating cells. And it is used for treatment of basal cell carcinoma. See, you remember BCC is also a component of nevoid basal cell carcinoma syndrome, which causes OKCs also. All right. So based on that also, you can correlate that, okay, BCC is OKC also common in BCC, nevoid basal cell carcinoma syndrome, and both have association with the patch gene. So how we use 5-fluorouracil, I mean, we have never used it, but how people use it is they take a Sergi cell or a collagen sponge, They dip the drug in that collagen sponge and they fill the cavity, fill the cystic cavity with that sponge, the collagen sponge, which is loaded with 5-fluorouracil. That is how you have a local application. It's not through an ointment or gel, but it is through that collagen soaked sponge which you put into the cystic cavity, and that is how there is a local application of this drug. All right. So 5-fluorouracil is also used in OKCs, but preoperative radiotherapy till now has not been used. So that's again a difficult question. Still, I would say that you could mark this question because you could rule out option A and B. I mean, almost all of you must have ruled out that cornoids is used, peripheral ostectomy is used. It's just between C and D. So those who have done that calculated risk and marked option D, you guys are correct. All right. Okay. Coming to question C. Okay. Here, it's not a difficult question if you know the meaning of dicapitular. If you know the meaning of dicapitular, you marked it correctly. Okay. Which of these types of condylar fractures have the highest chance of formation of ankylosis in skeletally immature patients? What is the meaning of skeletally immature patients? Means growing patients. We all know, and there was a question also, that the chances of ankylosis are more in pediatric patients compared to adults. Okay. Because they are growing, they have more osteogenic potential, and we'll come to that question. But which of these condylar fractures has more chances? Okay. Is it all types of condylar fracture have equal chances, or the subcondylar fracture, or the green stick fracture where only one cortex is fractured and there is slight bending, or the dicapitular fractures? What is the meaning of dicapitular? The meaning of dicapitular is head. The most common theory that we read about TMJ ankylosis is the condylar burst theory, right? We've read about condylar burst theory. It's there in our notes, it's there in our videos. So what the condylar burst theory says that there is impact on the condyle due to trauma and the condyle bursts open. Because of that bursting open, the inner callus part or the cancellous part or the marrow part, which is rich in osteogenic cells, which is rich in osteogenic potential, that is exposed. And that causes ossification and ankylosis. That is why whenever there is a head fracture, the chances of condylar burst, the chances of the marrow spaces being exposed is the highest. All right. So the correct answer to this question is the dicapitular fractures, which are nothing but the head fractures. Now, this is actually cheating. Asking such a question to a NEET aspirant is cheating. But just in case you knew that dicapitular fractures means head fractures, head of the condyle, it is, you would answer it. Okay, so that's the correct answer. All condylar fractures, no. Why would a subcondylar fracture have an equal chance with a head fracture? This is the joint, right? And subcondylar fracture is away from the joint. Why would a subcondylar fracture have equal chances of ankylosis? Similarly, why would a neck fracture have equal chances? A head fracture will have maximum chances, right? And head fracture means dicapitular fracture. Okay. Similar question in pediatric patients in comparison to adults. All of these are reasons for increased chances of TMJ ankylosis, except this is also not very difficult. It was moderate. It was easy to guess. You could make a calculated smart guess here. Bulbous condylar head with increased marrow content. Correct. If you see a pediatric condyle versus an adult condyle, this is the difference. An adult condyle has a proper head, a proper neck, and a proper, subcondylar region. Whereas a pediatric condyle is more like a ball. And directly it ends, it's, kind of starts with the ramus. There is hardly any neck of condyle. That is why there is hardly any neck fracture of condyle in pediatric patients. Usually either it's a subcondylar fracture or it's a head fracture. That is why there is more ankylosis. Right? So bulbous condylar head with increased marrow content. Obviously, we know that as the person ages, the cortical bone increases, the marrow spaces shrink down. There is more mineral content and less or inorganic content as the person, less organic content as the person ages. All right. So condylar head is bulbous. There is hardly any neck and increased marrow content. This is correct. This is correct option. High osteogenic potential. Obviously, as compared to an adult, the pediatric patient will have a higher osteogenic potential. Increased lateral pterygoid traction. Why? Why would this happen? Why would this happen? As the person ages, the muscle also becomes stronger. The muscle also becomes longer and stronger. So in adult patient, the lateral pterygoid traction will be much more as compared to a child patient. All right. So that theory of TMJ ankylosis, which says that it's a lateral pterygoid traction which pulls the condyle towards the zygoma and causes ankylosis, is more in adults as compared to children. Children, small joint, small lateral pterygoid, smaller forces, so less traction as compared to adult. And that's the correct answer for the question number 4. Okay. Short neck of mandibular condyle, this is correct. We've already discussed. There is a bulbous head and the neck is still not that slender like an adult neck. Okay. So increased lateral pterygoid force or increased lateral pterygoid traction is the correct answer to this question. Thankfully, one easy question, straightforward question, repeat question. Which of these processes cause formation of upper lip? Now, here they didn't ask defective fusion of which of the processes cause cleft lip. Instead, they asked what processes form the upper lip, but it is the same question. Okay, we all know it is the median nasal process with the maxillary process. We have discussed this. It's there in our notes also. This is a screenshot of our notes which clearly say that the frontonasal process splits into this pink part, okay, which splits into this green part, which is the median nasal process, which forms the central part of the nose, this and the central part of the upper lip. The lateral nasal process stays back and forms the alar cartilage, forms the lateral part of the nose. Okay. The median nasal process comes still down and forms the central part of the upper lip. And that yellow part that you see in the image, that is the maxillary process. So, median nasal process and the maxillary process, they fuse and form the upper lip. If they do not fuse unilaterally, it will form unilateral cleft lip. If they do not fuse bilaterally, bilateral cleft lip. If the median nasal process of the left and right side do not fuse with each other, median cleft lip, which is very, very rare. Okay. So, this is straightforward from the notes, from the classes, straightforward question, median nasal with maxillary process. Okay, this was again in easy questions, straightforward. All are true about Ludwig's angina except tracheostomy is the only resort in for intubation. This is correct because as much as you try oral intubation, you always try the oral intubation first. But in most of the cases, because of the severe swelling in the neck, you will not be able to negotiate. And in most of the cases, you have to perform a tracheostomy. So this is correct. Bilateral involvement of submandibular, sublingual and submental spaces. This is the definition of Ludwig's angina. So this is correct. It is a surgical emergency because airway is at risk. Of course, this is correct. And the first treatment is done for airway. Then treatment is started for the space infection. And what is the treatment for space infection? The treatment for space infection is always surgical. That is incision and drainage. The treatment for space infection is never ever medical. Okay. Medical treatment is always adjunctive treatment. This is an adjunctive treatment, that is along with incision and drainage. With incision and drainage, after incision and drainage, you have to do a supportive medical treatment, which is IV antibiotics, fluids, rest, whatever pus is drained. Before you start antibiotics, you send it for culture sensitivity, start empirical antibiotics, check the comorbidities of the patient. Okay, so these are all supportive or adjunctive treatments. The primary treatment is surgical, which is incision and drainage. Multiple incision and drainages, bilateral submandibular, sublingual, segmental. So multiple incisions, you can even give a big cutthroat incision or you can give multiple smaller incisions to drain all the involved spaces which are affected in Ludwig's angina. So that is the D is the wrong answer and that is the correct answer because except is asked. Okay, so IV antibiotics, rest, culture and sensitivity is the norm. That is what the option says. It's the norm. No, it's not the norm. IND is the norm. And these are all adjunctive treatments. So D is the correct answer. Again, this is straightforward from our notes of Ludwig's angina, bilateral, submandibular, segmental, sublingual, surgical emergency, tracheostomy, First choice of airway establishment, CCT, incision and drainage, and last is the supportive treatment, which is antibiotics, rest, fluids, and whatever is the comorbidity, you treat that and all of that. Okay? Okay. Okay, now this was an image-based question. The exact image, I'm sure this image was from some of the patients that the examiner has seen in his or her institute. But broadly speaking, I can draw this image for you because I was there in the exam. No eyebrow raise was there. One eyelid could be closed nicely. Other eyelid did not close properly. Okay. This was right, obviously, and this was left. Okay. Then nose was there. In nose, this side showed a proper nasolabial crease and this side had no nasolabial crease. Smile was also slightly teda, but it was difficult to judge. What was obvious? Three things were obvious. First was bilaterally, the eyebrows could not be raised. So this thing, which is caused by the temporal branch of the facial nerve, could not be done. Second thing which was obvious was orbicularis oculi. The zygomatic branch was affected. And third thing which was obvious was the nasolabial crease was gone. Okay, so these things were obviously seen in the image, and exactly this was the correct option. Right zygomatic, bilateral temporal, and right buccal nerve. Okay, question was, which of the following is seen in the patient who is recently operated for TMJ ankylosis? Like I've always said, whenever you do any surgery around the facial nerve, there will be surgical swelling, there will be edema in the site, and it will cause a temporary palsy of the facial nerve because of the pressure on the nerve, because of the edema. Okay, so in this patient, he could not raise both his eyebrows. So maybe it was a case of bilateral TMJ surgery. Okay, so that's the correct answer. Right zygomatic, right marginal mandibular. Okay, right zygomatic is correct. Right marginal mandibular could be correct, but it is missing two very important, buccal and temporal. Okay, similarly left तो वैसे ही wrong हो गया because सारे symptoms right में हैं, all the symptoms are on the right, so this is wrong. Right buccal and marginal mandibular, this could be right, but it's not the best option. You have to choose the best option. So all those who got the click by seeing the bilateral temporal option, whoever saw that both the eyebrows are flat, they cannot be raised. So whenever we check the facial nerve, we ask the patient to do multiple things. Raise the eyebrow, close the eyelid, smile wide, right? This is plateisma action, okay? So when you ask the patient to raise the eyebrows, if it is unilateral, one will go up, one will not go up. Okay, like this, something like this. So in this case, none of them had the frontal crease. When eyebrows go up, it will cause the frontal creasing in the frontal region. And in this patient, there was no frontal crease. So that means bilateral temporal nerves were having palsy. So that's the correct answer to this question. I will try and find a relatable image very soon, but this was exactly what was asked in the exam. All right. Okay, now this is one master blaster, I will call it. Okay, a patient presents with deviation of the chin towards the left, and in exam R was marked. Very obviously an R was marked. Okay, deviation of chin to the left side, which is painless. Okay, what would be your diagnosis based on the following radiograph? Okay, two radiographs were given. One coronal CT, which showed the TM joint and a growth like this. Okay, I could not find the exact radiograph because obviously it is an image from the institute in which the examiner is working. So there was a condyle and there was a growth like this. It was a horizontal growth, okay, like this kind of a growth on a coronal CT, okay. And the second image was a technetium 99M MDP scan, which is a nuclear medicine scan, which gives hotspots. Okay, it gives hotspots whenever there is a high metabolic activity like a tumor or any excessive growth. Okay. Now let us rule out the options here. Osteochondroma, yes, that can be an answer because osteochondroma is a painless tumor in most cases. Osteochondroma is on the condyle. Osteochondroma will grow vertically or horizontally also, more very, very commonly horizontally also. It will cause deviation of chin and it will definitely give a bright hotspot on the nuclear medicine scan. So definitely osteochondroma is first correct option. Right condylar fracture. Okay. This is definitely wrong because if there is a condylar fracture, okay, I'll draw it here. Okay, this is right and this is left. Okay, if there is a condylar fracture of the right side, okay, the left side will be normal. The left joint will be normal. The left joint will move. When the patient opens the mouth, the left joint will move and shift the mandible to the right side. But the right side will not be able to move because of fracture. So there will be deviation of chin to the right side, which is not what the question asks. The question says there is deviation to the chin to the left side. So definitely right condylar fracture is wrong. Left condylar fracture, the deviation would be correct, but right condylar fracture answer is wrong. TMJ dislocation. TMJ dislocation will never cause a hotspot. It's not a growth related, it's not a metabolism related thing. It's a mechanical thing. So definitely TMJ dislocation will not cause a hotspot. And the fourth option is condylar hypertrophy. Very, very close. Okay. Now both condylar hypertrophy and osteochondroma will have growth in the condyle. Both of them will have a hotspot on technetium 99 MDP nuclear medicine scan. Okay. But always remember you have to choose the best answer. And when you compare a tumor with an active growth, you always choose a tumor. Usually, we see it in condylar hyperplasia and not condylar hypertrophy. And one of the components of condylar hyperplasia is osteochondroma. So the best answer to this question is osteochondroma. Okay. The examiner has been very, what do you say, very, very strict by giving this option. He should not have given condylar hypertrophy because it's a very, 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 very confusing option. Because in condylar hypertrophy also, it's a physiologic process which is overextended. And in that also, you will have deviation of chin. In that also, you can have a hotspot. But the radiographic image which was there in the exam, that is, this was the condyle and it was this kind of a growth. It was a medially extending growth, which is typical of osteochondroma. And that's the answer. All right. I'm very, very unhappy and I'm very feeling very sad for all the students who have read condylar hypertrophy because that's not wrong, but it's not the best answer. The best answer is osteochondroma. We have discussed all of this in our classes. I have shown you examples of this boy having right-sided facial elongation, increased, deviation of the chin towards the other side, and technetium 99M scan. We have shown you the nuclear medicine scan. I've shown you the hotspots, how it causes, a hotspot on the increased side. But this can be there in condylar hyperplasia also, and in osteochondroma, in tumors also. And the chances of having it in the tumor is much more. All right. And this kind of CT, which image is shown, this kind of growth which was shown, this horizontal kind of growth is typical of osteochondroma. So don't worry guys, if you have masked condylar hypertrophy, you will do well in NEET. I'm sure you will do well in NEET. The correct answer, however, is osteochondroma. Again, a difficult question. I will really call it a difficult question. Okay, coming to the next question. Very easy, straightforward, direct repeat question. And it's a question from our PYQ, from our notes. Name the test seen in the image below. Okay, straightforward, this is the bowstring test. Bowstring test, it is done to check the attachment of the medial canthal tendon to the skeleton. It is usually done in naso-orbito-ethmoidal fractures, in the Noe fractures, and it's a bowstring test. Again, direct pick from our notes. We have discussed in detail everything about Noe fractures, how transnasal canthopexy is done, how you can do the bowstring test, which is a repeat MCQ. It's there in our notes, it's there in our PYQs, and I'm sure most of you have done it correctly. Okay, so this is a direct repeat. So these questions have made the paper not extremely tough, but moderately tough. Okay, again, this is a repeated topic, but this exact question has never been asked. Manson's subunit principle is applied in which of these fracture managements? Now, what kind of fracture will you divide it into subunits? Okay, the answer is panfacial fractures. Okay, comminuted zygoma, that means you have to treat only zygoma. Comminuted Noe, that means you have to treat only Noe. Dentoalveolar fractures, you don't even need to fix it with ORIF. But when it comes to panfacial fractures, what is panfacial? Panfacial means a fracture where the upper third and the lower third of face are involved. Upper, middle and lower thirds of face are involved. That is panfacial fractures. So in his revolutionary article, Dr. Manson was an oral surgeon, a plastic surgeon, and he told how you can divide each area of the face into subunits. Just consolidate that area, then move ahead. And area by area, you start fixing. You take the support of the more stable structures and reconstruct the less stable structures. So, Manson's subunit principle is typically asked for panfacial fractures, typically used. Just to give you some points, these are the principles of panfacial fractures. Individually reconstruct the comminuted subunits. Rigidly fix subunits to each other, like Noe should be fixed with ZMC, ZMC should be fixed with Leafort, okay, condyle should be fixed with Ramus, Ramus should be fixed with angle, whatever is fractured, you connect the subunits with each other. Connect the subunits to a region of stability. Hawa mein mat latkao. Don't fix mobile fracture to a mobile fracture. Fix a mobile fracture to an immobile structure so that there is stability in your fixation, okay, and their associated buttresses. Re-establish the occlusion and the facial width, which is the first thing that we do in the treatment of panfacial trauma. We try and re-establish the width of the face and the occlusion. Based on these two things, we keep reconstructing every part, either bottom to up or top to down or in to out or out to in. Whichever sequence we use, we have to make sure that we have restored the width and the occlusion. So, re-establish the occlusion, that is one more principle. And consider the management of Noe fractures early in the sequences of fractures. So, like I said, anything that controls the width should be considered first, like palate. Palate is the first thing that will control the occlusal width of the upper arch. So, do that early. Noe is the area that will control the width of the upper third. Okay, so if Noe is not fixed, you will not know the correct intercanthal distance. So, Noe, palate, these are all the structures which control the width of the facial skeleton. So, do Noe early and re-establish the soft tissue relationships after wide craniofacial exposure. This means that whenever you are doing panfacial, you are doing multiple incisions, okay? You're going intraorally, you're going extraorally, you're doing bicoronal, you're going through the laceration. So, multiple areas you have opened up the face. After you have done your plate fixation, do not forget to resuspend the soft tissues, whatever soft tissue dissection you have done. Just try and put those soft tissues back into their original position. Try to suture them with the plates so that their reattachment is done and there is no sagging of the soft tissues. If you don't suture the mid-face soft tissues, there will be sagging of zygoma. It was a repeat question in INI-CET May exam. If you don't suture the mentalis properly, it will cause sagging of the chin, so chin ptosis or witch's chin. So that's the last principle, that re-establish all the soft tissues that you have dissected. So these are the Manson subunit principles used for the panfacial fractures. Again, a new question, so I will put it in the difficult category only. Okay, but you could have guessed it. Somebody who has read trauma nicely, you can guess this. Okay, this is the last question and this is the most unexpected question for oral surgery, because what is the appearance of the articular disc of TMJ in an arthroscopic view. Now, TMJ arthroscopy, we are not taught as BDS. In India, I don't know how many people are doing TMJ arthroscopy, maybe one or two. Okay. No standard textbooks of the UG level or the PG level have arthroscopy or normal joint arthroscopy in the curriculum. This is purely a arthroscopic textbook based question, which is not expected. All right. But since arthroscopy is the latest in thing in TMJ, it was asked. Okay. Just like internal derangement. Last time, in NEET, in INI, internal derangement was a hot favorite of the examiners. This time, internal derangement through an arthroscopic view is what they have asked. Okay, so this is again a difficult question, a new question, and it took me really a big time. I took help from a lot of people to confirm this answer. I had an idea, but I had to really confirm this answer with a lot of people from the right resources, and the correct answer is shiny white. You can guess this answer because all of us know that articular disc of the TM joint is made up of fibrocartilage. Okay. It is made up of fibrocartilage. We all know that. Okay. Most of the synovial joints in the body are made up of hyaline cartilage. But the TM joint articular disc is made up of fibrocartilage. And what is the color of fibrocartilage? The color of fibrocartilage is shiny white. Okay. Let us rule out the options. You can also come to the correct answer by ruling out. Red due to hyperemia and high vascularity. This is obviously wrong because we know articular disc is avascular and non-nervous. There is no vascularity, no nerve supply to the articular disc. The retrodiscal tissue, however, is very vascular. But disc is avascular. So you can easily rule out option number A. Cotton wool appearance. The cotton wool appearance is also a appearance of the articular disc, but as a pathology. Okay, in degenerative joint disease, you can see a cotton wool-like appearance of the articular disc, not as a normal feature. Okay, and transparent with condylar head visible through it, this is also wrong. It is not transparent. When it becomes really thin, maybe it could get transparent, but in normal condition, it's a fibrocartilaginous structure. Fibrocartilage is white and it is shiny white, which is the correct answer. All right. So this is the oral surgery recall. I am sure most of you are unhappy or disappointed by looking at these questions, but this is it. All right. INI has to be difficult. Oral surgery was difficult. And just keep your fingers crossed. Don't be disappointed. See, NEET is your real game. All right. NEET is the real big game. And difficulty in NEET is expected to be a little less. Surprisingly, there were no questions. There were no questions from exodontia, which is the basic of BDS curriculum. So that will not happen in NEET. I am hoping and praying that it will not happen in NEET. There were no questions from orthodontic surgery because AIMS loves orthodontic surgery. There were no questions from distraction osteogenesis. Usually there is at least one question from distraction. There was only one question from cleft, which is the embryology of cleft, the median nasal process wala question. Okay. Most of the questions were from TMJ, trauma, one question of pathology, which was article based OKC wala, one question from infection, which is Ludwig's angina, and two questions from LA, which will be covered in pharmacology. The bupivacaine wala question and the ester LA wala question, which is high hyper reactivity to ester LAs, allergies to esters. So it was not a very balanced paper that covers all the topics of oral surgery. It was basically trauma and TMJ bhar ke. Okay, and facial nerve palsy, which is a part of TMJ. So there's a lot of TMJ and trauma, and I've always said AIMS, you have to focus on TMJ and trauma firstly. All right. Still, it was difficult. Don't be disheartened. It was one of the exams of your life. It's not the last exam of your life. So all the best, everybody. I hope you've got some questions correct, and we'll start with the next recall in a few minutes. Thank you so much.
So a very good evening, my dear students. A very good evening to you all. And I hope your INI exam went well. And we just heard Dr. Himani ma'am that the question paper was around moderate to difficult. Yeah, so I hope you just gave your 100% of the effort. And this session is really helpful for you all to just self-analyze how the exam went for you. Okay, so when we talk about pedodontics, so we had around only 5 questions from the subject of pedodontics, and mostly if I look at the questions, they were not very difficult, straight questions they were. There was nothing from child psychology, there were no tricky questions from pediatric endodontics. You get a lot of clinical questions from pediatric endo and oral habits, which can, hold you in a trick. But there were no questions like that, mostly straight questions you got from the subject of pedodontics. Okay, so to begin with, the first question that we have here for the subject of pedodontics is, what percentage of SDF is used for the anti-caries effect of dentistry? So basically, what is SDF? As you all know, it is silver diamine fluoride, and silver diamine fluoride is used for arresting the active carious lesions. Okay, the function is to arrest the active carious lesions. So whenever you have a patient who is very, very uncooperative, who is not letting you even excavate the entire amount of active caries present in the teeth, what you all do, you excavate with the help of spoon excavator how much ever he's letting you, and then you paint it on with silver diamine fluoride, and it acts upon the active caries to arrest the active carious lesion so as to stop the progress of that active carious lesion. Okay, so what percentage of silver diamine fluoride is used for the anti-caries effect? So the option was, you got various options in which the correct option was 38%. So option A, that is the 38% of silver diamine fluoride was the correct answer here. So basically, as is approved, silver diamine fluoride is a colorless topical agent. So it is colorless agent, but it does impart dark black, color to the tooth surface and even to the soft tissue where it is painted on. Okay, so that is the one disadvantage of silver diamine fluoride, that is it does arrest the active caries, but it discolors or it colors the tooth surface black where it is applied. Okay, and what is it composed of? It is basically composed of 24.4 to 28.8 percentage weight by volume of silver, and 5 to 5.9% of fluoride, and the pH of this particular silver diamond fluoride is maintained to a pH of 10. So basically, silver also helps in occluding the dentinal tubules. So it helps in cutting down the sensitivity that the patient has, and plus the fluoride will help the infected and the affected caries to the infected and the affected caries to get arrested. So that is the function of silver diamine fluoride, and the correct answer here is 38%. Right. So the second question that was given was the material of choice for pulpotomy. Extremely straight question. We've been reading it in our lectures for like 100 times. Every time we, discussed all the grand tests. I think we came across MTA in almost all the grand tests. In the lectures also we came across this. So the answer here undoubtedly is MTA, nothing else. So the gold standard, the best material of choice for pulpotomy is MTA, which is mineral trioxide aggregate, a material that has a composition similar to Portland cement. It sets on to the surface such that it cuts, when you do pulpotomy, when you remove the coronal part of the pulp, then you can place MTA so that the radicular part of the pulp remains unharmed. The part of the pulp that is uninflamed is further protected from any other harm. So MTA is the material of choice for pulpotomy. The other options like calcium hydroxide, whether slow setting or fast setting, does not matter. The choice, the material of choice for pulpotomy is MTA, that is mineral trioxide aggregate, which is again a great material for use in DPC, that is direct pulp capping, and in pulpotomy. Even in epexification, epexogenesis, we use MTA as a good material of choice for completing the procedures. Right? So answer is MTA. The next question, the third question, that was, yes, that's another good question that they gave. So which amongst the two statements is correct? They gave two statements and they asked which amongst them was correct. So the first question was, most common injuries in children are luxation and avulsion. That means in children, most commonly the dental trauma is either luxation or avulsion. And the second statement that they gave was, in adults, most common is the tooth crown fracture. Okay, so they gave the options like whether both of them are correct, or only the first one, or the second one, or both of them are false. So the answer here is A, that is both the statements are correct. Yes, the luxation injuries in primary dentition are the most common dental traumatic injuries that occur in children. So the first question, the first statement is 100% correct. Luxation followed by avulsion are the most common dental trauma that occur in pediatric patients. Second, in adults, the most commonly occurring dental trauma is the tooth crown fracture, okay, ranging from the enamel to the cervical crown fracture. The tooth crown fracture is the most common type of fracture or dental trauma in case of adults. So statement 1 and statement 2 both stand correct. Okay, both of them are correct. Right. The next question that we have here is, yes, very simple, direct question, no applying brains there. What is the composition of the KRI paste? Okay, so the composition of KRI paste, as we have read, so whatever other options they would have given, the only correct composition, it's a factual question. There is no applying brains, there is no clinical tricks there. It's just the composition. You have to have by hearted the composition and you would have got the option correct. I hope most of you would have got it correct. Straight pick from the notes. So KRI paste composition is, it contains camphor, it contains iodoform, it contains parachlorophenol, and it contains menthol. Okay, so the KRI paste composition is camphor, iodoform, parachlorophenol, and menthol. That's the composition. KRI paste is a material of choice used for the obturation in case of primary teeth, and that's the only correct composition of the paste. Okay, then we have one more question that actually took me by surprise. I had to go through the question, read a little, apply a little extra brain there, because it was one of its own kind of a question, totally unexpected, very confusing. Okay, so you had been given an image of an OPG in which there were all permanent teeth that were given. So it was an OPG of a permanent dentition where you could see resorption in the lower incisors and in the premolar region, specifically in the cervical area. The resorption was seen in the cervical area in that particular OPG. And the question was something like this: the OPG given is of a female patient with no relevant medical history. So there is no relevant medical history, okay? No previous history of orthodontic treatment or bleaching. So there was no history of orthodontic treatment or bleaching, etc. The patient has good oral hygiene. Though there was one thing that they mentioned which took me by extreme surprise, that she had a feline pet. Okay, what does the OPG show? So when we read the term feline, feline means a pet or an animal of the cat family, and the only animal of the cat family that you pet is the cat. You do not pet a tiger, right? So feline means an animal of the cat family. Okay, so there is nothing relevant that has been given in the history. There is no relevant medical history. There is the patient has not undergone an orthodontic treatment, no bleaching procedures, and the patient has good oral hygiene. Okay, so let us take one by one each option. Okay, so root caries. Okay, so when I say root caries are very specific in patients who have either gingival recession or in patients with xerostomia due to radiotherapy. So gingival recession was not seen in that particular OPG, right? There was no bone loss seen in the OPG. So root caries in the absence of bone loss and gingival recession is not possible. Again, there was no medical history, medical history such as that of cancer or a history of undergoing radiotherapy, etc., which would have been a reason for root caries. So nothing. So root caries is not the answer, or root caries can be eliminated from the answers. Second is external inflammatory resorption. So when I say external inflammatory resorption, it most commonly occurs in the root area, especially in patients undergoing orthodontic treatment or in case of trauma. Okay, so since there is no relevant medical history and they have specifically mentioned that there has been no history of orthodontic treatment, so external inflammatory resorption is not possible. Then we have idiopathic inflammatory resorption. Again, idiopathic inflammatory resorption is basically in cases where there has been a trauma or there has been some underlying systemic disorders. Okay, so all of these things, they have specifically mentioned that there is no such thing that is present in that female patient. So idiopathic inflammatory root resorption is not present. Now, when you've eliminated root caries, external inflammatory resorption, and idiopathic inflammatory resorption, the one thing that should strike in your mind is there has to be something related to the term feline pet. That is why they have specifically mentioned it. Why will they otherwise, Do you even ask your patients how many pets do you have? Which animal do you have as a pet? No, right? So why this information about the pet is important is because some researchers suggest that there is a bacterial transmission of a certain bacteria that is called as Bartonella henselae, which is found in cat scratches, which may contribute to ICR. What is ICR? ICR is invasive cervical resorption. Okay, so the only legitimate answer here, because of the specific information that they've given that the patient has a feline pet, is the cervical resorption. So this type of a cervical resorption has a specific terminology that is called as invasive cervical resorption. And there have been researches that have been found that certain bacteria such as Bartonella henselae, which is found in cat scratches, may contribute to invasive cervical resorption. Zoonotic transmissions, some studies suggest that zoonotic pathogens, that is diseases transmitted from some animals to humans, might also play a role in the ICR, that is in invasive cervical resorption. So again, to minimize the potential risks, so basically there is no 100% evidence to show that every time you own a cat, you will have ICR or invasive cervical resorption. It doesn't state 100% generalized situation like that, but there is a bacteria that is found in the cats that can result in this. So to minimize the potential risks, if you do own a cat as a pet, you must practice good hygiene, such as washing of the hands after handling the cats. You should avoid direct contact with cat saliva or scratches of the cats. You should keep the cats vaccinated up to date so that such a bacterial invasion is not present in the cat. And then you must go for regular dental checkups and good oral hygiene, because if you do not have a good oral hygiene, it will just give local irritation. It will act as a local irritant to further worsen the situation if you have some sort of a cervical resorption. So go for regular dental checkups, maintain a good oral hygiene, and if you do own cats, just make sure you take care of these particular points. So a very surprising question this was, but always know, when you have a piece of extra unnecessary information given to you in the question, it is in fact not so unnecessary but the most important piece of information. Imagine a OPG that they've given and they are mentioning that the person has a feline pet. There has to be some connection with the feline pet that they've given that piece of an information. So yes, the answer here is cervical resorption, also called as invasive cervical resorption. So these were all the questions that you got from Pedodontics, except for this particular image-based question. The rest questions were pretty straightforward, no confusion. So I am particularly sure that the other 4 questions, you've all marked them correctly. Nothing tricky there. So if still there are doubts, you all can, comment or just message me in the group. And yes, that we finish with the session for the periodontic discussion of the INI-CET November 2024 exam. And I wish you all the very best, all the very best. And we'll start with the next session in a few minutes. Thank you.
So, a very good evening to all the students who are watching this mega recall session. And I'm very proud to tell you that we are the first academy to come with such a mega recall session in just few hours after the exam. So, from perio perspective, I'll say till now we are able. Just hold on, guys. I have some disturbances. Okay. Okay. So let us start now. So basically there are six. Okay. So basically there were 6 questions that we were able to collect from our students, and I will request to other students who are watching this session on YouTube, please let us know. Uh, Okay, so students, actually there is some disturbance. Just wait. I am starting the session. Okay, guys. So from Perio, we were able to collect 6 questions, and I would request to all the students who are watching us right now live, please let us know in the comment section if any other questions were there, and we have we have recalled 6 questions with the options. Even if in the options you feel that there is something else, some other options are also there, we can change it. Okay. So let us start with the session and with the question discussion. The first question is periochip size and composition. So basically, periochip in this options we have not written what is the composition. This is one of the questions which and composition. Basically, composition periochip is a local drug delivery system, and in periochip there is chlorhexidine. Okay, so the dimensions of periochip. We have already discussed this in the chapter of local drug delivery, and the dimensions of periochip are what the options that were given were like this: 4 into 5 into 0.35, 0.4, 0.5 into 3.5. The answer here, this is a direct question, a repeat question, and we have discussed this question many times. The answer to this question is option number A. The dimension is 4 into 5 into 0.35. Okay. The answer to this question is 4 into 5 into 0.35, and it contains chlorhexidine as a local drug delivery system. Okay. Now the second question. Dentogingival unit consists of what? This is also a repeat question, and we have discussed it many times. This is from gingiva, chapter gingiva, one of the repeated topic, one of the most repeated topics. This also we have discussed in the live session as well as in INI-CET, the grand test which we discussed. The dentogingival unit consists of option number A, junctional epithelium plus gingival fibers, junctional epithelium plus sulcular epithelium, junctional epithelium plus sulcular fibers, or junctional epithelium plus gingival epithelium. So the answer to this question is option number A, junctional epithelium plus gingival fibers. Now, the third question is, which of the following is a surgical curette? Now, the thing to highlight here is they have asked the surgical curette, okay, and not the other curettes which we use during root planing. So here the options are option number A, Gracie curette, option number B, Barnhart curette, option number C, Columbia curettes, option number D, we were not able to correct, properly recollect, but surgical curettes, the options are Langer curettes, Kramer curettes, Kirkland curettes. Okay. Gracie curette is area specific curette, and it is not a surgical curette. It is a curette which is used during root planing, right? During scaling and root planing. So this is not the correct answer. Okay, this is not the correct answer. Barnhart and Columbia are also universal curettes. These are universal curettes. So B and C is also not correct. The correct answer here will be this: Langer, Kramer, and Kirkland. So please let me know in the comment section whether Langer was there or Kramer was there or something else was there. Okay? So just let me know what was the option here. Now, question number 5th. probing on labial aspect of the tooth is painful. What can be the reason for the same? Okay. This is a question from periodontal pocket. And we know the reason of pain. This also we have discussed in our sessions. The reason of pain while periodontal probing is ulceration in the periodontal pocket, right? Ulceration in the pocket is the main reason for causing pain in the tooth. So the answer here will be option number B. Option number B. Next question is 2/6 distal surface has 7 mm pocket. There is a pocket of 7 mm, and apart from that, there is 2 mm recession. Okay. This is also a very frequently asked question. Even the values, they have not changed in this question. What is the clinical attachment loss in this case? Okay. So now this is the image. In this image, you can see that there is recession, right? There is this much recession is there. This much recession is there, and that recession is 2 mm. And the pocket depth, the pocket depth from the gingival margin up till the base of the pocket, that is 7 mm. This also we have discussed in our sessions. So what is the clinical attachment loss? This much is the clinical attachment loss, guys. Till here, there is loss of the periodontal ligament fibers. The attachment is lost up till this much length. So the answer will be 7 plus 2 is equal to 9 mm. So the answer to this question is option number A, 9 mm. Okay. Now, guys, this is the last question. And I think actually the options we were not able to recollect. I would request you to tell me the options here. Some students are saying that in this question there was like multiple options were there, and we had to choose between that. So please let me know in the comment section what factors affect formation of plaque. The factors which affect formation of plaque are the food intake, the composition of the saliva, and the topography of the tooth. There are multiple factors which affect the formation of plaque onto the tooth surface, right? So many students are saying that it was a multiple choice, like there were many correct options in that. So please help us with this question and we will correct it. Okay. So the these were the questions which we were able to collect from for Perio. And guys, uh, thank you so much. And I hope everyone, most of you, like the Perio part was relatively easier. And all the best, guys, for the results. Thank you so much.
Good evening, students. I hope you did well in today's exam. I heard that the paper was a little tough, but then that must be for everyone. So I think there'll be the theory of relativity, so don't panic. And I hope to see you all getting selected in all the exams. And if not now, then at least, don't forget about how you performed and get in full, vigor for your NEET exam, okay? So we can just analyze the paper today, learn from it, gauge our performance, and then move on to the next exam, right? Okay, so I think we don't have the proper questions which were asked, but then let's try to, recall whatever best we could and understand the basic concepts so that we know at least what all we answered and what was asked according to the options. Okay, so yeah, so as you all know, I am Dr. Garima Bhambani, your faculty for public health dentistry. I teach in the capacity of a professor in People's College of Dental Sciences. Okay, so one of the questions which was asked is the principle of Lagarde's involves. Okay, so what are Lagarde's basically? Like whenever a new program is being introduced, so I'm also checking for your questions in the chats in case you have any questions. Okay. Yeah. So what are Lagarde's? Basically, whenever a new program is being implemented, there are 5 types of adopters. Okay. So different people try different types of product by different speeds. Okay. So there are 5 types. What are they? First is innovators. The second is early adopters who adopt any program very easily. The third is early majority. The fourth is late majority, like early majorities, they form the majority early. The fifth type, which was actually asked, is Lagardes. Okay. So they are the people who have some preconceived notions, like they're very traditional people, like old people, they have a set of belief that if you want to try something, it has to be that way. Okay. So they are the last ones. Okay. It's not that they do not have the money, but they are the last people to try any product. So they have a tradition mindset that traditionally this is how a thing should be. Okay. So based on their mindset, they are late. So accordingly, the options that we have as of now is like the options that that they've asked in this is that the options are firm health belief and non-adoption, communication protocols, okay, adoption of new medical systems, and the other one is basically 1 second. The other one is adoption of new medical systems and mental health. Okay. So the answer to this would definitely be the firm health belief and non-adoption. Okay. Because they are the people who have a firm health belief and they are the late ones to adopt anything. Okay. Now, the second question is a question which has been discussed with us multiple number of times and asked in queries also by you all, and we've recorded those lectures. We have taken those questions in the exam. So I'm 100% sure that you all have answered this nicely. The question is that which of the following type of validity is measures of a new test against a validated test? Okay. So now what is a validated test? Validated is a test which is gold standard. Okay. Like this particular test we know is the way to measure this particular entity. Okay. So that is again a gold standard. Gold standard is something which is certified as the right method. For example, in mouthwashes, they say that the gold standard mouthwash to be used is basically a chlorhexidine. It has been proven in its properties to be an ideal mouthwash. Okay. So the answer here will be, this was also a question which was asked in your NEET or in INI-CET last year. And the answer for this is criteria validity, okay? Because criteria validity is what? This says that if a test is already established, okay? So as a standard of comparison, we refer that to as the gold standard. What is convergent validity? So like, I think you all get confused, which was also in the queries in the, various times. Convergent validity is how closely a test is related to the other test which measures the same entity. For example, you have a particular test to measure the oral hygiene. So how much that test is converging is called as the convergent validity. All right. Face validity is how a test looks. Okay. And content is that suppose if you have a questionnaire to measure something, so how much are those contents exactly in sync with what you want to measure? Okay, so these are the various types of validity. So I think you understood this particular, concept of validity. Okay, now the next question that you have is, okay, so this is again a repeat question which was asked earlier in the exams. I think in INI only. The mean is given as 49. Standard deviation is 8. Calculate coefficient of variance. Okay. So now if you want to calculate it, there is this formula. If you know the formula, you can very easily calculate. How do we do that? The formula of coefficient of variance is basically coefficient of variance is what? The ratio of the standard deviation to the mean. So they have given it as a direct question. Okay, which is that you have to basically, so you have to divide the standard deviation with the mean, okay, into 100, okay? That is the coefficient of variance. So you will divide 8 divided by 49 into 100. The answer is 16.32, okay? That's the answer. Also, I think someone told me that there was something about risk difference. I do not know the values, what was asked and what was not asked. Okay, like what were the values given? So the formula for risk difference, as we know, is that if you want to calculate the risk difference, it is calculated by subtracting the cumulative incidence, okay? Like incidence or occurrence in an unexposed group, a group which is not exposed to the disease or to the risk factor. Okay, unexposed may say you subtract the incidence in the group which is exposed. Okay, so the formula is CLE minus CLU. Okay, E is exposed minus unexposed. Risk difference is A. A is the incidence divided by A plus B total minus C upon C plus D. When you, I think the values would have been given to you, and if you put these values, you would have taken out the risk difference very easily. Okay. Now the another question is when the data is not according to the Bell's distribution. Okay. So this is something again, you all know that Bell's distribution is what? A Bell's curve is when the distribution is normal. Okay. That is a normal distribution is when the values coincide. Okay. When the data is normally distributed. However, when the data is not normally distributed, okay, it is called as skewed. Okay. So there are two types of skewed. One is a right-tailed when the curve is shifting towards the right side. This is all taken in your test and discussion videos. So you can go to the recorded videos and see that there are two graphs where the tail is shifted towards the right. Okay. So that will be, in that case, when is the tail shifted towards right? When the mean is more than the median, and that is more than the mode. Okay. When the tail is shifted towards the left, that is when mean is less than the median and that is less than the mode. Okay. So these are basically what you understand. So here the answer will be D. When the mean is much lesser than the median. Okay. That is when the data is not according to the Bell's distribution. Okay. Now, which guideline is used for randomized controlled trials? So all these guidelines I had covered in your test and discussion videos. Okay. So what is there? What are the guidelines? Guidelines are basically when you conduct a randomized controlled trial. Okay. Or when you write a randomized controlled trial, how exactly do you want to conduct it? What are the guidelines that you follow? So for different types of studies, different guidelines are there. Okay. Now, for example, for a case report, okay? So for a case report, the guideline is CARE, okay? Now, for a randomized control trial, the guideline that you use is CONSORT. So the right answer will be CONSORT. CONSORT means, the full form of CONSORT is the Consolidated Standards of Reporting Trials. Like what are the consolidated compiled standards of how you report the trial? Then there are PRISMA guidelines for systematic review. Okay, so this is again a very direct and nice question. I'm sure you would have answered this. The answer here is CONSORT. Okay. Okay, so when is variance equal to mean? Okay, so this is the property like in Poisson's distribution. One of the properties of Poisson's distribution is that variance is equal to mean. Variance and mean are considered equal. Okay, what is Poisson's distribution? Poisson's distribution is a way of calculating, like if you want to calculate the probability of rare events, like how the rare events occur, okay? And when these rare events occur, basically, like randomly in a fixed interval of time, okay? In a fixed interval or time, when like in a particular fixed time interval, when rare events are occurring, that is called as the Poisson's distribution over that particular interval. I hope I'm audible, like I'm not sure. Okay. So so in case of a Poisson's distribution, how much the rare intervals are happening in a particular time, that is called as Poisson's distribution. In the Poisson's distribution, the variance and the mean are equal. So answer here will be C, which is Poisson's distribution. Okay. Now, again, this question, it could not be exactly recalled by what the examiner was saying. So I have decided to tell you both the things. Okay. So they asked that they mentioned something about induced cost. So I'll just tell you what is induced cost. Okay. Induced cost is the cost that arises due to the cost that arises due to firm actions. Like if you take a firm action and decision that this is what particularly we want to do, this particular technology which we want to say. So you have not included that cost directly, but that is an indirect cause. Okay, that is not directly related to the firm, but it is a result of an action. Okay, for example, a particular firm decided to use a particular type of technology which may have increased the cost. So induced cost is that you decided to take a decision that increased the cost. So because of the technology, the cost increased. Okay. So that is called as the induced cost. It is not directly increasing the cost, but because of a particular decision, a firm action, the cost increased. Okay. Now, maybe the question asked something on, cost effectiveness. So what is cost effectiveness? As I've taught you all, that is that if you want to attain a predetermined objective, okay, at the least amount of cost and have the same result, or to maximize the benefit from the limited resources. You have limited resources, but you want maximum benefit out of it. So there are two options. One is it can be you reduce the cost also, effect is also less. Or make it more effective, then the more cost is okay. That is cost effective. Like as per your cost, how effective your program is. Okay. The next is cost benefit. Cost benefit says that you calculate the benefit in terms of money. Okay. Like there is another type, which is it calculates on the basis of the results achieved, the health status. But benefit is the economic benefit. Like in terms of money, how did you benefit? Okay, like did your resources were used less? Were your expenditure on the health was less? So cost and benefit, both the benefit is also not in terms of the health status that you achieved, but in terms of money. That is cost benefit. Okay, so maybe something was asked related to this, like on the cost benefit. Okay, the next is health expectancy can be defined as. So again, we don't know what exactly the question said. Was the question on the index, HALA, LE, like Hale index, or was it on health expectancy? So what we know about health expectancy is the average number of years a person is expected to live. That is health expectancy. Okay. Now, basically, what is physical quality of life index? That is also one of the questions which is commonly asked. So if that was the question, physical quality of index has three aspects. Okay, that is basically your infant mortality. Okay, expectancy at age 1 and literacy. These are the components. Okay. Then there is something called as Hale index, which is health adjusted life years. So this is basically that like the life expectancy at birth, but this also includes the time spent in poor health. Okay, like what at birth, how much life a person is supposed to have, that is known as Hale. And also the years which are spent in poor health, they are also included. Okay. Now, what is DALY? DALY means disability adjusted life years. which is the years, like, disability adjusted. So the years which are lost due to premature death, okay, or the number of years a person had to live due to disability. So those years are included in DALI, okay? So that is also one thing. Okay, now someone also told me there was something on pre-protocol analysis. So we don't know what that question was, but I'll just briefly tell you what is pre-protocol analysis. Pre-protocol analysis is the planned and documented analysis, okay? Like before you are doing the study, you have properly planned, before conducting an examination, that what is the specification at the endpoint, what are the borderline characteristics, and basically the aim is that before you do give the treatment, you have identified what will be the effect of the treatment under the normal conditions. Like before the treatment, before the thing has occurred, you can identify the treatment, okay? You can identify the effect of the treatment before it happens, okay? That is there. Now, what are the tests for meta-analysis? So I don't know what exactly was the question here and what were the, what were the options that was given, but the test which is most commonly used, see, Cochrane and Tau are also used T-square, okay? I alone is not used, it is I square always, okay? Z is also used, but I square is used. So I think in this case, the most appropriate should be T-square and I square. But we don't know the options, but mostly the tests used for meta-analysis are, T-square and I square. Now I'll quickly join the link, and because the voice was echoing, so I'll just see if you have any questions in there. Meanwhile, I'll also see, any questions? Okay, ma'am, please be slow. Pre-protocol analysis, Moin, I did answer. Yes, Kritik, I was actually, my pen is not connected, so maybe, that's why you're finding it a little difficult. Good evening, Nami. Good evening. Okay, Faizan, what exactly you're not getting? PPT not moving. I think later on it moved. Okay. Yeah, PPT and ma'am's videos. Standard deviation, I answered. Okay. I don't know the exact values, but whether it was 8 or 9. But the formula that we use is again 8. Formula is the same. Okay, standard deviation divided by mean into 100. Okay. Yeah, Krutik, I just read that you wanted me to be slow. Okay, one option was standard deviation 1. Can you tell me the exact question, Moin? Okay. So yeah, those who've written, I think one of you wanted me to be a little slow. So please repeat any questions that you want me to ask. Hi, Nami. Yes, Swasti, the answer is right. Okay, I think it's T square and I square. We don't know the other option, but yeah, I think that should be the right answer. Okay. So anyone wants me to repeat any particular point, I'll do that. Okay. Laggards I've explained, right? Any other question that I've not explained? Validity I've explained. Any other question? Poisson's ratio I've explained. Guidelines I've explained. Risk difference, mean. Okay, there was something also which is, it is a Hawthorne effect, right? Hawthorne effect is basically, there was one question someone told me on Hawthorne effect. Hawthorne effect is basically the way a human reacts. Okay, Nami, let's get to the right options later on, and then we'll have a discussion again when we have all the options, because so that we'll exactly know what the examiners were asking for the meta-analysis question, right? Because right now we don't have all the answers. Yes, Ritik. Ma'am, in first question, it was asked that Laggards and innovators are component of which theory? And the diffusion of innovations of theory was in option. They are the, okay. So basically, Laggards are related to the health belief. That was one of the questions which was asked. Okay. Laggards, yeah. Any other question? Any other comments like? Effect of person who's been studied, workup bias, Hawthorne, yes. I'll get to that. Yeah, so Ritik, basically the diffusion of innovations is the name of the theory, and laggards are a component of that. Okay. Yeah, there were two questions on Hawthorne effect. So I'll explain that. Yeah, so Hawthorne effect is basically a type of a human behavior, okay, or reactivity in which individuals modify an aspect of their behavior, like when they know that they are being observed. Like when you know that you will be observed for your oral hygiene today, so you will probably brush more effectively or in the right brushing technique. So that is known as Hawthorne effect, okay? That the effect when you know that you are being monitored, okay, so there is a change, there's a modification in the behavior, that is not the actual behavior, okay. Then the effect was discovered in the context of research conducted. It is called as Hawthorne because it was conducted at the Hawthorne Western Electric Plant, okay. That is why it is called as Hawthorne effect. The other is the Rosenthal, and there is something called as Pygmalion effect. What is Pygmalion effect? This is a psychological phenomena where high expectations lead to improved performance. Like if you're expecting more, then the performance is enhanced. So this was first described by Robert Rosenthal. So it is called as the Rosenthal effect. Okay. So I think now it's clear, and we are clear on this. Okay. So any other questions? I think we can, yeah. Positive thoughts impact the performance. Yes, Amina, you got it right. Any other questions? Shall I end the session now for PhD? I think we have tried to cover whatever was asked. Okay. Okay, so I'm just reading your comments. Okay, any other questions, beta? Okay, so that's it. Yeah, Krutik, thank you. Thanks to you all. Okay, so I think we'll end the session then, maybe. Ma'am, when variance is equal to mean, that is a characteristic. Variance and mean are equal in a Poisson's distribution. So that answer will be Poisson's distribution, Ruby. Okay? Okay, Nami. Okay. So I'll end the session now. And all the very best for your INI-CET results, okay? Thank you so much.
Let me just see if it's working fine. Yes, it is. So, hi, evening, friends. We know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemato-Oncology, AIMS Delhi. And let's have a look at the path and micro recall. So, before I even go further, I know that overall the paper was tricky, but pathology and microbiology are always the two subjects which work okay, which work fine, and हम लोगों की नैया पार कराते हैं. So let's have a look at the questions associated. Let's have a look at the questions. Starting with the first set of questions. Hi, evening Komal, evening Kirti, got me. Everybody, bache, everybody. So let's have a look at the questions. Fatafat se, with respect to Path Micro, they were from notes, they were simple, straightforward. Hi, evening Nami, bache. everything was set, and I mean, very, very satisfied with respect to the paper. Evening puja. अच्छा सबसे पहले ये बताओ, what was your feel with respect to the paper with respect to path and micro? I'm not talking about the overall paper. I know that overall paper was tricky. It had the repeat questions were less. I am aware of that. But with respect to pathology and microbiology, it was from the notes part. So starting with the first three fungi questions, mucormycosis. Fungi, it was asked 17 times. 17 questions from fungi in last time's INI. This time there were three questions, but straightforward. That is mucormycosis. It shows the presence of hyphae which are present at right angles, Mrinal, which I always feel nice reading this statement that micro questions and path questions are nice. Evening Sangmitra, evening bache. So mucor hyphae are present at right angles. They can either be aseptate, they are actually usually aseptate, or are minimally septate, or are minimally septate. So this was mucor. I'm sure everybody would have been right in this. BF, boyfriend name, black fungus, mucormycosis associated with uncontrolled diabetes, COVID-19, therapy to be given liposomal amphotericin B. You know all that. Next, the second question was again with respect to microscopy of aspergillosis. That is, it has the characteristic acute angle branching. It had the characteristic acute angle branching. Next, SCID, severe combined immunodeficiency. Those students, hi, evenings, Anjali, Swasti, everybody. You won't believe it, guys. Yesterday, we were having a class of live class of immunity of pathology only, and we were discussing about SCID, and I simply said ki chances are that this question can be asked because it was this time's MBBS segment, NEET PG PYQ 2024. SCID, it occurs due to ADA, adenosine deaminase, ADA deficiency, adenosine deaminase deficiency, autosomal recessive, ADA, adenosine deaminase deficiency. Next, another question which is pretty commonly asked is with respect to anti-inflammatory mediators. Whenever we talk of inflammation, all the cytokines and chemokines cause inflammation except three main ones: interleukin 10, TGF beta, and lipoxins. That is also anti-inflammatory. Next is interleukin RA. Even if you were not aware of interleukin RA, but you very well know that interleukin 1 or interleukin 1b, it is associated with fever. It is an acute cytokine associated with fever. Most potent is interleukin 1 followed by interleukin 6. So all anti-inflammatory except interleukin 1b. Next, there was an image-based question in which I am being told that an HE image was given and then a blue colored. Sangmitra, see, yes, I 100% agree, and we were laughing about it also when we were talking about SCID yesterday, I guess. So we always have a laugh in class. That is until Gautami is not there and the live class students know what I'm talking about. But yes, we were discussing it yesterday. Next, there was a blue stain of PAS, periodic acid shift. You were asked the stain and which organism it stains. That is PAS positive actinomycetes, periodic acid shift, PAS positive actinomycetes. Next, there was next question on pernicious anemia. Pernicious anemia, it is associated with antibodies against intrinsic factor. Remember, intrinsic factor binds with vitamin B12 and it is absorbed from terminal ileum. You know this very well. Antibodies against intrinsic factor is type 2 hypersensitivity. So it is associated with which anemia? It is associated with megaloblastic anemia. I think the word in the question was cyanocobalamin deficiency or vitamin B12 deficiency. So yes, got me agreed. And Adya, I hope कि तुम सब लोगों को राखी वाखी बांध चुकी हो दिल्ली में. Adya was celebrating Bhai Dooj today. So don't ask me why. वो आधे काम she does which we are never able to comprehend why. So coming back. Pernicious anemia. It is a megaloblastic anemia, cyanocobalamin deficiency. Next question was asked on RBC diluting fluid. RBC diluting fluid is Hames fluid. Next, नहीं उसने स्वस्ति सब लोगों को बांध दिया दिल्ली में आज, पता नहीं किस किस को. Next, another question was Turk's fluid. Smile बच्चे, I do not have the exact set of options with respect to periodic acid shift, but I was told that PAS and actinomycetes was in the option. If the image showed the presence of pseudohyphae, then it will be Candida. if the image had pseudo hyphae, then it will be candida. Then it will be candida. Otherwise, actinomycetes. Spas and actinomycetes was in the set of options. Next, with respect to diluting fluid, Turk's fluid was also in the option, but Turk's fluid is used for WBCs. Turk's fluid. Turk's fluid. Just a very silly way to remember, all the Turks, they keep on fighting with each other. So Turk's fluid is with respect to WBCs. हाँ, because tomorrow Nimesh will also be there. You are so right. बाकी लोगों के साथ कल celebrate करेंगे. Next, lastly, xanthelasmas. Remember, we were discussing about giant cells and xanthelasmas. Xanthelasmas showed the presence of Tauten giant cell. It was associated with hypercholesterolemia, hyperlipidemia. We even saw the image of a female who had elevations on eyebrows as well as the bridge of the nose. So it is associated with hyperlipidemia. Next, K. Bache, though I have no idea what K stands for in the full form, but if you give in the comments, it will be extremely nice if you can if you can tell the image. Kyunki lichen planus, there was another question maybe of lichen planus. So that will be discussed in oral path, which that will be taken care of in it. But if you can actually search from Google and show me the image, because the image will tell us whether it was candida or it was actinomycetes and whether the stain was Pass or not. But I was told that it was periodic acid shift. But fair enough. देखो life को बहुत ज़्यादा seriously नहीं लेना है. Frankly speaking, it's okay. I know it was an INI exam. It was important. But I'm again saying this, it has absolutely no bearing on your NEET PG rank. Getting a good rank in INI does not guarantee a good NEET PG rank and vice versa. So what is the take-home message, or what are the lessons we learned from this paper? Firstly, notes are absolute gold standard. उनको तो बहुत अच्छे से करना है. Give 2 proper revisions. I'm extremely lazy. I don't believe in having 3 or 4 revisions. 2 good revisions and you are set. But minimum of 2 revisions. If you're on your 3rd revision, that is extremely nice. But don't miss out any topic. Don't miss out any chapter, because the topic or chapter we miss out, question is always asked from that. Understand the concepts, because Nami agreed there was another question, probably sulfur granules actinomycetes, but I do not have the recall of the same. If there was sulfur granules, that is actinomycetes. Sanmitra, I agree. Image based में ना, you have to extrapolate what the image is showing you and correlate it with the options. अब जैसे अगर brown black है, तो it can be very well be sulfur granules. I have no idea what the image was because I actually didn't get any recall on that. But अगर brown black sulfur granules type देख रहे हैं and actinomycetes is in the option, we mark that. So you always extrapolate. And I think girls are extremely nice in this. हम लड़के लोग, we say something but you always extrapolate ना कि नहीं, this was said but this was what it meant. So do not worry about extrapolating. Do not worry about extrapolating. Sort of फिर तो actinomycetes सीधा साधा हो गया. Simple actinomycetes. And the most important thing for being successful, study calmly. Do not be under overdue stress. The right amount of anxiety, stress, and calmness is the one that is going to get you selected. So on this note, needless to say, bestest of luck for this is certainly, I hope that for majority it is the final paper, but rationally speaking, I know it will not be. So keep on slogging, keep on working, and nice things in life are just around the corner. So on this note, and go out tonight यार. आज तो बाहर जाके अच्छे से खाना खा के आएंगे. कौन बाहर आज अच्छे? Who all are going outside today to have nice dinner? Seriously, very, very curious. फटाफट से tell it in the comment section, and I wrap up the session so that you can go to the next subject. But please do tell me who all are going out tonight. So on this note, बच्चे, we wrap up our this session. Thank you, बच्चे. हाँ यार, got me 8 questions only. अब ये नहीं वालों ने, they just gave 8 questions this time instead of 17 like the last one. It's okay now. It's okay. Take care. हाँ Durga, very nice, very nice. Thank you. Take care.
Done, sir.
Thank you. Thank you.
Hello, good evening, everyone. Okay, yes, we will have a review of OP questions. Okay, Ruby, not to worry. Okay, and if you have any doubt related to this, you can just mention in the comment box. Okay. Now with respect to the oral pathology, I would say the question. Good evening, everyone. With respect to oral pathology, I would say the question was of very moderate type, and majority of the questions we have already discussed in the live class. Okay, so few of the questions, they were direct pick from the past year paper and direct pick from your live session, and also from the past year questions which was conducted in your grant test and INI. Okay, now this everyone knows this answer. Most common odontogenic developmental cyst. Okay, so it is a very easy question. Most common odontogenic developmental cyst, it is dentigerous. Now those students who have marked radicular, so the most common odontogenic inflammatory cyst is radicular. Okay, but odontogenic developmental cyst is dentigerous cyst. So here the answer is dentigerous cyst. Okay, BRAF and V600 gene mutation is seen in. Okay, so in this hi Nami, okay, yes. So BRAF and V600 gene mutation is seen in. Now this question was directly picked from your live session. I had this huge gut feeling that they might ask you in your INI paper. So I will share the image of the live session which was discussed in the class. So mutations associated with ameloblastoma. So there is a mutation of MAPK gene. Now again, this has not been asked till yet, and it has a high probability that this question as MAPK gene mutation might be asked in your coming paper. Okay, hedgehog pathway, also fibroblast growth factor along the gene associated is BRAF and V600E gene mutation. Okay, now HPV16 DNA has been seen and associated with multicystic ameloblastoma, but not seen in unicystic ameloblastoma. Okay, so here the answer is ameloblastoma. Now these three questions which we have discussed till now, already discussed in class. Now, most common location for ameloblastic fibroma, again we have discussed. Adya, very good evening. Okay, now most common location for ameloblastic fibroma, it is retromolar region. Okay, ameloblastic fibroma. And as in general, if you guys don't know that if they have asked you about tumor and if you have no idea about it, generally most common, although odontogenic tumor, they are seen in the posterior part of the oral cavity. Okay, now tell me Adya, how was your paper? Periapical cyst. Okay, so even if the periapical cyst was also in the option, what is periapical cyst? It is a radicular cyst. Dentigerous cyst का दूसरा नाम periapical cyst नहीं है. Periapical cyst, it is also known as radicular cyst. Even if they have mentioned periapical cyst, then also the answer will go to dentigerous cyst. Okay. Now, yes. So here the answer is retromolar region. Okay, OP was good. OP was good because you have attended all the live session. That is why OP was good. Okay, because we have discussed everything in detail and whatever is required in your paper. Okay, now most common odontogenic tumor. So most common odontogenic cyst we have discussed. Now most common odontogenic tumor. Now one student, I was having a discussion with her that she said that ma'am, OP was really good and you had discussed all the questions whatever you have discussed, it had come in the paper. Okay, so most common odontogenic tumor, it is odontoma followed by ameloblastoma. Okay, odontoma followed by ameloblastoma. Now, this question I have not got the options. It is a very confusing, okay, but I know that necrotizing cyalometaplasia and squamous cell carcinoma. Now, necrotizing cyalometaplasia, it is a self-limiting disease. The only way to differentiate necrotizing cyalometaplasia and squamous cell carcinoma, that all the features of malignancy which is seen in squamous cell carcinoma will not be seen in necrotizing cyalometaplasia. Now, it is a lot of inflammatory cells will be seen in necrotizing cyalometaplasia. So, I would be glad if you guys will tell me the other options. Okay. Now, all of the following can be used as an alternative for enucleation in the OKC, except Except, okay. So yes, enucleation, we do enucleation, that means removal of the cystic lesion. Now OKC, it is a very recurrent type of cyst, okay. Now Carnoy solution is used, peripheral osteotomy, because it is very recurrence in nature, we do peripheral osteotomy. Yes, along with the enucleation, we do local application of 5-fluorouracil, but the only option which can be ruled out here is preoperative radiotherapy. Preoperative radiotherapy. Now, oral hairy leukoplakia, histopathology. Oral hairy leukoplakia, histopathology. Now, this was slightly tricky question, okay? Hyperkeratosis was given, ballooning cells were given, and parakeratosis was given, okay? Yes, all these three things are seen in oral hairy leukoplakia. Actually, it was parakeratosis. Parakeratosis. Parakeratosis, okay? Now, hyperkeratosis. Now, which is the most prominent feature of oral hairy leukoplakia? It is hyperkeratosis and marked parakeratosis. But also we see acanthosis is caused by the ballooning coilocytic-like cell. But the prominent feature is hyperkeratosis and parakeratosis, which is seen in oral hairy leukoplakia. Now, this was directly picked from this image, okay? Hyperkeratosis and parakeratosis, which is seen here, that it is seen as marked, which is seen more commonly in oral hairy leukoplakia. Now, which are the following microorganisms seen in the parakeratinized layer and stain used? Okay, so I don't know what was the other option, but what the students told me that in the superficial layer. Now, candidiasis, it is basically, it was hyperplastic candidiasis. Hyperplastic. One second. Was hyper. It got stuck. It was hyperplastic candidiasis. Now, whenever the candidiasis, it will, yes, now. Candidiasis, it gets attracted to the superficial layer, okay? Now, the candidal hyphae is seen in the superficial parakeratinized layer, and the stain which is used is the past stain, okay? So, mostly here the answer is hyperplastic. No, dear, I'm not going out. Okay, can you guys tell me the questions related to lichen planus? So there was another option which was given as lichen planus. Okay. But I need the histopath. I need histopath. Okay. Now identify the histopathological image. Now this question was recently discussed in your INI November, which was asked. Okay, 1 week back I had taken the session and I had discussed this question. Okay, now here if there is a big samema-like bodies are seen with loosely arranged cellular fibrous connective tissue, then here the answer is samematoid ossifying fibroma. So this question was discussed already. Okay, now which feature will confirm that patient is having mucous membrane pemphigoid over the other erosive lesion? Okay, now what I had said that this is the exact image of the class, life class. Okay, so cicatricial pemphigoid, it is also called as benign mucous membrane pemphigoid. Now in cicatricial, generally the blisters, they heal with scarring. Okay, but when is present in the oral cavity, it do not scar, and most common site is gingiva. And what I had written, this can also be asked as a MCQ question. It is not been asked previously. It has high chances that it might come in your INI paper, and this question was directly picked from, I can say that from my live session. Okay, so here the answer is gingival scarring is not present. This question is already discussed, I think, about the oral hairy leukoplakia. Now, chances of squamous cell carcinoma is more in. Now, it is a very controversial question. It is said that squamous cell carcinoma, it is divided into developed countries, developed and developing. So, India is a developing country. Yes. So, India is a developing country. India is a developing country. So it is said that in a developing country, here there is a more use of erica nut chewing. So erica nut, it is generally kept inside the buccal mucosa. So more chances of squamous cell carcinoma in the oral cavity, it is seen in buccal mucosa. Okay. So here the answer is alcohol and the erica nut. Okay. Alcohol and tobacco. Alcohol and tobacco, it is generally seen in the developed country and most commonly seen which location? It is tongue. Okay. So most common location of oral squamous cell carcinoma, if you get the question in NEET, okay, you will mark buccal mucosa. Buccal mucosa. Here the answer is alcohol and erica nut. Okay. HPV, they have not mentioned which type of HPV, low risk or high risk. High risk HPV has more chances to develop oral squamous cell carcinoma. Now, there was a diagram of OPG showing the cyst. Okay. Now, there was an impacted tooth, as students had told me that, ma'am, there was an impacted tooth which is present in the 4A, and there was a radiolucency which was covering around the impacted tooth. So any radiolucency covering around the impacted tooth, that means they are asking about the dentigerous cyst. Okay, dentigerous cyst. So here the answer is dentigerous cyst. Now, maximum increased chances of the recurrence of the cyst. Very easy question. Okay, it is OKC. OKC has the maximum chances of recurrence. Now, OKC, as you all know, that it spreads in the anterior-posterior direction. Okay, while all other cysts, they expand in the buccolingual direction. Again, this question is already discussed. Gingival scarring is not present. Okay. Now, pemphigus vulgaris, I have shouted in the class. Okay. It is very, very, very important. And it is this question is been asking in your paper from past 5 years. So, what do we see in pemphigus vulgaris? We see suprabasilar slit. So, yes, it is intraepithelial and it is seen above the basement membrane. Okay. Very direct question. And we have done this in our class. Okay. Yes, so this was the recall with respect to oral pathology. I hope you guys have done your paper very well. And if you guys have any doubt, you can just contact me on the Telegram or you can just directly call me. Okay. So I wish you all bestest of luck. And please write the feedback with respect to the oral pathology. How was the live class and how you guys have interrelated the live class and you have solved the MCQs and how it has helped in your paper. Okay. अच्छा, मैंने जो बोला सब आ गया. Thank you so much, Adya. Thank you so much. Okay. And I wish कि नीट पेपर में भी मैं जो बोलूं वो सब आ जाए क्वेश्चन में, है ना? So all the best, guys.
Okay, so am I audible? So let me just check with the students. Am I audible so that we can start the session? Okay. So now, how was the anatomy question being asked for your examination? What was the level, dear students? What you felt? Okay. So how was the anatomy paper, dear? Whether it was easy, moderate, or it was difficult? Please let me know. Yes, ma'am. It was great. Okay, I am audible. Yeah. Okay. Good evening, Nami. Good evening, Gotwami. Good evening to everyone. So let's solve the recall anatomy papers of INI-CET exam. So yes, let's start with that. So yes, let's start with the first MCQ. So which of the following muscle is innervated by deep branch of ulnar? So I think many of the students must be telling it was like facing Sohaib Akhtar. Okay, okay, okay. So not worried here. So actually, this was a question of upper limb, and basically when I talk about the dental INI-CET, most of the question comes from the embryology, head and neck parts and all, but it came from the upper limb. So no worries, we will solve it. Actually, so only in your INI-CET test series also few MCQs I take from the other body parts also. So when we are talking about the ulnar nerve, it's very important for you to understand that ulnar nerve is basically a nerve which is giving innervation to the muscles of hypothenar region. If this is the hand, so just see here, if this is the hand here, this is the thenar region in which we have got the thenar muscle. This is the thenar eminences, which is formed by the flexor pollicis brevis, abductor pollicis brevis, and opponens pollicis. When I am talking about the muscle which is lying close to the little finger, in this region below it, this is actually the muscle of hypothenar region. So we will have flexor digiti minimi, abductor digiti minimi, and opponens digiti minimi, all is supplied by ulnar nerve. Actually, here, if I have to mark the most correct answer, the correct answer will be adductor pollicis. Actually, adductor pollicis is the muscle which is lying deep to thenar region, and adductor pollicis muscle is also called as the graveyard of ulnar nerve. It is also termed as graveyard of ulnar nerve because ulnar nerve ends by giving innervation to this muscle. So basically, abductor pollicis brevis is the muscle of thenar region. So it is not the right answer. Palmaris brevis is a muscle. Palmaris brevis is a muscle of panniculus carnosus group. What do you mean by the word panniculus carnosus, my dear students? Panniculus carnosus means the muscle which is residing in the superficial fascia of the hand. So this is the superficial fascia of the hand. So basically, this is also innervated by ulnar nerve, but deep branch of ulnar nerve की बात की गई है. So we will go with the adductor pollicis as the most correct answer. Opponens pollicis is again a muscle of thenar region which can also get innervation from ulnar nerve. But if I have to pick the most correct answer, we will go with that of the adductor pollicis. Deep branch of ulnar nerve innervates following muscle. It is innervating hypothenar muscle, which was not given in the option. Opponens digiti minimi, introcei muscle, third, fourth lumbricals, and adductor pollicis. So basically, yes, flexor pollicis brevis, also opponens pollicis muscle is innervated by it. But if I have to pick most correct, actually all the options are very near. But if I have to go with the most correct one, I will go with adductor pollicis muscle. Is it okay, everyone? Have you understood? Nimesh, Aditi, Gotwami, Nami, Prashant. So if I have to choose the most correct one among the option, I will go with adductor pollicis muscle, the muscle residing in the thenar region, deeper region. It's a graveyard of ulnar nerve, and ulnar nerve ends by innervating this muscle. So we'll go with the option A. Is it okay, everyone? Can we move on to the next one? Okay. Can we move on to the next question? Understood? Yes, dear. Okay, thumbs up goes for you. Ostration is seen in, this is easy one. Ostration is seen in esophagus, stomach, small intestine, large intestine. Okay, Dr. Aditi Agarwal, Nami, Ruby, Gotwami, everyone is telling it's okay. Okay, so let's move on to the second one. Ostration is seen in esophagus, stomach, small intestine, or large intestine. So I think most of you must have given the right answer. And I'm quite clear the right answer is large intestine. Yes, Nami, large intestine. Actually, there are three cardinal features. For identification of large intestine, we have got colon, large intestine, the three cardinal features are, it will have the presence of Taenia coli, it will have the presence of hostration, and it will have appendices E. coli, which is the fat pouches. So hostration is the feature of large intestine. Like I just want everybody to revise the features of the cardinal features of large intestine. The cardinal features of large intestine is Taenia coli, hostration, and appendices E. coli. Appendices E. coli. Taenia coli is actually three bands of smooth muscle that runs lengthwise along the large intestine, and they create pressure on the intestinal wall, which will be present in the form of bulges and hostrations. Okay, that is medial longitudinal muscle coat. Actually, all the Taenia coli converge at the base of appendix, and these are three longitudinal bands. Now, when you see the large intestine, it will have hostrations in this form, and it is a pouch bulging in the intestine in between Taenia coli. Appendices E. coli is a fat pouches, visceral peritoneum on the surface of colon. I just want everybody to see two images. One is the cross-sectional view and the other is the surface view of colon. So we are talking about cross-sectional view and the surface view of the colon, large intestine. The three cardinal features, Taenia coli, the longitudinal muscle band. Appendices E. coli is the pouch and sacculation and hostration. So these are the three features. So definitely hostration is the other name of sacculation. So we'll mark it as the right answer, that is large intestine. Everyone, I think, must have marked this answer right. Is it okay? Nami, Ruby, Dr. Aditi, Gotwami. Let's move on to the next one. I think most of you must have marked this right because this was the easy one. Few are the confusing MCQs which I have targeted here also. So now this bone forms all of the following joint except. So which bone is this? Can anybody tell me which bone is this? This is a cervical vertebra. So which cervical vertebra? What is the name of this bone? Everyone, Nami, Ruby, Aditi, Gotwami. Yes, which is this image is of which bone? I am just enlarge it. Ma'am must be tried reviewing questions of MBBS and BDS. No, dear, I'm all right. Okay. No, dear, I'm all right. So basically, if I'm talking about, yeah, absolutely correct. Neelu has given the correct identification. This is the odontoid process. This is the odontoid process. This is the odontoid process. That is dense. This is the dense. Yeah, this is the dense and the odontoid process of axis, which will articulate with the atlas to form median atlantoaxial joint. And when I am talking about median atlantoaxial joint, what is the function? It is causing the rotational movement. Okay. And actually, so pivot is definitely there. So pivot is definitely, and also if I'm talking about superior inferior articular facet, when I am talking about the facet joint. So in case of vertebras, there is facet joint. What do you mean by the facet joint? That means superior and inferior. That means superior and inferior articular facet joint is formed, and this will lead to the formation of plain type of synovial joint. This will lead to the formation of plain type of synovial joint. So superior inferior facet joint, that is also called as zygapophyseal joint. So zygapophyseal joint is actually here as is the right answer. Okay, D is syndesmosis. Actually, the correct answer is symphysis. We know that intervertebral disc is there. Intervertebral disc is there, and which is in between the vertebrae. Last option was condyloid. The correct the correct answer will be symphysis. Why? I will tell you now. Know the axis vertebra. If I talk about the axis vertebra is not forming symphysis joint. Actually, intervertebral disc is present, which is not a mobile joint. It is secondary cartilaginous joint. Minimal amount of movement occurs there. But if I am talking about atlantoaxial joint, it is a pivot type of synovial joint, which is also called as trochoid joint, and there is rotational movement occurring there. So odontoid process dense will articulate with the ring of the atlas, and that will lead to movement, and that is leading to rotational movement. Intervertebral disc is secondary cartilaginous joint. And secondary cartilaginous joint, other name is symphysis. What is its other name? Its other name is symphysis. So if I have to choose one, symphysis is the joint not formed by that of the axis vertebra. Is it okay, everyone? Have you understood? Because we know that rotational movement, you can see rotational movement is possible and between the axis and atlas. So definitely A is the right answer. Ritik, Neelu, Dr. Anjali, Nami, Nitika, let's move. Saloni, let's move on to the next. Yeah, which this arrow shows the point of attachment of its structure. So can you see the green color structure? Can you see the green color structure? So when I'm talking about the green color structure, so I just want to enlarge this. So this green color highlighted area is, if I'm talking about this green color highlighted structure, this green color highlighted structure is external occipital protuberance. What is it called as? It is called as external occipital protuberance. And many structures, external EOP, in short form we write it EOP. External occipital protuberance has got attachment of many important structures, and definitely the right answer is trapezius. So if I have to choose the right answer, the answer is trapezius. Let me revise you all the structures attached on external occipital protuberance. External occipital protuberance, you can, if you will see the skull, you can palpate it posteriorly. The elevation on the occipital bone posteriorly is external occipital protuberance. So basically, so ligamentum nuchae is attached. So yes, actually the structure attached on the external occipital protuberance is nuchal ligament, which attach on external occipital protuberance and also the crest below. Trapezius muscle attached to the tip, that is inoid. Tentorium cerebelli is attached on the internal surface of external occipital protuberance. So I think one of the student is telling me, ma'am, ligamentum nuchae was also there. So basically, if I am talking about one of the option, he is telling, very good for revising the option. So this is ligamentum nuchae. So basically, if you are telling ligamentum nuchae also, and if the arrow was in the center, so if the arrow external, if the arrow was on the center of EOP, on the highest point of EOP, then the answer is trapezius muscle. So basically, trapezius muscle is attached on the tip of EOP. If the arrow, can you tell me, I think they will, if the, yeah, ligamentum nuchae can also be the right answer, but if the arrow is on the external occipital most prominent point, that is called as inoid, so then the answer will be, trapezius. So you have to tell me the correct arrow. If the arrow is on the external occipital protuberance and slightly lower to it, then the answer will be ligamentum nuchae. But if it is on the highest point of EOP, that is external occipital protuberance, most protruded point of EOP, external occipital protuberance, then the answer will be trapezius muscle. I think the arrow was on the midpoint of EOP, so the answer is trapezius muscle. Yes, they will, then the answer will be trapezius muscle. Otherwise, it was ligamentum nuchae. And also tentorium cerebelli is attached on it. Now moving to the next. All these are correct regarding movement caused by muscle of mastication except. Actually, this can be a match the following, and exactly the match the following option was not with me. So not with me, then it will be, if it is lower, then it is lower and to the line, then it will be ligamentum nuchae. If it is on the highest point or the most protruded point of EOP, then it will be trapezius muscle. All these are correct regarding movement caused by muscle of mastication except retraction, elevation, depression. So for solving this MCQ, right? I just want you to give you a quick recapitulation of individual muscles of mastication. So see here. So for example, if I am talking about action of masseter muscle. So primary. So my dear students, actually, if I am talking about, so quickly we can solve this. If we have got 4 muscles, we have got 4 primary muscles of mastication. Is it okay? 4 primary muscles. So if I am talking about masseter muscle, the masseter muscle has got an action of elevation of mandible. It elevates the mandible. It is also having the action of, it is also causing the action of protrusion of mandible. It is also causing the action of retraction. Okay. So masseter is a muscle of mastication which is having multiple action to perform. It is actually when masseter muscle contracts, it causes elevation. Superficial fibers can cause protrusion, and the intermediate fibers can also cause retraction. Okay, that means masseter muscle has got multiple action. Now coming to the next muscle, that is medial pterygoid. MP for medial pterygoid. Medial pterygoid muscle is causing protrusion. जो protrudes, it also causes lateral movements. It also causes elevation. It also causes elevation. It also causes elevation. If I am talking about lateral pterygoid muscle, a very important action of lateral pterygoid muscle is causing protrusion. The lateral pterygoid moves the mandible forward. It is the one muscle which is causing depression of the mandible, side to side movement, and also hinge like rotation. So this lateral pterygoid muscle again has got multiple action to perform. It is causing protrusion, depression, side to side movement, and hinge like rotation. Temporalis is a muscle. When I am talking about temporalis muscle, it is a fan shaped muscle which is not only causing its posterior fibers are causing retraction, and it also causes elevation of the mandible. So it is involved in stabilizing the jaw. The posterior fibers pulls the mandible backward retraction, and it also causes elevation of the mandible. So in short, I have summarized the action of primary muscles of mastication. Acha, retraction, medial pterygoid and temporalis was given. Okay, so medial pterygoid is not causing retraction. Yes, medial pterygoid is basically not causing retraction. If I talk about medial pterygoid, yes, medial pterygoid. Yes, medial pterygoid is not causing retraction, so that will be the right answer. Retraction, if it is given medial pterygoid, so that will be the right answer. It is not causing retraction, is caused by posterior fibers of temporalis, and retraction is also done by the intermediate fibers of masseter muscle. Masseter muscle. Is it okay? Yes, yes. So I think it is okay, dear. Everyone okay? Yeah. So infrahard muscle causes depression. No worries. Infrahard muscle causes depression, dear. Yeah. So don't worry. We will have an elaborate description of INI-CET recall once again, where all the correct option along with the match the following will be done. But I have enumerated all the action, and I am quite sure if it was given retraction by medial pterygoid, then that would be the right answer. Now coming to the next option, next question. Is it okay? Can we move to the next question? Everyone, can we move to the next question? Question number 6. Lateral pterygoid muscle marked on the dissection specimen of the head. Coronal, it is not a coronal section. This image is actually not taken as a coronal section. Okay, so it was about lateral pterygoid muscle. I presume the question was about lateral pterygoid. So what is the action? So what is the action of this muscle? What is the action of this muscle? A unique action when the action is against resistance. Depression, absolutely correct. Absolutely correct there. Yes, against resistance, the action is depression. Absolutely correct. This is the lateral. This muscle is LP, lateral pterygoid muscle, which is inserting into articular disc and TM joint, which is inserting into TM joint, fibrous capsule, articular disc, and pterygoid fovea. Basically, lateral pterygoid muscle has got superior and inferior head, and multiple action is there to perform. But if I have to talk about most important option and the right answer, definitely lateral pterygoid muscle action is against the resistance, and it is involved in forceful mouth opening. So if resistance is applied, see here, mandible resistance is applied, and I am opening the mouth. That action is done by lateral pterygoid muscle. So that will be the right answer. Depression. Yes. Thumbs up goes for you. Thumbs up goes for you. Primary function of lateral pterygoid muscle is it moves the head of condyle. It pulls the head of condyle, of mandible along the articular eminences. So it protrudes the mandible. The other action is that it helps in opening of the mouth against resistance. It is also a masticatory muscle, and it is also involved in side to side movement of mandible. Now, one of the question was very easy, which was about the derivative of second pharyngeal arch. Can you help me with the options? Can you help me with the options? Can you help me with the option? Which of the following is second pharyngeal arch derivative? Second pharyngeal arch derivative. Everyone? Which of the following is second pharyngeal arch derivative? Okay, stylohyoid was an option. Okay, stylohyoid, sphenohyoid, stylohyoid, sphenohyoid. Okay, any other? Stylohyoid ligament. Okay, stylohyoid ligament. Okay, sphenomandibular. Yes, better will be sphenomandibular. Yes, sphenomandibular. Okay, Merkel's cartilage. Yes, Michel's cartilage. So sphenomandibular is from the first arch. It is from the first arch. Michel's cartilage is also from the first arch. Right answer will be stylohyoid ligament. That is from the second arch. Stylohyoid is the right answer. So muscles of facial expression, facial nerve, stylohyoid ligament, all these are arised from the second arch, but Michel's cartilage is from first arch. Yes. So basically, you can go through the quick revision of the important structures derived. So first arch is the mandibular arch, and it is giving innervation to, it is, malleus was there. Malleus is also not. So malleus is also from first arch. Malleus is also from first arch. Stapes is from the second arch. So malleus incus is from first arch. Muscles of mastication, tensor tympani, tensor villi palatini, trigeminal nerve, and the terminal branch from all from the first arch. Second arch is giving rise to the part of hyoid bone, upper part of the body of hyoid and lesser corona. It gives rise to stylohyoid ligament, which is the right answer for the MCQ. Muscles of facial expression, posterior belly of digastric stapedial artery. Facial nerve is the nerve of second arch. Third arch muscle is stylopharyngeus muscle. Nerve is glossopharyngeal nerve. Fourth and sixth arch is giving rise to the muscles of larynx, pharynx. It gives rise to thyroid, arytenoid, and that of cuneiform corniculate aortic arch. So definitely the right. Okay, ma'am. Okay, so let's move. Yes, definitely we will move to the next. So may not move to, yes. Now, one of the question was, yes, dear, one of the question was about carotid body or carotid sinus. So basically, there was one question about carotid body and carotid sinus about innervation. So first thing is that it is exactly important for you to know what is carotid body and carotid sinus. Okay, so when I am talking about carotid bodies are sensory organs or part of peripheral nervous system, and it is involved for the, so basically if I am talking about carotid body, it is important for detecting changes in the arterial blood flow. So basically it is important for the partial pressure changes of oxygen, carbon dioxide and pH. So carotid body is innervate. If it was nerve supply, the question was about nerve supply, please let me know. Is the question about nerve supply? The question was about nerve supply, dear. So the nerve supply of carotid body is by 9th cranial nerve, also by the vagus nerve, and also by the sympathetic nerves of superior cervical ganglion. Superior cervical ganglion. Okay. So if it was of carotid sinus, then carotid sinus is responsible for controlling blood pressure. It is baroreceptor, and it is located at the bifurcation of common carotid artery below the angle and at the level of thyroid cartilage. So basically, its innervation. Carotid sinus primary innervation is by glossopharyngeal nerve, also by the other nerves, that is vagus and cervical sympathetic trunk and hypoglossal nerve. Both were given. Nerve supply, ma'am. Oh, that was confusing. Now tell me. No worries, I will solve it. Tell me, the question was about carotid body or carotid sinus. What was the location? Can you tell me exact location? Can you? If it was not mentioned whether it is carotid body or carotid sinus, give me the exact location. If the question was about carotid body, it should be behind carotid bifurcation. And if the question was about carotid sinus, it will be just above carotid body. If it was of carotid sinus, the right answer will be bifurcation area. So just above the bifurcation or behind the bifurcation. Okay. So my dear, if the question was just one nerve and it was about carotid sinus, then the right answer will be actually ninth cranial nerve, vagus nerve, and also sympathetic nerves, that is cervical sympathetic nerves is the right answer. So basically it is by the cervical sympathetic tongue, all are right answer. But if you have to choose one, you will go with glossopharyngeal nerve if the question was about carotid sinus. So carotid sinus is a bulbous dilatation at the internal carotid artery located just above carotid body. Ninth, 10th, ma'am, calendar were okay. So bifurcation. So just okay, bifurcation. If it was, I think ninth cranial nerve is the most correct answer, because there were, if you have to choose one, then ninth cranial nerve, glossopharyngeal is the most correct answer, because if it is carotid sinus, it will be just above. It will be slightly. If the just above carotid artery bifurcation, just above carotid artery bifurcation is carotid sinus, and it is primarily innervated by glossopharyngeal nerve, also take contribution from vagus and cervical sympathetic trunk. So you have to go with glossopharyngeal nerve. Okay. Now coming to another question which was slightly confusing, but we will solve it. Pterygomaxillary fissure. Pterygomaxillary fissure and maxillary. So an image was formed for the pterygomaxillary fissure. As you can see, the green color arrow here. The green color arrow here is towards this foramen-like structure, that is pterygomaxillary fissure. So this is the arrow which is marked at pterygomaxillary fissure. So here the question is, which vessel is terminating at this location? So basically external carotid artery can't be the right answer, because terminal branch of external carotid arteries are maxillary artery and superficial temporal artery. So they are not at the level of pterygomaxillary fissure. Superficial temporal artery is over the scalp temporal region, and the maxillary artery will start in the infratemporal fossa. Sphenopalatine artery itself is the terminal branch of maxillary artery. Deep temporal artery is a branch from second part of maxillary artery. Okay, so deep temporal is a branch from second part, and second part of maxillary artery is lying behind the lateral pterygoid. So these two is not the right answer. If I have to pick, I will go with maxillary artery, because third part of maxillary artery traverses through pterygomaxillary fissure and there it terminates. Sphenopalatine artery, if I talk about, if it is carotid body, then it should be both 9th and 10th. But I think carotid sinus must be asked, because both the nerves was not in option. So carotid sinus must be asked, because everyone is telling it was slightly above the bifurcation. So carotid sinus, and if it is dilated in the image, then carotid sinus, and that will be the 9th cranial nerve. Okay, smile. Maxillary artery is the right answer. Sphenopalatine artery also not exactly terminate at this location. So pterygomaxillary fissure has got following structure. The terminal, please note down, the terminal part of maxillary artery passes through pterygomaxillary fissure. So this was asked in the MCQ, and this is the most correct answer. The terminal part of maxillary artery passes through pterygomaxillary fissure. Posterior superior alveolar nerve lies here, and sphenopalatine vein lies here. So Sphenopalatine artery itself terminates into posterior nasal artery, posterior lateral nasal artery, which supply the lateral wall of nasal cavity, and posterior septal branches are there when it is at the branches with greater palatine. So these are terminal branch, which is not exactly at the location of pterygomaxillary fissure. So if I have to choose one, I will definitely go with the maxillary artery. This is the location of pterygomaxillary fissure, as you can see, and which is a communication with the pterygomalatine fossa and infratemporal fossa, and terminal branch of maxillary artery is located at this location. Now, one of the image-based question was this. Everyone. Everyone, one of the image-based question was here, in which identify the marked structure. Arrow was marked here. Can you see this image? This is an embryology question. Arrow was marked somewhat here. And you have to tell that whether it is secondary neural plate, whether it is a neural groove, or whether it is a primitive strip. So if I have to go with the most correct answer, okay, exact this image. Okay, then a thumbs up goes. Yes, exact this image. Very good. So then a thumbs up goes for you, and the correct answer will be notocode. The correct answer will be notocode. So basically, notocode is a rod-like structure which start developing from 17th day of intrauterine life, and it lies above primitive streak. Notocode is lying above primitive streak. It lies above primitive streak. It lies above primitive streak, and in the adults, it forms. Week was asked. Yes, 17 week. It start forming by 17 days. So exactly that weak question is other one. I will also tell. It will form nucleus pulposus of intervertebral disc. Actually this notocode is the blueprint for the development of central nervous system, and you can just compare this image with this image. So what you can see, if the arrow was exactly marked at this location, this is notocode, and below it, if it was marked, then it was primitive streak. As shown in the image. This is primitive streak and this is the notocode. So we'll mark notocode as the right answer. Yes, posterior neuropore. Yes, I will tell you, dear. I will tell you posterior and anterior neuropore also. Now, one question I think in the earlier part students were discussing, there was one question about prefrontal gyrus. There was one question about prefrontal gyrus and what will happen if there is injury of prefrontal gyrus. Actually, this area of brain is related with the psychiatric function, and actually this is the area of anterior most part of the frontal lobe, and this is exactly related with the personality of the patient. So this is the exact location of prefrontal cortex, and the important function of prefrontal cortex is that if I am talking about the function of prefrontal cortex, it is very important. Why? Because it is exactly influencing the determination of judgment, concerned with moral and ethical awareness, social behavior. It is also concerned with the social behavior. And exactly if I talk about this area, so basically this right answer will be the patient is not able to emotional imbalance. Yes, emotional imbalance. If there was an imbalance, if there is an option of social behavior and emotional imbalance, so that is the right answer. Yes, emotional imbalance is the right answer. Actually, some of you were, yes, emotional imbalance is the right answer. Okay. Okay, dear. So some of the students were telling about temperature changes, action measures. So emotional imbalance will be the right option, will be the right answer. One of the question was patient. So this is PT, means patient is having syndromes. Patient is having sign and symptoms of tremor, slow movement, poor posture, speech changes, worthy changes, poor balance. Okay. So this was a case of injury of which part? This was a case of Parkinson's disease. This was a case of Parkinson's disease. Yes, emotional function. Yes, Nami, emotional function is the right answer. Yes, if you want the option, I will just see. I have clicked the image of the person who was asking this. I think Yeah, there I will just check. Yes, they were telling it that option, like other option was smell. Yes, the judgment. Okay. Yes, the right answer here will be the part of basal ganglion. Actually, this is involving the substantia nigra. This is involving substantia nigra, and there is a this is involving substantia nigra, which is related with the dopamine. Actually, this is a condition of progressive brain processor where the dopamine that occurs when neurons introduce less dopamine, and this will help. This will lead to movements, pill rolling, tremor, movement, stooped posture, mask-like expression, and this is a case of Parkinson's disease. Yes, smile, judgment, and all is the right answer. Emotion, judgment, and all. No. Okay. So this is a case of Parkinson's disease. Okay. Temperature is spinothalamic tract, lateral spinothalamic tract. Nami, temperature is spinothalamic tract. Now, one of the question, if it was of caudal, arrow or mark, one of the question was posterior neuropore closer. This is again an embryology question, posterior neuropore closer. So actually there are two, one is anterior neuropore, one is anterior neuropore or cranial neuropore, and when there is, so we have to go with posterior neuropore closer. So both dates and somite stage you have to know. So actually the neural tube is communicating anteriorly and posteriorly, and anterior neuropore closes by 25 days. And 18 to 20 somite stage, and posterior neuropore closes by 28 days, that is corresponding to 25 somite stage. If it was posterior neuropore and day, then you will go with 28. So yes, so one of the story, yeah, ma'am, if there is more both judgment and emotion, then Dr. Meher judgment, then you will go with Dr. Meher, then you will go with judgment. Here, judgment, then if there was a judgment given, judgment is the best answer. So the judgment is the best answer. So judgment will be the answer. Decision making, judgment is the most correct answer, because emotion is also with the limbic system. Judgment and decision making is the most right answer. Decision. Is it okay, Dr. Meher? Judgment will be the right answer. Okay, Dr. Meher, is it okay? Then judgment and decision. So if, yeah, so it will be judgment, dear, judgment. Okay. Okay, dear, seeing your image. Okay, emotion is also social awareness and all is also there, and but emotional imbalance will also with the limbic system. So we will go with judgment in that case. Okay, so you will go with 28. Posterior neuropore, most correct answer will be 28. 28 is the most correct answer. So is it okay? Can we end now? Everyone, can we end now? All the best. Keep studying and we'll meet again with the more of the session. I hope I give you blessings that you crack the examination with a good rank. All the best, dear. Can I end now? Can I end now, dear? Can I end?
सर
ठीक. All right. So a very good evening, everyone. I hope you have done the session well. And let me just discuss the questions of the general medicine. So there are only two questions of the general medicine. And these two questions of the general medicine was one question related to the resuscitation and the other question was related to the diarrhea. So let me take up the first question. So this is the first question. Which of the following is true for the infant and pediatric cardiopulmonary resuscitation? So the examiner was very clever in framing the options, right? You know, he has confused you a lot by giving whether it's like one rescuer or whether it is two rescuers. And he has like, mixed the options in the permutations and as well as the combinations. Okay. Now, if suppose like if the individual is a single rescuer, then 30 compressions have to be given to 2 breaths. Okay. So 30 compressions and 2 breaths if it is a single rescuer. Now we have only one option with a single rescuer. Okay. Where it has been given as 15 compressions and 1 breath, which is a wrong statement regarding the single rescuer. Right. Then you take the 2 rescuers. That means double rescuers. Okay, 2 rescuers. If it is 2 rescuers, then one rescuer has to give 15 compressions and the other rescuer will be giving 2 breaths. Okay, so here it is 15:2. Now, what do you think is the correct answer now? The correct answer, one second. Yeah, the correct answer is the 15:2 is the correct answer. Right? Just 1 minute. Yeah. So I hope everyone is clear with this. Yes, the answer is B. Now, you take the second question. Second question was a very simple and straight question. It was only this particular question where there was, definitely there was a scope of confusion if you are in a state of stress. But if you understand this question in a very calm and cool state, then it is a very simple and easy question, right? And the other question from the medicine point of view was this. Like we have a 15-year-old boy, right? He had loose stools with fever. Okay, this is very, very important. Fever. And there was mucus discharge in the stool. And practitioner have given 2 grams loperamide orally once daily. What is the true statement regarding this regimen? Now, the presence of fever along with the mucus discharge in the stool, what is this suggestive of? This is suggestive of that the individual had the infection. Okay, that is the first point. Now, so the options are, it is rational treatment as it will relieve the symptoms first. Now, whenever there is any infection, what is loperamide actually? Loperamide, it is an anti-motility drug. That means what this loperamide will do is, it will reduce the gut motility. Right? Loperamide will reduce the gut motility. Now, whenever there is any infection, right? Whenever there is any infection, you should not give these anti-motility drugs. When you give anti-motility drugs, what will happen? I will tell you in the next option. So it is rational as it will relieve the symptoms? No, it is a wrong statement. Okay, next. It is irrational treatment as it will increase the chance of bacterial infection. That is a correct statement. So whenever you give anti-motility drugs in the presence of an infection, right? Whenever you give anti-motility drugs in the presence of the infection, what will happen? The gut motility will not be there. The forward movement of the feces will not be there, right? And there will be precipitation of the infection, right? There will be precipitation of the infection. Okay, that's a very, very important point. You should not give anti-motility drugs when there is presence of infection. If it is non-infective diarrhea, then you can give these anti-motility drugs. And you take the third option. It is irrational because it will worsen the symptoms. Okay, it will worsen which particular symptoms? Like whenever the individual loose stool will not worsen, right? The loose stool will not worsen with the, right? The loose stool will not worsen whenever you give loperamide, right? What will worsen is the fever will worsen. The loose stool will not worsen. Okay. In fact, the loose stool's frequency will reduce. Okay. So that is the reason why C is not the correct answer. Then it is rational as it will cause sedation and relief of symptoms. No. Right. If this loperamide is not the one which will cause the sedation, so that is completely out. So what is the correct answer now? It is irrational treatment as it will increase the chance of the bacterial infection. That is a correct statement. Okay. So first question was like infant and pediatric CPR. If there is 2 rescuers, 15:2, that is a correct answer. And for the infective diarrhea, you should not give anti-motility drugs. If you give anti-motility drugs, there is increased chances of the infection. Okay. So these were the 2 questions from the medicine, right? So mine is a very short session, right? So I'll just wind up. I hope you people have done these 2 questions correctly. Yes or no? Please answer me in the chat box. These 2 questions of yours were right or wrong? Okay, great. So I'm happy for those who have answered them correctly, and I wish you all the best for your results, right? Thank you very much. And please text me after your results that you have achieved a very good rank. I'll be the happiest person and the entire team will be the happy for your ranks. Thank you very much.
Hello, good evening, everybody. Can you all see me, hear me? Just put it in the chat box so that we can start. Okay, got me. Can see me, hear me. All right. Am I audible? Am I audible? Okay. Okay, so let's start. How was your exam, guys? How was your exam? Good evening, Aditi. How was your exam? And were you able to solve OMR questions? Because that was, I think, easy to moderate. So, and we have discussed that in our classes also. Yes. Okay. All right. So let us just start with the OMR recall session. All right. Question first was two radiographs that can be used for localization in two-dimensional radiography are. So we have discussed this many a times, that is localization techniques, right? Localization techniques. So we had discussed about two localization techniques in our class, right? First is right angle technique and second one is the SLOB. Okay. So in this exam, they have asked about this right angle technique. All right, right angle technique. And we have studied this. I have shown this radiograph in our classes. So in right angle technique, we use two radiographs. That is IOPA plus occlusal view. Occlusal view, right? Occlusal view. IOPA gives us the position of, say, impacted tooth or supernumerary tooth. So whether they are mesially or distally with respect to some tooth, it will give us this position or this, you can say, mesial or distal positioning. Whereas this occlusal view, you can see here, this IOPA is giving us where exactly the impacted tooth is located, right? The second one is the occlusal. Occlusal view will tell you exactly it is located buccally or lingually, right? So here, can you see this tooth is located lingually or palatally, say. Okay, palatally to the tooth. So this is a localization technique, right angle technique. Okay, so two radiographs that we use are IOP and occlusal. So now let us just go through the options. Now here I cannot see IOPA plus occlusion. So which are the radiograph or which is the radiograph that can replace IOPA and that can give you same view, right? So if you can see here, this is a OPG. So OPG is just a magnified version, right? It is giving us same positioning where exactly it is located, and this occlusal will give us whether it is located buccally or palatally, right? So what is the exact or correct answer here? It is option A. It is option A. I hope you guys have marked the correct answer, right? This was easy question. Okay. So let us move on to the question number 2. Question number 2 was based on IBQ, right? And this is, they had given the upper lip swelling and they had just mentioned the sudden appearance of lower lip swelling, okay, which is, sorry, it is not lower, it is upper lip swelling, which is not pitting, okay, non-pitting right? And painless. Okay. And we had two options recalled. Option A is cheilitis granulomatosa and option B is angioneurotic edema. Okay. What is the correct answer here is sudden appearance, okay, sudden swelling and the non-pitting and painless. Okay. This is the exact characteristic feature of what? Angioneurotic edema. Angioneurotic edema, option B, right? Non-pitting is what? Non-pitting edema. Whenever you say non-pitting means when you apply pressure, okay? When you apply pressure, it does not leave indentation. It does not leave indentation. That is non-pitting, okay? And this angioneurotic edema, we have discussed this. This is the sudden appearance. This is basically allergic reaction. Okay, allergic reaction to food and drug. Okay, most common causes are food and drug. Right, sudden appearance, allergic, IgE mediated hypersensitivity reaction. Right, and what is the drug of choice that is there in angioneurotic edema? It is antihistamines, since this is an allergic reaction. All right. So the correct answer is B. So cheilitis granulomatosa. First of all, it is a soft swelling in cheilitis granulomatosa. It is a soft swelling, okay, and it is not, or it does not develop suddenly, okay. It gradually or slowly over months and years. Okay. And this is associated with, we know one syndrome which is associated with cheilitis granulomatosa, right? Which is that syndrome? We have Mulkerson-Rosenthal syndrome. So in which we have association of facial palsy, fissured tongue, and cheilitis granulomatosa. So if they would have given this association of all the three features, then we would have marked cheilitis granulomatosa, right? So I hope this is clear and you people have marked it correct. Okay. Now question number 3. Question number 3, IBQ based. Okay, they had given this OPG and there was well-defined corticated radiolucency which is associated with impacted tooth. Now again, coming to the options, we have OKC due to impacted 8, dentigerous cyst due to impacted 8, residual cyst due to extracted 6, traumatic bone cyst. Clear answer here. Impacted, as long as you hear the term impacted, okay, and the cyst involving the impacted tooth occurring in the third molar region, go for dentigerous cyst, option B. Okay, option B is the correct answer. All right. Now, question number 4, tumor suppressor gene in nevoid basal cell carcinoma, where we see this multiple OKCs, What is the correct answer here? PTCH. Again, easy, direct question, easy question. All right. Moving on to question number 5 right now, craniosynostosis syndromes. Okay, so we have seen this craniosynostosis in 2. So we have discussed the 2 conditions in which there is a craniosynostosis, right? Craniosynostosis seen in Krausen syndrome, and the second one is the hypophosphatasia, right? We have seen this 2 condition in our classes where we see craniosynostosis. What is craniosynostosis? Is a premature closure of suture. Premature closure of sutures, right? Now, this occurs due to defect in which gene? It is FGFR. Now, FGFR is nothing but the fibroblast growth factor receptors. Okay, fibroblast growth factor receptors. And these are the genes which are commonly involved in this growth and differentiation of cells, right? And mutation of which can lead to abnormal growth of skull and the face. Okay, so correct. Question 5. Yeah, I can see many people are marking correct or have marked correct answers. Very good. Okay, now teardrop shaped radiolucency seen bilaterally, okay, on OPG is most commonly. Now, whenever they give this bilateral term, bilateral, okay, so teardrop shape radiolucency. Now, here in OPG, can you all see this teardrop shaped radiolucency on both the sides? On both the sides, there is a teardrop shaped radiolucency, right? What is it? What is it? Can anybody answer? What is this teardrop shaped radiolucency? Okay, I'll give you a clue. Here we have a pterygoid bone. Okay, here we have the pterygoid bone. And here we have the maxillary bone, zygomatic process of maxillary bone. Okay, so between them we have space or fissure. Between them we have this teardrop shaped radiolucency, okay, which is a space or fissure. Okay, so what is that? What is that? It is pterygomaxillary suture. It is pterygomaxillary suture, right? Very good, very good. Okay, now next question. Okay, come on. This was asked in INI-CET exam last May exam, right? Parallax is seen due to. This is very easy. Okay, TYQ है. Okay, ये तो आना ही चाहिए, right? Parallax is seen due to. So we have discussed this in our classes also, in PYQs also. Okay, parallax phenomenon is seen with the or when we use double emulsion film, right? So what is this parallax? Is the unsharpness around the sharp image, right? So we have seen that the distance between the source, distance between the object and the film. So object is this, our tooth is the object, film is our receptor, right? So distance between them should be as small as possible to get sharper image, right? To get sharper image. Now, when we have double emulsion layer, the second layer is having larger distance between the object and the film, right? As compared to the first layer, first emulsion layer. Okay, so obviously the image formed on this layer will have this unsharp, you can say, boundary around it. That is called as parallax. That is called as parallax. And this is seen when we use double emulsion film. Okay, double emulsion film. All right, question 7. Option D is the correct answer. Right? Now, moving on to question 8. So this was kind of difficult. We have not discussed it. This is out of box question. Okay. So silver in fixer can be disposed by, right? Silver in fixer can be disposed by. Now, I'll tell you, we have this 4, you can say, methods by which we can separate silver from the fixer solution, right? So first method is electrolyte desilvering. Electrolyte desilvering, in which what we do is we pass the current, electric current, through the fixer solution, right? When we pass electric current through the fixer solution, the silver ions gets deposited at the cathode, right? Silver ions get deposited at cathode, and then we can separate the silver from the solution, right? The second method that we have is the metal replacement. Metal replacement. What is metal replacement? We dip iron in the fixer solution. So this iron will replace the silver ions, okay, through chemical reaction. Okay, and then this silver gets precipitated out, and then we can separate the silver by filtration. Okay, there is a second method. Third method that we have is the chemical precipitation. chemical precipitation. What is chemical precipitation? So we add sodium sulfide. We add sodium sulfide in the silver fixer solution. What this solution does is, by chemical reaction, this forms silver sulfide. This forms silver sulfide. Now, silver sulfide gets precipitated out, then we can filter it out. Okay. The last procedure that we have is the ion exchange. Ion exchange is the least commonly used method, right? Ion exchange. What we do is, we use resin material to separate out the silver. Resin material to separate out the silver, right? So, these are 4 methods by which we can dispose the silver. Okay, and among the given options, what we have is A, filtration before draining, B, use of chelating agent, C, replacement of material, D, leave the container for suspension. Okay, the most, I would say, correct option according to me is replacement of material. Okay, we are replacing, okay, the metal silver ion with the iron. Okay, add ion, pass currents, silver will get deposited at cathode, and then we can separate it out. Ion add karna hai with a chemical reaction. This silver gets precipitate, and then we can filter it out. Okay, here also silver sulfide gets precipitate out, and then we can filter this solution. Okay, so what is the correct answer here? Option C should be most, according to me, is the most correct answer. Okay, so I hope this is clear, guys. I hope this is clear. This was out of box question. Okay, it would have been better if you have left this answer question basically. All right. Okay, moving on to the question number 9. Which of this is the correct? Which of this is the correct statement? Which of this is the correct statement? I hope you all have solved this question. Now, remember these 2 terms. What is oligodontia here? Oligodontia is the developmental dental anomaly in which there is absence of 6 or more permanent teeth, excluding third molars, right? And what is hypodontia? Hypodontia is just a developmental anomaly in which there is an absence of 1 or 2 or 1 or more teeth, excluding third molars. Okay, so in the options we have, I think option C is the most probable or correct answer here, right? What is oligodontia? Is the 6 or more missing teeth, excluding third molars. All right. So question number 9, option C is the correct answer, right? Moving on to question number 10. Again, this we have discussed in our important topics of INI-CET YouTube session, right? So, triad of micrognathia is the question. Glossoptosis and airway obstruction is seen in. So, they have just replaced this feature with the complication of glossoptosis, right? So, here it should have been cleft palate. Here it should have been cleft palate, right? So what is glossoptosis here? Glossoptosis is the abnormal positioning of tongue. So why there is abnormal or backward positioning of tongue that can restrict the airway. Okay, so there is a you can say lesser jaw development due to which the tongue positioning is hampered. Okay, so that can lead to airway obstruction. So this is seen in Pierre-Robin syndrome. Pierre-Robin syndrome. Yeah. Option D is the correct answer. All right. Now, Question number 11. Question number 11 also I have discussed it in our live classes. Moth-eaten appearance seen in. So we were able to recall only two options. If you remember option C and D, you can post it in the chat box. Otherwise, moth-eaten appearance is seen in. So this we have discussed in our live classes. The same, you can say the radiograph. Okay, this is what moth-eaten appearance is, right? So moth-eaten appearance is nothing but a ill-defined lytic lesion or lytic area. Okay, there is a bone resorption and there is a ill-defined lytic area. Okay, and this is seen in malignancy cases, okay, squamous cell carcinoma, osteomyelitis cases, and osteosarcoma. Okay, rarely seen in osteosarcoma, but most commonly seen in malignancy and osteomyelitis, right? And this is also an example of moth-eaten appearance. Okay, lytic area, ill-defined lytic area is seen. And what is the correct answer here? Osteomyelitis, option A. Correct? So here we complete our recall session of OMR subject. If you have got any doubt, you can post it in the comments, right? And I hope most of you have got correct answers. So you can post your doubts in the comments, otherwise we'll conclude the session. Have you marked correct answers, guys? Dr. Aditi, Nami, Pooja, an aspirant, Sindhu. All right. So any doubts, or you can post your doubts in Telegram group also. If you can recall more questions, let me know. All right. So have a nice dinner and all the best, guys, for your results. Don't worry. It will all be worth it at the end. All right. Chalo, bye bye.
Hello everyone. Very good evening to all. I think the audio visuals are fine. Yes. So I welcome you all to this recall session of INI-CET MDS November 2024. Physiology questions with me, Dr. Abhirami, your faculty for physiology. Most of the questions what we saw, they were of direct type of questions, mostly one-liners, not much of clinical integrated questions in physiology. Mostly it was basic physiology. Let's move on to the discussion of the first question. What is the membrane potential when the direction of current is opposite? This is a very, very important topic. Repeatedly from equilibrium potentials and membrane potentials, questions are asked. So the answer to this is Nernst potential. What is this Nernst potential? Equilibrium potential is given by the Nernst equation of Nernst potential. Ions will keep on moving. At one point, when the electrical gradient matches with that of the chemical gradient, the movement of the ion will stop. So when the membrane potential, when the direction of the current is opposite, exactly the moment of the ion stops, and that we call it as the equilibrium potential or the Nernst potential. So the answer to this question would be Nernst potential. Question number 2, characteristics of UMN lesion. This we had discussed in our classes when we learnt about the corticospinal tracts, the UMN and LMN lesion. Hope you remember this description. We saw that in upper motor neuron lesion, three things are up. What is up? Tone is up, which we call hypertonia. Reflexes are up. This is called hyperreflexia, and toes go up. And this we call it as Babinski's sign, positive. So these are the features of UMN lesion. What would be LMN lesion? Exactly opposite. Hypotonia, hyporeflexia, and Babinski's sign, negative. So in this question, characteristics of UMN lesion. So the most appropriate answer would be positive Babinski's sign. Babinski's sign, positive, where the toes go up when you scratch on the sole of the foot from lateral to medial. Where else will you see Babinski's sign positive? Yes, in infants up to 2 years of life. Question number 3. There was a question on steatorrhea and fatty bulky stools. Yes, steatorrhea means fatty bulky stools. This is seen in which of the following? Obstructive jaundice. What is steatorrhea? The passage of fatty, bulky, and foul-smelling stools is called steatorrhea. Why do you see fatty, bulky stools in obstructive jaundice? In obstructive jaundice, which is also known as cholestatic jaundice, there is stasis of the bile. That's why it is called cholestatic jaundice. It is a condition characterized by obstruction of bile flow from the liver to the small intestine. So if bile is not flowing from liver into the small intestine, bile only helps in fat digestion. So if bile flow is obstructed, fat digestion would be obstructed, and this results in bile decrease in bile reaching the small intestine, therefore interferes with fat absorption and causes steatorrhea in these patients. So the answer is obstructive jaundice. Question number 4. Shivering in response to cold is a mechanism of thermoregulation. Which of the following plays role in shivering response? So the question is about the shivering mechanism. The posterior hypothalamus, as we have learnt about the different nucleus of hypothalamus, we know that posterior hypothalamus helps in shivering mechanism. Whenever body is exposed to cold, in order to balance for this cold, your body will produce heat. How do you produce heat? You shiver. When you shiver, the muscles are contracting. When muscles contract, more heat is produced, and that is caused by posterior hypothalamus. So shivering in response to cold is by posterior hypothalamus. What are the other functions of the nucleus given in the question? See, all of them are basically nucleus found in the hypothalamus. Mammillary body. What is the role of mammillary body? Yes, it helps in memory mechanism. Arcuate nucleus produces releasing hormones for the anterior pituitary. Anterior nucleus helps in cooling of the body. So the answer to this would be posterior hypothalamus. Question number 5. Arteriovenous gradient of oxygen at resting state is highest in AV oxygen difference. This is highest for the heart because in the myocardium of the heart, there is a wide arteriovenous oxygen difference of 10 to 20 volume% at rest. And this reflects that oxygen in the blood passing through the coronary artery circulation is nearly maximally extracted. Arteries are bringing in the blood to any organ, and veins are removing this. So if there is more AV oxygen difference, it means much of this has gone into the organ. The organ has extracted a lot of oxygen. That's why there is a difference between the oxygen in the arteries and in the veins. So this value can be compared with 4 to 6% volume difference across the systemic circulation. So the AV oxygen difference is almost 10 to 20% more than that of the systemic circulation. The heart itself notably has the highest oxygen consumption per gram of all the organs and high oxygen extraction rates even at rest. Yes, heart consumes much of the oxygen. That's why AV oxygen difference is more. The answer to this is heart. At heart, the arteriovenous oxygen difference is more. Question number 6. The diluent fluid used for total RBC count is the red blood cells. Heme's fluid is used for RBC count. Then what is Turk's fluid used for? WBC count. Dunger's fluid is used for eosinophil count. And Rees-Ecker's fluid for platelet count. So RBC diluting fluid is called Heme's fluid. Question number 7. True about juxtamedullary nephrons. There are two types of nephrons. Nephrons located in the cortex and nephrons located deep in the medulla. They are called juxtamedullary nephrons. The cortical nephrons are more than 85%. Juxtamedullary nephrons are less, only 15%. Cortical nephrons have a short loop of Henle. Why do they have short loop of Henle? Because their role is only excretion of waste. For excretion of waste, short loop of Henle is enough. But the juxtamedullary nephrons, they have long loops of Henle. Why do they have long loops of Henle? Because their role is concentration of urine. In order to concentrate urine, you need long loops of Henle. That's why, as an adaptive process, these desert animals like camels have a long loop of Henle. Because of the long loop of Henle, they have well concentrating mechanisms for urine so that they don't lose water. Already in the desert, there is less water, so camels cannot lose water. So they have long loops of Henle for concentration of urine. So the answer to this question, true about juxtamedullary nephrons, critical for concentration of urine. Question number 8. Which of the following cannot be recorded by a spirometry? Spirometry is a technique where you put the spirometer tube into the mouth and you ask the patient to breathe into the tube. And that is connected to the monitor. The monitor would draw this graph for you. So when you breathe into the tube, only the air that comes out of your mouth and goes into the tube can be measured. Residual volume is the one which is not at all coming out. It stays in the lung itself as a residue. If you don't breathe into the tube, the machine can't measure. So since residual volume is a residue, it stays in the lung itself. It is not coming out. So this cannot be measured by using a spirometer. So in order to measure the residual volume, what are the techniques that you will use? You need to put gases which will go into the residual volume and will come back. And that also you should be able to measure. So we use nitrogen washout techniques, helium dilution technique, and body plethysmography. These techniques can be used to measure residual volume. Question number 9. Hostrations are seen in. Hostrations are large movements of the intestine which are helping to push the fecal material for defecation. So in large intestine, you see hostration. Not only hostrations, but also mass movements. Movements called mass movements. So hostrations and mass movements are seen in large intestine. Question number 10. Stretch reflex is given by. So this was given by Sir Charles Scott Sherrington. He's called the father of physiology. So he only proposed the importance of stretch reflex. What about Paintal? What is the contribution of Paintal? J receptors were discovered by Paintal. Parkinson, James Parkinson discovered Parkinson's disease. V.S. Ramachandran, again an Indian scientist who discovered mirror neurons. Mirror neurons. Question number 11. Which of the following is the best ECF buffer? Outside the cells, this is extracellular fluid. Inside the cell, it is intracellular fluid. Extracellular fluid, we have acid. Intracellular fluid also, we have acid. Outside the cells, in the extracellular fluid, this H plus is neutralized by bicarbonates. So bicarbonate is the major buffer in the extracellular fluid. Buffer means any substance which will neutralize the acid. So bicarbonate is the major buffer in the ECF. In ICF, proteins are the major buffer which will neutralize this acid. So which of the following is the best ECF buffer? Yes, it is bicarbonate buffer system. Question number 12. Damage to prefrontal cortex. Prefrontal cortex has an important role in determining personality, knowledge, emotional status, social behavior, attention, motivation, personality, behavior. All these are functions of the prefrontal cortex. So if there is any damage to prefrontal cortex, there would be emotional disturbance. So the explanation, damage to ventromedial prefrontal cortex results in deficits in social and emotional behavior, including lack of affect, poorly modulated emotional reactions, lack of empathy, inability to observe social conventions, and poor social decision-making behaviors. Question number 14. Jager's chart is used to test the near vision. Jager's chart, it's a small chart which has few written words and sentences in it. You keep this chart at a particular distance and you ask the subject to read. So this is kept very close to the eye. So that tests for near vision. Jager's chart is an eye chart used for testing near vision. It is a card on which paragraphs are typed and printed with the text sizes increasing from 0.37 nanometers to millimeters to 2.5 millimeter. So you will have different sizes of text there. This card is to be held by the patient at a fixed distance from the eye. The smallest print that the patient can read will determine the visual acuity. So you ask the patient to read from large alphabets to smaller ones. Distance, so this is called the Jager's chart. There's another chart called Snellen's chart, which is used for measuring distance vision. So near vision, Jager's chart, far vision, Snellen's chart. Snellen's chart, I think you would have seen in ophthalm OPDs. It's a big chart with A, B, C, D, or letters like E or numbers written at a particular distance of 6 meters, and you have to read from a long distance. So Jager's chart is used to measure, yes, near vision. Question number 15. COX-2 inhibitors act on prostaglandins. COX-2 inhibitors, they block the production of prostaglandins, which are associated with inflammation and pain. So prostaglandins can cause inflammation and pain. If you use COX-2 inhibitors to block this prostaglandin, you can use them for the treatment of inflammation and pain. So they block the action of prostaglandins. That's how they become painkillers. Question number 16. Capacitance vessels are veins. Yes, veins are called capacitance vessels because veins have a huge capacity to hold blood. They are highly compliant. Because of the increased compliance property of the veins, they can hold huge blood. At any point of time, 64% of total blood volume is held up in the veins. Arteries are elastic, whereas veins are compliant. That's why capacitance is more. Question number 17. True regarding action potential. Action potential is self-propagating, yes. Conduction with depreciation. You don't see depreciation in action potential. In local potentials only we see depreciation. In action potential, once it is set, it won't go for depreciation. It will just continue. Follows all or none law. Yes, action potential follows all or none law. Needs minimum threshold. Yes, once it reaches the minimum threshold, then from that point you have the firing or the action potential curve. It has refractory period. Yes, action potential has absolute refractory period and also relative refractory period. So it is A, C, D, and E. B is false. Question number 18. Hormone which acts through cell surface receptors are all except thyroxine, because thyroxine acts through nuclear receptor, not through cell surface receptor. Whereas all others, insulin, glucagon, and growth hormone act through cell surface receptors, but thyroxine can penetrate into the cell. It can act on the nucleus. Yes. We have completed our physiology question session with this. Hope it was a useful session. So any clarifications, let me know on the comment box. Remember, don't settle, don't stop. Good night to all of you. Thank you.
Yeah, so very good evening to all of you. So myself, Dr. Saurabh, and we have come here for this pharmacology discussion. And I know that it's very late, 10 o'clock, and it's already post-dinner time. So half of you might have slept till now. So it's a day of enjoyment for you because you have just over with a big burden of giving this INI-CET exam. So just a quick session. We'll finish these questions very fast. Now, if I talk about this pharmacology level, the level of questions they have asked, like this time, the examiner was in mood to throwing up the marks. So pharmacology was very easy, except for 1 or 2 questions. So it was very easy. So they have given you around 4 or 5 marks free of cost in terms of pharmacology questions. I don't know whether these questions are really asked or not. So I'm not very much sure because AIMS people usually don't ask this level of questions. Like question number 1, hormone having hypoglycemic effect. So hormone which is having hypoglycemic effect. So guys, can you please tell me, was this question really asked in the exam or not? Because these kind of questions, if asked in the exam, then obviously clearing an entrance exam is a cakewalk for you. Hormone having hypoglycemic effect. So this was the question in the exam or not? Was this question asked in the exam or not? I want the interaction from your side, guys. I'm online with you on this YouTube chat with you people. So if anyone can help me out in this, yes. Okay, this question was asked. Yes, Dr. Libra, good evening. Dr. Subhra Jyoti has said that this question was asked. So guys, I mean, you must have marked it correctly. No such question was asked. Dr. Tabish Manzoor Khan said no such question was asked. Libra has said yes, it is asked. Monogna has said it is asked. So out of 5 people, 4 have said that it is asked. One is saying it is not asked. So I'm considering this question is asked in the exam. So question number 1. Yes, Pooja also said yes, and Prashant also said yes. So now 7-1. So Dr. Tabish, maybe you have skipped this question in your exam. So it's the most easy question of the exam. Insulin is the one that can cause hypoglycemia. Question number 2, again a very, very easy question. Antidote of PCM. Like if anyone has become a doctor in his life, the one thing he would be knowing about any antidote is about a paracetamol antidote. So please let me know whether this question was asked or not. Whether this question was asked or not, antidote of PCM, sorry, not PSM. So antidote of PCM, did they ask this question or not? Okay, this was asked. Very good. Dr. Dentistry has answered that this question was asked. Dr. Tavish, this question was asked or not? Tavish, did you find this question in your exam or not? Okay, yes, it is asked. So Dr. Tavish, this question was there in your exam or not? Yes, the answer is N-acetylcysteine, and it will be great, guys, in case you help me out in finding the other option. So one was N-acetylcysteine, the antidote of paracetamol. Any other option you people know? Like, what are the other options they gave you? Yes, antidote of PCM was asked. So what are the other options in this question, guys? One was N-acetylcysteine. Again, a very easy question from pharmacology. Okay, so Tabish attended this question in his exam, so it means this is asked. So what are the other options, guys? What were the other options? One was N-acetylcysteine. Any other option you know? Like, did you know, like, if any kind of word is written, like flumazenil is written, naloxone is written, like these kind of antidotes they gave you in the exam? If anyone can help me out in this, flumazenil, naloxone, or any other antidote they have written. Okay, they have written activated charcoal. So they have written activated charcoal. So activated charcoal was the one option. So this can also be used. Activated charcoal can also be used when the patient has come to us within 4 hours of toxicity. But after 4 hours of toxicity, we have to give the antidote now, right? Okay. This question was not in your paper. Okay, so Dr. Pooja Kumari did not have this question in his paper. Okay, one option was penicillamine. One option was penicillamine. So penicillamine is given for copper toxicity. Now this penicillamine particularly asked in your last AIMS exam. So penicillamine asked in your last AIMS exam. Okay, naloxone was given. So naloxone is an antidote of opioid. Now this is asked in your this time PG exam. So NEET PG exam, they have asked you naloxone, and penicillamine asked in your last AIMS exam. Okay, Siksha did not look at the questions at all. Okay, very good, Dr. Siksha. You are giving a very good Siksha to all of us that we should not see any other thing when we know the answer is correct. So Arjun ki aankh hai, agar machli dikh gayi to there is no need to look at any other thing. So 4 options are N-acetylcysteine, activated charcoal, naloxone, and penicillamine. So question 2 answer is A. Question number 3. Okay, this question was asked by Dr. Abhirami also discussed by Dr. Abhirami. Hormone that will not act through surface receptor. So in general pharma, guys, we discussed this point so many times. Like, what are the various receptors which are present in nucleus? So we discussed during our lecture, what are the nuclear receptors? What are the cytoplasmic receptor? So if you remember, like if you have attended our lecture, you must be knowing nuclear receptors, we made a mnemonic of tape in case you remember. Cytoplasmic receptor, we made a mnemonic of steroid. Then we have the membrane receptor. Now, membrane receptor can further be of 2 types, can be associated with kinase enzyme, can be associated with G protein. So in this MCQ, guys, nuclear receptor, T stands for thyroid hormone. So thyroid hormone we discussed during our lecture also. So thyroid hormone receptors are present in nucleus. So nuclear receptors, yes, it's a thyroid hormone. The answer is A, discussed by physio-faculty also, and this also belongs to pharmacology. There are some topics which are overlapping between physio and pharma. Yes, so question number 3, answer is A. So I hope everybody has marked it correctly. Everybody marked this question correctly. So question 3, answer is A. According to some students, one of the option was parathyroid hormone. 4th option given was parathyroid hormone. So question 3, answer is A. Thyroid hormone was the answer. So again, a very easy question. Now look at the quality of question, the extent of difficulty. Question 1, insulin is a very easy question which will cause hypoglycemia. Question 2, paracetamol antidote, again a very easy question. Question 3, which hormone does not have the surface receptor? Thyroid hormone. Moving on to question 4, again discussed by physio-faculty, COX-2 inhibitor. Like, guys, like if you are a dentist student and you have cleared the secondary exam and you are now preparing for the entrance exam, everybody knows this thing that COX inhibitors are the NSAIDs. They are the non-steroidal anti-inflammatory drugs. They inhibit COX enzyme, and by inhibiting COX enzyme, they stop the prostaglandin synthesis. So these medicines will stop prostaglandin synthesis. But if any drug inhibit the lipoxygenase enzyme, any drug inhibit the lipoxygenase enzyme, then only the leukotriene level will go down. So the drug which is lipoxygenase enzyme synthesis inhibitor is xylutone. Xylutone is a medicine that's a LOX enzyme inhibitor. So this is an unimportant drug for the exam. This is never asked in the exam, but NSAIDs are important. So guys, can you please help me out? What are the other options here? One was prostaglandin. This was the answer. Other was leukotriene. What are the other 2 options? Because guys, we people have to give you these questions in full. Like we want to give you all the 4 options. So it will be good. Like it will be helpful for us if you people will provide us the other options. One was prostaglandin, second was leukotriene. What are the other 2 options? If, okay, I should go a bit fast. Okay, it's very slow, so I should go a bit fast. So guys, if you help me out in these options, it will be good. It will be good if you tell me about the other options. Question number 5, drug with lower rate of resorption of alveolar bond. Okay, guys, this was the question of your periodontics, right? This was a question of your periodontics. So like even I did not know the answer of this question. So I discussed with one of the dental faculty and they have said the answer is ibuprofen. I don't know because this is not given in my pharmacology books. In any of the pharmacology book, this answer was not given. So this is something related to periodontics, right? So patient is having periodontitis, okay, periodontitis, and now which drug will prevent the resorption of alveolar bond? So that person has told me the answer is ibuprofen, but exact answer I still don't know. Okay. So yes, so this question will be cleared by your perio faculty, not by me, guys. Sorry for this. And also, I did not cover this part in my lecture. I apologize for that because I couldn't cover this topic up till that extent. But fine, guys, we cannot cover 10 out of 10. Okay, fine. So one of the option in the previous question here, it was lipoxin. So one of the option given is lipoxin. And the 4th option given here is, according to one student, is isoprenoline. So isoprene. Yes, very good, guys. Isoprenoid is a one thing that is formed by the arachidonic pathway. So lipoxin, isoprenoid, leukotriene, prostaglandin. Yes, the same thing told to me by that person also. This was a repeat question from your one of the previous year questions. That's why they have marked ibuprofen. But guys, none of the books support this fact. Like I did not find this fact in any of the books. Sorry for this, right? Okay, now again, an easy question, like which is not an opioid? So oxycodone is a codeine analog. Basically, the word should be oxycodone. So this medicine is oxycodone. This is a butorphanol. So all spelling mistakes. So this is a butorphanol. So my technical team has done some mistakes because they are working since morning. Like since the time the paper has started, they have started noting down the questions when the student has started coming out. So like they are not the medico people, but still they have worked very hard to compile all the questions for you. So I apologize on their behalf that they have made the mistakes in these drug names because every doctor make the mistakes. So even they are also been allowed to make this kind of mistakes, right? So oxycodone is a medicine which is an opioid. Butorphanol is an opioid. One option given was L-fentanyl. So L-fentanyl is one more option that is given. So this is also an opioid. And guys, which was the 4th option? Which was the 4th option that is there? So did they ask you this drug as lumefantrine? Did they give you this medicine lumefantrine? So lumefantrine is an anti-malarial drug. So according to me, if this drug was lumefantrine asked in the exam, this is an anti-malarial. So this is not an opioid. This is an anti-malarial medicine. Rest of the medicines, like we discussed during our lecture also. So we discussed this thing in detail during this discussion of opioid, that the fentanyl group of medicines are used as a painkiller. Oxycodone is a painkiller. Butorphanol is a mixed action opioid. We discussed so many times during our lecture. But lumefantrine is an anti-malarial. So I just wanted to know from you people whether this was there in the MCQ or not. Lumefantrine. Okay, till that time I'm moving to the other question. Last words for orphan. Okay. Last was something orphan. So orphan. So I don't know like which drug is this. Filling the blank. Opioid something drug. Opioid like medicine. Amioten. Okay. Guys, was there a medicine like this one? Okay, amioten. Guys, was there a drug LV Mopen? Was this drug was there? LV Mopen? LV Mopen. So LV Mopen is a medicine which is an opioid antagonist. It's a new medicine. This is an opioid antagonist. This is not an opioid. This is opioid antagonist. Okay, yes, Dr. Vicky has cleared the air. Like he is saying it was LV-Mopen. So guys, LV-Mopen is an antagonist. So this would be the answer. So this is not an opioid, it's an opioid antagonist. LV-Mopen is an opioid antagonist. This medicine we use for the treatment of opioid-induced constipation. So opioids can cause constipation. So opioid-induced constipation, this medicine we use very commonly. So guys, I don't remember whether I have covered this medicine during my regular batch lecture or not, but usually we cover in medical science. This drug is covered usually for when we teach the medical students, like the MBBS students, because this is a drug that we use here more commonly. In dentistry, we don't use this medicine. This medicine has got an approval for opioid-induced constipation. It's an opioid antagonist. So this was the answer of that question. Rest of the medicines here, I don't know which was the first medicine given. Maybe this was the L-fentanyl. So maybe this was a mistake. So this is L-fentanyl, butorphanol, oxycodone. These three medicines are opioid. And the fourth one is antagonist they have given. So this was the answer of question number 6. Now moving on to question number 7. Now this question, guys, we have discussed so many times during our grand test as well as during our INI-CET class discussion that bupivacaine should not be used in patients of ventricular arrhythmias. So one of the most important side effect is most cardiotoxic local anesthetic medicine is bupivacaine, right? So most cardiotoxic medicine is bupivacaine. So this is the one that we don't use in treatment of ventricular arrhythmia. So who will tell me which local anesthetic we use for the treatment of ventricular arrhythmia? Can you answer this question? What is the name of the local anesthetic? It's not bupivacaine, but there is one local anesthetic. That's a wonderful medicine. That's a life-saving medicine, which is given for the treatment of ventricular arrhythmia. And we people use that medicine like anything. Question number 7, answer is C. This medicine is used in nerve block, and this medicine cannot produce the effective nerve block when you given it by spinal root, right? And C statement is the most correct answer here. Question number 8, why we rare, okay, this question is not given properly here. This is again given later on, so we'll discuss that. Yes, lignocaine is an antiarrhythmic drug. So lignocaine, we also call it lidocaine. This is the medicine that we use for ventricular arrhythmia. Yes, this is the medicine that we use for ventricular arrhythmia. Okay, guys, this question is asked so many times in before also, and we have discussed so many times during our lecture also. Like whenever we give opioids to a patient, tolerance can be seen against all actions of opioids. So tolerance can be seen against all actions of opioid. Even this we have discussed during our INI-CET revision papers. So during our INI-CET revision papers, we people have discussed this question so many times, that tolerance can be seen against all actions of opioids except meiosis and constipation. So tolerance is not seen against meiosis and constipation. For all actions of opioids, we can see the tolerance. So question number 9, answer is A. So tolerance can be seen against all actions except meiosis and constipation. Clear-cut question, repeated question. You should not have made mistake in this. Question number 10, thiopentone. So guys, the question is not completely available to us, like what is the exact answer of this MCQ. But let me tell you the thiopentone sodium. There's something interesting about this medicine. Thiopentone sodium is a drug which follow redistribution phenomena. So this is the medicine which follow redistribution phenomena. Now, what is this redistribution phenomena? Whenever we give thiopentone sodium by IV route. So this medicine is only available by IV route. Thiopentone sodium. Okay, in this MCQ, one option was bradycardia. In the previous MCQ, one option was bradycardia, one option was sedation. I am really thankful to you, Dr. Subrajyoti and Dr. Manogna, that you people are helping out in fulfilling all these options which are left blank right now. Okay. So, okay, what was the question, Dr. Dentistic? In case you can help me out in this question, finding this question, then it will be great. Like in case you can draw one photograph or you can share it somewhere in the group, that will be good. So I just telling you the important points about this medicine, thiopentone sodium. This is the drug that is given by IV route. So this medicine is given by IV route. Yes, it is not available by oral route. It is not available by subcutaneous route. This is given only by IV route. Now this medicine, whenever you give, this medicine will first of all take entry in those visceral organs. Medicine will take first of all entry in those visceral organs which have high blood supply. So the visceral organs which have high blood supply, thiopentone sodium will take entry in those organs. So first of all, the organs which have more blood supply, the medicine will take entry in those organs. Like this medicine, first of all, take entry in central nervous system, in liver, in kidney, in heart. So these are the organs which have the high blood supply. So medicines first of all go over there. Now, once the medicine will go there, after some time, this medicine is secreted back to the plasma. So this medicine is secreted back to the plasma by these organs. So this medicine will come back to the plasma. And once this medicine will come back to the plasma, then this medicine is again redistributed. Now this medicine will again go to all organs of the body uniformly. We call it redistribution phenomena. And now this medicine will go to all other organs like a normal distribution. And the last part of the body which will get the blood supply is the one which has the minimum blood supply, like the fat cells. So fat cells are the one which will get the blood, which will get the thiopental sodium in the last. So this is the information that we required for thiopental sodium. Now let me read your messages also. Yes, this medicine is given only by IV route. This medicine is given only by IV route. No, it is not given by subcutaneous route. It is a IV general anesthetic drug, right? And thiopentone route of administration based on image provided. Okay, so based on image provided, तो फिर guys वैसा होगा. Like the moment we give medicine by IV route, immediately the level is very high. So you can draw like this way. Immediately the medicine level will increase and keep on decreasing like this way. So this is the IV route. But if I give medicine by oral route, if I give medicine by oral route, the level will gradually increase. So this is the oral route, right? And if I say the subcutaneous route, in subcutaneous route, this will be like this. So somewhere in between oral and IV, we have a subcutaneous route. So IV route, immediately we have the high level. So this is the different routes they can give you. So I'm just trying to make out like what kind of question they have asked in the exam. So thiopental sodium is given by IV route. So this is the answer, right? Question number 11. What is the correct definition of these? So maybe they have asked a question from General Pharma. What is the correct definition of these things? Like what is antagonist, what is additive, what is synergistic, what is progressive? So I don't know what was the exact question. So can you help me out? What was the exact question asked here? What was the exact question they have asked here? Have to mark the correct definition. Okay, they have given you the definitions. So guys, antagonist is the medicine that will stop the other medicine action. Additive effect means if you give a drug that will cause the additive effect, like 1 + 1, 2. And synergistic effect means 1 + 1 is equal to more than 2. So in the overall effect become the more than the individual drug effect, that is a synergistic effect, right? One more synergistic effect is like this way. This can be 1 + 0 become more than 1. This is a synergistic effect. This is the additive effect. And antagonist effect is like 1 + 1 become less than 1. So this was the question asked in last year AIMS also. Yes, this was the question asked in last year AIMS also. So antagonist is when you give two medicines together, the overall effect is less than the individual drug effect. Additive is just a simple addition. Synergistic is 1 + 1 become more than 2 and 1 + 0 become more than 1. Yes. Okay, so this was the question asked in last year AIMS also, and we've discussed this point so many times during our INI-CET revision papers as well as during our NEET exam papers. We discussed these points so many times because this was asked last year. Question number 12, which drug is given in renal insufficiency? So guys, this was the topic I told you so many times in the exam during my regular batch lecture also, that you should be knowing which medicines are safe to use in renal disease. So what are the various drugs that are safe to use in renal disease? Antibiotics, which are safe to use in renal disease. This is a list of antibiotics. This is very, very important for the exam. Every year they ask the question. So here the answer is moxifloxacin. So, okay, in the previous question, progressive option was not there. Drug potentiation is there. Okay, so guys, I'm just changing the option. So this is the drug potentiation. This is the drug potentiation. This is the drug potentiation and synergistic effect. Synergistic effect can be of two types. Synergistic effect can be of two types. This can be additive. This can be potentiation. So this can be additive potentiation or this can be supra-additive. Drug potentiation is also known as supra-additive. So additive means 1 + 1 is equal to 2. This is 1 + 0 become more than 1. This can be 1 + 1 more than 2. So this is your supra-additive or the drug potentiation effect, guys. Okay. So accordingly, you can mark the answer, whatever is asked in your exam. So among fluoroquinolones, please remember moxifloxacin is a drug which is purely metabolized by liver. One more drug is pefloxacin. This is also metabolized by the liver. And we have given you the list of all antibiotics. Like there are hardly 7 or 8 antibiotics which are safe to use in liver disease. safe to use in CKD. So you have that list with you, and every year the question is asked. So now the question number 13. What is not an advantage of oral administration of thiopentone? So what is not an advantage of oral administration of thiopentone? So it is not available. It is not available in the market. So this is only available by IV route. So drug is available by IV route. Okay, so Dr. Devendra Singh, Dr. Shailesh, what was the question? Can you please help me out? What was the question based on fluoroquinolones? Like which fluoroquinolone can be given in renal insufficiency, or what was the exact question? Dr. Shailesh, it will be great, like in case you share your expert recall here. Dr. Devendra, what was the exact question? Which drug can be given in renal insufficiency? Was this the question, or there was something else? Like which fluoroquinolone is safe to use in renal insufficiency? Okay, ciprofloxacin is there. So guys, apologize for my technical team part. Ciprofloxacin was there, levofloxacin, ofloxacin, moxifloxacin. Anything else they have asked in this MCQ? In case you come to know anything else about this question, please let me know. Okay, so this is the advantage. This is the reason why we don't use this medicine by oral route. It's not available by this route. Now, question number 14. Okay, is question number 14. What is the immediate management of methanol toxicity? So methanol toxicity can cause acidosis, and acidosis can result in death. Acidosis can result in death. So what we can do, we can give an antidote. We can give an antidote of methanol toxicity. So antidote of methanol toxicity is fomepizole. Fomepizole is an antidote. The second antidote is ethanol. So first antidote, fomepizole. Second antidote, ethanol. So this is the antidote. But if the patient is having acidosis, the first thing we can do is sodium bicarbonate. So sodium bicarbonate is the one that we can give to the patient to take care of this acidosis. So acidosis, yes. So acidosis we can take care with by giving sodium bicarbonate. So was this option given in the MCQ, sodium bicarbonate? If this is not given, then immediate management may fomepizole is also not given, then the answer would be ethanol. So ethanol can be given. No role of dextrose. Dextrose is only given when there is a hypoglycemia. Although there can be a hypoglycemia here, but we don't require to give this medicine. It's not that much common. Vinegar is an acidic material. So patient is already having acidosis. This is not recommended. Methanol is also not recommended. Ethanol is the answer. Okay, guys. So this is question number 14. Moving on to question number 15. Metronidazole. They have asked you metronidazole. So metronidazole is a liver enzyme inhibitor. I told you this was the question during my regular batch. I especially told you this is the very, very important point, that metronidazole is inhibitor of warfarin metabolism. So this is a liver enzyme inhibitor, can inhibit the metabolism of warfarin and can result in increased risk of bleeding. So this metronidazole is not a mycolic acid synthesis inhibitor. Mycolic acid synthesis inhibitor are the TB drugs, right? So reduce mycolic acid synthesis. This is for the TB drug. This is a liver enzyme inhibitor, right? Can increase the action of warfarin by inhibiting its metabolism. So guys, do you remember what are the other options? Question number 15, what are the other options they have asked you regarding metronidazole? So regarding metronidazole, what are the other options they have asked you? Okay, moving on to question number 16, not correct for succinylcholine. Okay, no option. Not correct for succinylcholine, nothing is given. So patient on anti-tubercular regimen having the color blindness and loss of vision. Guys, TB drugs, so we people have discussed so many times during our lecture as well as in each of every kind of INI-CET revision exam and NEET exam. So every paper we always put a question on the TB drugs. So we know that this question is going to be asked. So ethambutol is the answer. Ethambutol was the answer. Okay, this is repeat. Metronidazole is orally bioavailable or not? Yes, guys, metronidazole. Okay, one option was metronidazole is orally bioavailable or not. So this was one of the option. Yes, it is available, guys. We know that metronidazole is given by oral route. Metronidazole is given by oral route. So this is also correct. Metronidazole is bioavailable by oral route. So this time pharma is easy. Yes, isn't it, guys? Pharma is easy this time. Question number 18 regarding Pretomanid. So what was the question based on Pretomanid, guys? So I'm just telling you about Pretomanid as a drug. Now, Pretomanid is a medicine. This is a cell wall inhibitor. This is a TB drug, and this medicine is a cell wall inhibitor, and this is inhibitor of mycolic acid. This medicine is mycolic acid synthesis inhibitor. This medicine is mycolic acid synthesis inhibitor, but this medicine can also form the free radicals. This medicine can also form the free radicals and can inhibit the bacteria. So with formation of free radicals, this can also inhibit the bacteria, but its main mechanism is it's a cell wall inhibitor. Now, this medicine is given for the treatment of XDR TB. So any option was there related to this, like I'm asking? Medicine is mainly given for XDR TB as a part of B-PAL regimen. So B-PAL regimen is we can give bedaquiline. B-PAL regimen is we can give bedaquiline, we can give Pretomanid, and we can also give linezolid. So we can give linezolid, Pretomanid, bedaquiline. This is a B-PAL regimen. This is given for XDR TB. Yes, it is given for resistant case of TB, XDR TB. We call it B-PAL regimen. We give bedaquiline, Pretomanid, linezolid. Number 3, this medicine is the one. This medicine is the one. This is also given. Yes. Yes, this is also given for MDR TB. This is also given for MDR TB, multi-drug resistant TB. So is there any option given like this way? Okay. So next question is regarding a muscle relaxant used in anesthesia. True regarding the muscle relaxant used in anesthesia. So neostigmine is used as an antidote of succinylcholine. No. Neostigmine is an antidote of non-depolarizing muscle relaxant. So succinylcholine is a depolarizing muscle relaxant. This is a depolarizing muscle relaxant. Okay, they have asked the true statement. So this statement is false. This is not the true statement. Neostigmine is used as an antidote of non-depolarizing muscle relaxant like curium and all. Second option, succinyl is the only depolarizing muscle relaxant that is available for clinical use. Yes, guys, this is correct. The mechanism of train of 4 in depolarizing muscle relaxant shows fluid mechanism. No, this is seen with non-depolarizing muscle relaxant. So fade phenomena seen with non-depolarizing muscle relaxant. With depolarizing muscle relaxant, this phenomena is not seen. Neostigmine cannot be used as an antidote of succinylcholine toxicity. Rather, it will increase it. Right? Now, what was the fourth option? I did not know. Right? So fourth option, I did not know. So I did not mention over here. Okay, this is a CYP3A4 inhibitor. Metronidazole is CYP3A4 inhibitor. One option is metronidazole is CYP3A4 inhibitor. So this statement is also correct. This statement is also correct. This is what we have discussed. This is a liver enzyme inhibitor. Liver enzyme name is CYP3A4. It's a cytochrome enzyme inhibitor. And that's why warfarin metabolism is inhibited. So guys, maybe this question is based on metronidazole, all statements correct except all statements correct. All statements given here are correct except. So regarding metronidazole, which statement is not correct? So now the answer would be this is incorrect statement. Like this is not a mycolic acid synthesis inhibitor. Rather, metronidazole is a drug. This medicine is a direct nuclear protein inhibitor. So now we can find out the all options. So 4 options now we have found regarding a metronidazole drug. So this medicine is inhibitor of liver enzyme like CYP3A4 enzyme. This medicine can increase the action of warfarin. This by inhibiting liver enzyme, this can prolong the action. This is orally bioavailable, right? Yes, poor. Yes, it has a poor bioavailability. That's why this medicine need to be given multiple times daily. This medicine need to be given multiple times daily. Its oral viability is poor. Okay, so all these things we have discussed. Answer is A. Question number 20. Which of these is used as a carrier for other anesthetic agent? So which gas is used as a carrier for other anesthetic agent? So this we already know, nitrous oxide. So nitric oxide can be used as a carrier for other anesthetic agent. This is always used whenever we want to give the other medicines. So this medicine is associated with second gas phenomena, also second gas effect, also associated with diffusion hypoxia. So all these things are due to this nitrous oxide. So answer is 20, answer is A. 20 answer is D. 21, again the same question repeated. We discussed so many times during our lecture. This medicine is not used in ventricular arrhythmia. So bupivacaine is not used in ventricular arrhythmia. This we have already covered. One of the side effect of medicine is ventricular arrhythmia. Now, I can see Dr. Kunal is waiting, so let's finish it fast. So in case, guys, you find any question or any option is not given correctly, you can message us directly, and we will happy to see your responses, right? So what is the reason why we don't use Eastern local anesthetics? So Eastern local anesthetic medicines are allergic in nature. They can cause hypersensitivity. This is correct. Now, when they are given by systemic route, then they are short acting. So when these medicines are given by systemic route, then they are shorter acting. But when I use the medicine for infiltration technique, when the medicine is given by infiltration technique, then this metabolism is not possible. Infiltration means they are giving the medicine by local route. So there the liver enzymes or the plasma enzymes will not metabolize the medicine. Otherwise, when I give the medicine by systemic route, this problem can be there. So this is metabolized by plasma esterase. This is not possible by the infiltration technique. This is not possible by infiltration technique. So question 22, answer is 3 only. So chances of hypersensitivity will be there. So chances of hypersensitivity is the answer. Analgesia you can have complete. Like you can have complete analgesia if you give the medicine by infiltration technique. It's a very good anesthetic drug. But the problem is allergic reactions can occur to anyone. And when given by systemic route, they are the short duration of action and metabolized by the plasma esterase enzyme. So question 22, answer is 3 only. So guys, with this, I would say the level of pharma here is easy. Like if I say approximately 15, 16 questions have asked, because although we have covered 22, but 4 or 5 were repeated out of that. So 15, 16 questions, you must have scored, I should say 12 to 13 questions. So 12 to 13 questions, you must have scored correctly. So I would love to see your responses, like how many questions you have marked correctly. I would love to see how many answers you have marked correctly. So I'm just signing off right now. And till the time Dr. Kunal will join us and he will give his expert opinions on there. Till that time, you can, okay, Doctor, one of the students is saying that he has shared the graph with me. So I'm not able to get where he has shared the graph. Okay, Doctor, dentistry, on which group you have shared the graph? Can you please let me know so that I'll share it? I'll discuss with you people. So is it on the Telegram group, guys, you have shared? Dr. Kunal, I'm letting you to wait for some more time because one of the student has shared the graph with me. Okay, guys, I'm not able to download right now because this presentation is connected. So I'll give you the answer on the group, right? So let Dr. Kunal to join us and give his expert opinion on the questions, because pharma is not that important. Dr. Kunal subject is more important. I think Dr. Kunal takes orthodontics, right? Dr. Kunal, up to you now, boss. Take care. Good night.
Hi, Dr. Saurabh. Hi, Dr. Saurabh. How are you?
Good, good. Dr. Kunal. Students are saying कि Dr. Kunal की wait हो रही है. Dr. Saurabh, जल्दी से जाओ आप. बहुत बढ़िया. Okay, take care.
No, nothing like that. You can take your time. You can completely take your time. I was listening to your session. You have been explaining it really, really in a fluent way, in a very good manner. I really like your sessions. Sometimes whenever I get chance, I have actually listened to few of your recordings earlier. So
thanks.
It helps me refresh my concepts about pharmacology as well, you know.
Okay. My honor. Bye.
All right. Hi students. Hello everyone. Good evening everyone. This is Dr. Kunal Agrawal, your original guru for the subject of Orthodontics at DBMCI MDS. So, how was your session, guys? How was the exam? How was the exam today? What was the level of questions which were asked in Orthodontics? Can anyone tell me? What is the overall impression of the subject? Where is the chat button? Where do I see chat? 1 second. Just a second, guys. वो चीज इसमें चैट ऑप्शन कहाँ आता है? All right, guys. So let's carry on with the session. There was some technical error, so that's why that's why we had to. I had to just pause for a moment. So I was asking, how was the session? How was the exam? What was the level of difficulty of the questions asked in exam? So I'm here today to just to brush up and just to give you my opinions about the question which had been asked in today's exam. Few of the questions which I can see do not have any options. So I'll explain you what the question is. Maybe as the time goes by, I'll be able to gather few other authentic options for you guys, and then we'll be able to discuss them in a better way. Right? So starting with the first question, formation of maxilla happens by which of these mechanisms? Is it mesenchymal condensation, endocorneal ossification, persistence of zygomatic or malar cartilage throughout the life, and loss of corneal cartilage just before the birth? So we have discussed about this in multiple sessions, multiple times before in my live lectures, in my recorded lectures as well. So the ossification of maxilla happens only by intramembranous ossification. There is no role of endocorneal ossification. And the condylar cartilage, the fourth option, the loss of condylar cartilage just before the birth does not, the option is not valid in this particular question at all. So the formation of maxilla happens only by mesenchymal condensation, or you can also say that happens by intramembranous ossification, right? So basically maxilla is a flat bone, not exactly a flat bone. The facial surface of the maxilla is a flat bone, right? So that completely undergoes ossification by intramembranous niche, not by endocorneal ossification, right? And one more peculiar thing about the growth of maxilla is that it undergoes both primary displacement as well as secondary displacement. That means the growth of the maxilla is downwards and forwards by means of its own growth. The maxilla itself is growing, and according to Newton's third law of motion, every action is equal in opposite reaction. So whatever growth the maxilla is having in the anti-direction, the maxilla pushes backwards, the maxilla itself pushes itself backwards so that the entire maxillary, the nasomaxillary complex, can grow in a downward and forward direction. It also undergoes secondary displacement in the space. Why? Because it is connected to so many different bones in the facial architecture, in the facial skeleton. So the growth of the other bones, the growth of surrounding bones, the condyle, the cranial base, specifically the cranial base itself grows in upward and forward direction. So the growth vector of the maxilla, the entire nasomaxillary complex, is that the entire maxilla is pushed downwards and forwards because the base of the skull is going in a forward and upward direction. So that is the example of secondary displacement. The bone itself is pushed, or it is translated into space because of growth of surrounding bones, right? So first question, the correct answer will be option A. The nasal bone growth completes at what age? Now, this is a little controversial question because many sources have given different answers. Actually, there are two aspects of looking at this particular question. One aspect could be that nasal bone growth completes at what age? They are asking the ossification of nasal bone completes at what age intrauterine life. Whereas the other aspect of the question could be the complete growth of the nasal bone, is concluded by what age, right? So let me start with that. The initial ossification of the nasal bone, which can be seen in an ultrasound in a fetus, in developing fetus, is around 3 months. 3 months of intrauterine life. That is the last month of the first trimester. That is when the ossification of the nasal bone starts. And you must be knowing about something called as target scan, or not a target scan particularly. In an ultrasonography examination, to rule out the possibility of Down syndrome, the first and the foremost structure which has to be pinpointed by the radiologist, by the sonologist, is the nasal bone. If the nasal bone is ossified by the end of the first trimester, so that is a sure shot indication that rest assured the child in 99.9% cases is not suffering from cleft lip and palate or Down syndrome, particularly Down syndrome. That is specifically for the target scan is specifically for the Down syndrome. Excuse me. Now coming back to the question, the nasal bone growth completes at what age? Now, the second aspect what I was talking about is that the entire growth of the nasal bone, not the ossification. The question is asking the entire growth of the nasal bone completes by what age? So I found out is that it is 14 years in females and around 16 years in males. So we have to assume that this particular question is asking for females. So the correct answer will be option D, that is 14 years in case of females. All right. The correct answer will be 14 years in case of females. Next is, in a 5-year-old child, how many growth sites are present in the mandible? Now, there's a difference between growth sites and growth center. Growth center is what? Growth center is the part of the bone, not mandible particularly, any bone within the body, which is not secondarily influenced by the external environmental factors. The growth potential of that particular bone is inherently present within that growth center. So examples of growth center: synchondrosis, the nasal cartilage. In the axial skeleton, we have the costochondral joints. Basically, all the primary cartilages in the body, they are growth centers. Whereas all the secondary cartilages in the body, they are growth sites. Now, in the craniofacial skeleton, we have growth sites as condylar cartilage and sutures present between the different bones. So they are growth sites. Now, question is asking how many growth sites are present in a mandible in a 5-year-old child. So the age of the child is written just to confuse you. During the entire course of the life of the person, right from the time the child is born to the time the person dies, the mandible has only 2 growth sites. That is the condylar cartilages. Right? So correct answer will be option A. We have only 2 growth sites, that is the right and the left mandibular condyles. Clear? Excuse me. Next question, posterior airway space in an average adult is about, what's the dimension? The question is asking the linear distance of the posterior airway space. Now, posterior airway space, you can say that it is a horizontal distance between the back of the tongue, and the posterior aspect of the posterior pharyngeal wall. That is what is called as posterior airway space. It is approximately 10 to 15 millimeters in an adult. The correct answer is option B, that is 10 to 15 millimeters. It is also called as retroglossal space. The space present behind the tongue, retroglossal. Retro means behind, glossal means anything related to the tongue, is called as retroglossal. Okay, so the fourth question, option number B is the correct answer, 10 to 15 millimeters. Function of the component marked. It was an image-based question, although we don't have any recalled options for this question. So we have discussed about this many times in the sessions, in live sessions, in recorded sessions. The function of the component marked. So in the image, we can see the red arrow points to the vestibular shield of the frenkel appliance. Now, you know what is the function of, what is the modus operandi, the mode of operation of this appliance called as frenkel appliance. It works by force elimination. The buccal vestibular shield, it eliminates the teeth from being acted upon by the compressive forces of the buccinator muscles, right? So it acts on the principle of force elimination. So function of component marked, I think the options which are present, which are not given, one of the options could be that it works on the principle of force elimination and it helps in passive expansion of the maxillary dentation, right? You can have another question regarding the very same appliance, that is the frenkel appliance. The question could be, which of the following appliances works on the principle of functional matrix hypothesis, FMH? So correct answer will be frenkel appliance. Okay, because it eliminates the forces acting upon the posterior aspect of the teeth by the inwardly directed, centripetally directed forces from the cheek musculature, specifically the buccinator muscle. Child chewing is converted to adult when? So I think the correct language of this question should be, the chewing pattern of a child is converted to an adult pattern of chewing by what age? That is what the question is asking, I think. So we have discussed about the different chewing patterns in both child and in adults in the chapter on functional development in both recorded and live lectures. I hope you must have remembered that. So you know, when in the frontal plane, the chewing cycle of a child is like when the child opens the mouth, the mandible is deviated towards one side, and then it comes back to the centric relation when the teeth are completely occluding with each other. Whereas in case of adults, the chewing cycle is like a teardrop shape. You know that. So it happens, the conversion, the transition from the chewing cycle of a child to the chewing cycle of an adult, that transition happens around the late mixed to early permanent dentition. So I think it should be approximately 12 to 14 years when the last primary tooth is replaced by the second molar. That is when the complete transition of a child's chewing cycle is to an adult chewing cycle is completed. So the correct answer should be approximately 12 to 14 years of age. So I did not understand this particular question. Maxillary arch discrepancy, how will dentition be placed? So we have seen multiple cases having maxillary arch deficiencies. So dentition can be placed in many ways. You know, The dentition can be extremely compacted, means the arch is extremely narrow in a V-shaped manner, or we can also see extreme amount of crowding in the maxillary dentition, right? So I don't know what the question is exactly asking. Without the options, I cannot answer this question properly. So maybe once I get the correct options to this question, I'll be in a better position to explain what exactly the question was asking. Okay? There can be multiple answers to this question. I don't know what the options were to pinpoint the exact answer for you right now. Now, the gene responsible for malocclusion. Now, malocclusion is a phenotype according to the genotype, right? The genotype of a person, suppose I have inherited a particular gene from both my parents, from my mother and father, and the phenotype is what is seen to the outside world. The physical characteristics of that genotype is called phenotype. So gene responsible for malocclusion is what? Now, as you know, malocclusion is a multifactorial condition. It is not inherited by a single particular gene. It is inherited by the gene coming from both parents, plus the environmental factors also contribute to the development of malocclusion. So I don't know what exactly the options were again. They have not been provided. Maybe the students were not able to recall it properly. So I found out many genes are responsible for malocclusion. Examples could be fibroblast growth receptor factor 2, then COL1A1, MATN1, MYO1H, MSX1, P63 genes. There are many options. So if any of these options which I just said, if that is present in the answer, in the options, in most likelihood, that would be the correct answer, right? So I'll skip this question for now. I'll be able to answer this question in a more better way when I'm provided with the options. Nasal growth is completed at what age? We have discussed this question earlier. Torque to force represents what? Now, torque to force represents, actually, there's nothing called torque to force. The better way to answer this question should be moment to force represents what? Now, you know, moment is the rotational tendency of a tooth or any given object. Sorry. Speaking in the context of orthodontic treatment, moment is the rotational tendency. The moment is rotational tendency. If the force acting on a particular tooth is away from from the center of resistance of the tooth. So it is a vector quantity which is represented by force into perpendicular distance. That is what is called as moment. And it is expressed as gram millimeter. Gram for force and millimeter for perpendicular distance. That is gram millimeter. Okay. So better way to ask this question should be moment to force represents what? Now we have got different types of moment to force ratios. You know what is moment to force ratio? If anything given, the moment to force ratio below 6 means 1:6, it represents uncontrolled tipping. Between 6 to 8, it represents controlled tipping. Right? Then 8 to 10, it represents bodily movement or translation. And anything above 10, it represents torquing movement of the tooth. So torque to force or moment to force represents the type of tooth movement which is possible in that particular tooth under the given biomechanical condition. That is what the question is asking. Excuse me, if I gather it in a proper way. Okay. Then in orthodontic treatment, what makes teeth prone to resorption? What makes teeth prone to resorption? Excuse me. Is it a single rooted tooth? RCD treated tooth? Only two options are there. So if you are to, if you want to take my opinion, clinical opinion, I would say single rooted tooth is the, I mean, the teeth which have only one root, they are more prone to getting resorption due to orthodontic treatment. If there was one more option, that extreme overjet in the anterior region, in the anteroposterior plane, if that would have been the option, that would have been a better answer. Why? Because the more the amount of distance, the more the distance the tooth has to move, through the bone. So that makes it more vulnerable to undergo more root resorption. Okay. But I don't know if that particular option was there in the exam or not. So according to the options given right now, I would go for single rooted tooth as the answer right now. Means option number A. This should be the correct answer in the absence of option number C and D. Okay. Again, an image-based question. Now let's study this image properly. Excuse me. It's asking the collective anchorage value of three teeth, that is a maxillary, central incisor, lateral incisor, and canine, and of the mandibular, same mandibular central, lateral canine, and maxillary 456 and mandibular 456. So in this particular question, you should be aware of what anchorage value means. Anchorage value is nothing but the total root surface area of that particular tooth. So the more the root surface area of the tooth will be, greater will be the amount of force which will be needed to move that tooth. As simple as that. It's a common sense. Right? So the bulkier the tooth will be, or the bulkier the root of the tooth will be, more will be the anchorage value of that particular tooth. So the collective value of all the teeth, of all three teeth, as it is as being shown in the image, according to this, both statements are correct. A will have more anchorage than D, means A is this scenario, maxillary incisors of one quadrant. So naturally, maxillary incisors are bulkier teeth than mandibular incisors and mandibular anteriors. So the anchorage value of maxillary 1, 2, 3 will be more than the anchorage value of mandibular 1, 2, 3. That is true. Similarly, the anchorage value of maxillary 4, 5, 6 will be more than that of mandibular 4, 5, 6. Excuse me. So both answers are correct. Both statements are correct. So I would go with both. I don't know what 1, 2 is written here. So I would go with both options are correct. A will have more anchorage than D, and B will have more anchorage than C. Okay. Maybe the recall of this question was not proper. If I fathom it properly, I would go for A will have more anchorage than D, and B will also have more anchorage than C. So both the given statements are correct according to the clinical situation described in the image in front of you. Right? So that's all for now. Actually, I'm not in Bhopal, my hometown. I am in Kerala. So all the students who are joining me from Kerala. So this is Dr. Kunal Agrawal saying hi from Kerala right now. I'm sitting at Alleppey in one of the hotels with my family and friends. I had come to a vacation with my family and friends. So I'm very happy to solve your doubts. So I can see Dr. Pavan Kandhari is waiting in the waiting room. So without much ado, I would like to hand over the mic to him. Right? So if you have got any doubts, you know where to find me. And until then, don't settle, don't stop. All the best. Take care. Good night. Dr. Pavan, it's all yours. Thank you.
Okay, okay. Right. So I hope I'm audible and visible to you right now. Okay. So what we are going to do is we are going to kind of discuss the 3 questions. There was only 3 questions which were asked to you in your exam. I'm not able to share my, what do you call as, I'm not able to share my screen due to some or the other reason, but that's all okay. No issues. There were only 3 questions and I'll discuss those 3 questions with you guys. Okay. So the first question which I've got on the recall basis was, xanthelisma is found due to what? Okay. So the first question was, I'll write it for you guys. So the first question was, okay. Anyways, the first question was xanthelisma. Okay. So xanthelisma is caused because of what? Is formed due to which of these? So, okay, yeah, you can share the PDF. I'll stop sharing. Okay, I have stopped sharing. They will share the PDF from their end. So Manisha, can you please share the PDF?
Yes.
Manisha, can you please share the PDF? No, I'm not asking you to. Just 1 minute. I'm trying some other way. Okay. Manisha, can you please give me the access to share the screen? Like the new Pavan Gandhari, which has joined through my iPad. Can you please do that?
Yes, sir. Done.
Yeah. Did you give?
Yes, sir.
Okay. There's some issue with your settings, Manisha. I am trying to share the screen from mine, and it is showing that the admin has blocked the screen sharing. Anyways, guys, let's kind of start. I think there's some issue, but no. The first question which they had asked you was xanthelisma. Okay, so just focus on me. There were 3 questions, very simple. Let's kind of discuss them up. So the first question was, xanthelismas are found due to which of these? Okay, so hypertension, hyperglycemia, hyperlipidemia, or hyperthyroidism. So what is xanthelisma? Xanthelisma is a condition where the cholesterol is basically deposited underlying the skin. Okay, so this is basically caused in the hyperlipidemia. Okay, so when the patients have lipid profile goes haywire, the LDH, the HDL basically goes down, the LDL and the VLDL that basically rises. In this particular condition, what happens is that the cholesterol gets deposited underlying the skin. Okay, so this is what is called as a xanthelismas. So on the physical examination, you will be able to find that, and that is what is a xanthelisma. Nothing major about this. Okay, so again, like this was not a traditional kind of question. Frankly, it is not per se related to the surgery as well. But I've seen that many times they tend to ask questions here and there, like few of the topics here and there. This was one of the ectopic kind of a questions. I would say it was like surgery Dhamma combination kind of a question. Okay. Now, the second question which they had asked you is this. Which of these is a non-absorbable suture? Now, this was a very, very straightforward question, and I hope that you guys have done this correct. Okay. The options which I have got in front of me are polyglycolic acid, polyglyconate, polyglycaprone, and polyester. Okay, so out of these, what is the non-absorbable suture? It is polyester. Okay, so polyester is the non-absorbable suture out of these kind of 4 options. Okay, polyglycaprone is the monofilament suture. Okay, polyglycaprone. Okay, so others are the absorbable sutures, and yeah, see, so sutures is obviously one of the very, very important topics for you guys, and you should know in and out of that. Okay, monofilament advantages, disadvantages, and everything. But here, what they have given is which of these is a non-absorbable suture? And the option was polyglycolic, polyglyconate, polyglycaprone, polyester. So polyester is the answer for that. Okay. It was a simple question. This particular thing was a simple question. I hope that you have done this correct. Polyester is a non-absorbable suture. Now, the third question which they had asked you, now this was slightly tricky, or what you call as a different kind of a question. Okay. And the recall is not very, very proper, but let's kind of discuss this up. Please pay attention over here. I'll read the question for you. The question is, which of these would point directly towards an ectopic thyroid instead of metastatic thyroid carcinoma? So this is what the recall I've got. So the question basically says that out of the options which I'm going to read, which of these particular statements points towards an ectopic thyroid gland rather than a metastatic thyroid gland? Okay, so they're just trying to ask you the difference between them. Options are nothing related to the metastatic, but let's kind of read about that. The first option which I've got is thyroglobulin and thyroid peroxidase 1 positivity on the fine needle aspiration biopsy. Okay, so let's say if at all you do a FNAC and you get thyroglobulin. Okay, that's fine. First of all, okay, and TTP is thyroid kind of TTP1. Okay, so what does it mean? Okay, so now we have the kind of slides in front of us. The third slide. Okay, yeah. So this is the slide which you have got. Okay, now out of this, I don't agree with the fourth option. That is absolutely kind of bizarre. So the first option was thyroglobulin TTP1 positivity on the fine needle aspiration biopsy. So what you need to understand is that, first of all, thyroglobulin is something which is the protein. Okay, you usually do not get it on the FNAC or something like that. But if at all there is so what you need to understand is that thyroglobulin is a tumor marker for what? Differentiated thyroid malignancies. Papillary carcinoma of thyroid, follicular carcinoma of thyroid. So what we do is, it is not per se a distinguished tumor marker, but we use it as a surrogate tumor marker. How? For example, let's say if at all I have a papillary carcinoma of thyroid, which is a what you call as a differentiated thyroid malignancy. If I get the thyroidectomy done, okay, if I remove my thyroid gland, what should happen? After I have removed my thyroid gland, the thyroglobulin levels in my blood should drop down to nearly 0, because now the entire thyroid gland is out. But if at all, let's say the thyroglobulin levels are still persisting. In that particular scenario, what you need to understand, either there is a metastasis or there is some residual disease. I did not remove the entire thyroid gland. You understand my point? So first of all, it should not be under FNAC. I don't know, you guys have given the exam. I don't know the exact wordings of the option, but thyroglobulin positivity after doing a thyroidectomy may tell us about the residual disease or maybe a metastatic disease or something like that. Okay, and anti-thyroid like TTP1 positivity, that's all fine. Okay, now hyperemic midline mass at the base of the tongue in the females. Okay, so this basically tells us about the ectopic thyroid gland. Okay, so what happens is occasionally. So how does thyroid gland develops? It starts from the base of the tongue, like from the foramen cecum. The thyroglossal duct basically comes down. It comes down to the neck, and then the thyroid gland is kind of given out. And then the thyroglossal duct, it basically disintegrates. Okay. Now, if at all, let's say there is some problem in this embryogenesis and the thyroid gland basically develops at the base of the tongue only. So what you're going to have, you're going to have you're going to have a mass in the midline at the base of the tongue. So out of the 4 options, I would say that, you know what, this is something which is trying to tell us that, you know what, maybe there is a ectopic thyroid at the base of the tongue. Reading about the third thing, uncapsulated thyroid follicles on the histopathological examination, that again tells us about the thyroid malignancy. Okay, so follicular carcinoma of thyroid, they are usually uncapsulated. Okay, so they are usually uncapsulated. So papillary, to differentiated thyroid cancers, the follicles become uncapsulated. So papillary and the follicular, when you do an FNAC, if it was it's encapsulated, it basically is showing about the malignancy. It has nothing to do with the ectopic thyroid gland. I hope you understand what is an ectopic thyroid gland. That is, the thyroid is not present at the normal location. It is present at an ectopic location. Okay. Now, the first option which I've got is history of thyroidectomy in a patient with a midline swelling at the base of the tongue. Now, what you need to understand is that I don't think that this particular recall is like this particular option which they have kind of sent it to me is very, very accurate. You guys would be able to comment on this in a better manner. History of thyroidectomy, frankly, doesn't mean anything. Okay, for example, rest of the option is the same. That is an ectopic swelling at the base of the tongue. There's a possibility that some residual tissue might be left behind as well. So ectopic will be proven by both. Ectopic is basically what? That the thyroid tissue is basically at an abnormal position. It can be with the presence or absence of a thyroid tissue which is present at the normal location. Okay, most of the times there is a normal look thyroid, and at the same time there is an ectopic thyroid as well. Occasionally, the normal thyroid tissue is not present at all, and there is only tissue which is present inside the body is the ectopic tissue. Okay, that is one of the reasons why in the thyroglossal cyst, you do remember, like you do realize what is a thyroglossal cyst. Here, the thyroglossal duct, it fails to disintegrate, and there is a cystic development in this thyroglossal duct present nearly in the subhyoid level. Just below the hyoid bone, there is a most common location is the subhyoid. Okay, so whenever you are performing a thyroglossal cyst excision, it is good to at least look whether the normal thyroid is present or not, maybe on the ultrasound or maybe a radionuclide iodine scan, because if at all the normal thyroid tissue is not present, and if at all the tissue is basically present in the thyroglossal cyst only, once you remove it, the patients will be hypothyroid. So all these particular things are pointing towards that the ectopic thyroid tissue can be present either at the base of the tongue or in the thyroglossal cyst. So out of these, I would have marked B, but B and D are very much similar. I am proud that both of them were basically present in your exam or something like that. Okay. So yeah, these were the 3 simple questions which they had asked you. Xanthelasmas, which is basically deposition of the cholesterol in the kind of the cutaneous tissue, which is basically what you call as which occurs in hyperlipidemia. Then the second they had asked you was non-absorbable suture. We talked about that. Polyester is the answer. Rest all the 3 are the absorbable sutures. Now I've taught this at least 10 times to you guys. So what you need to understand, you definitely need to read the sutures in a very, very good manner. What are absorbable, what are non-absorbable, what are the advantages of monofilament, multifilament, and all those things. And finally, thyroid is an important topic you all know, but the question which I had asked you was slightly tricky. If at all I get accurate options, I'll be able to tell. But according to the options which I've got, I would have gone ahead with option B. Option B and D are more or less the same. I don't think so. They both were there in the options or something like that. Okay. So that's all from my end, guys. I mean, nothing major. Only 3 questions were asked in the general surgery. Yeah, that's it. Thank you. I guess I'm the last session, guys. I hope you have kind of given the exam in a proper manner. So now just sit back, relax, and like wait for the results. And yeah, enjoy life. Bye-bye. Thank you. Good night. See ya.